Am I audible?
Yes, sir, you are audible. Good morning, sir.
Good morning.
You are not visible, sir.
Yeah.
Thank you everyone for joining us day 3 of the 46th Indian Cooperative Oncology Network Conference. It gives me great pleasure to introduce our organizing secretary, Dr. Lalit Mohan Sharma, and I request sir to please give the opening comments for the day.
So, very good morning to my dear friends. On behalf of the organizing team of 46th ICON meeting, Professor Dr. Hemant Malhotra, sir, Dr. Purvish Parikh, sir, and the whole Mahatma Gandhi Medical College and University team, on behalf of them, I welcome you all on the third day of ICON meeting. And without wasting much time, we start with the academics. So may I request the first session directors to please take over. And may I invite Dr. Rekha Gupta. Dr. Rekha Gupta is a medical geneticist with Mahatma Gandhi Medical College Hospital. She is the only DM in genetics in Rajasthan currently. Along with her, Dr. Naresh Somani, who is senior consultant medical oncologist, and he is director of oncology services at HCG Hospital in Jaipur. So may I request the directors to please start the first session.
We'll request Dr. Rekha Gupta to call upon the chairpersons to start the proceeding. Ma'am is available?
Yes, first chairpersons are our Dr. Manish Gautam. He is a medical oncologist and working at Shanti and Sudha Multi-Speciality Hospital, Kota. So please, Dr. Manish Gautam. And then our second chairperson are Dr. Dinesh Yadav, who is assistant professor and Department of Surgical Oncology, Mahatma Gandhi Hospital, Jaipur. And our third chairperson are Dr. Sandeep D'Souza, who is professor and HOD of Medical Oncology, SMS Hospital, Jaipur. So welcome to all chairpersons.
Thank you very much. Thanks for nice.
Good morning.
Thank you, ma'am. And I now request Dr. Manish Gautam to please introduce our first speaker. Over to you, sir.
Hi, our first speaker is very well known Dr. Purvish Parikh sir, and he now aware us about the molecular tumor board, what, why, when in the real world. So without wasting time, we can start. He is the chief advisor of MOC, Precision and Medical Oncologist team, Asian Institute of Oncology.
Thank you very much. I thank the organizers for giving me this wonderful opportunity.
Sir, mic is yours.
Can you hear me?
Sir, yes, sir, we can hear you.
Yes,
great. So can you go to the next slide, please? Yeah. So if you look at the incidence of cancer, according to Times of India, in the next 2 years, it would have increased by 5-fold. And then if you look at this distorted map of the geography, it shows that the number of preventable deaths are highest in India and Africa. Next slide. So while this is happening, our quest is to constantly improve outcome. And this, all of you know that pediatric ALL, way back in 1962, it was a 10% 5-year survival. And next slide, please. And now it is more than 96%. But we are still trying to evolve in pediatric ALL because we are not satisfied with 96%. Next slide. But we must remember that what got us here won't get us there. In other words, if we continue to do what we are going to do just now, then we are not going to progress further. Next slide. So that is why we have to have molecular tumor boards. We all know the benefit of tumor boards, but instead of having a uniform gray group of patients, using the molecular tumor board, we can actually highlight and aggregate patients who are most likely to benefit from targeted therapy, which we are all aware of. Next slide. So tumor boards are the most systematic, reliable, and proven methods of a second opinion. Okay. This, I think, if the audience goes home with this particular sentence, then I would have made a big difference in today's outcome. Next slide. So why molecular tumor boards? And I put two photographs of Dr. Amit Verma and Dr. Sevanthi Limay because they have been regularly conducting molecular tumor boards, which I'm sure all of us have benefited from. So this is required because of the landscape of actionability is constantly changing and evolving regarding approved targeted therapies, updated to clinical guidelines, new clinical trials, mutations that contribute to cancer, both risk, development as well as progression, and then the various pharmacogenomic alterations that decides the response to a particular drug. Next slide. So the need for a tumor board which consists of specialists is because we have to survive in this vast ocean of overloaded data, significant ethnic variations, and therefore interpretation needs to be customized. This immense collection of variation whose significance is unknown is an ever-changing and evolving phenomenon, and VUS can become significant or not significant in a matter of few weeks. Next slide. So when we are deciding about molecular tumor board, we should also know that there is a large number of techniques available. NGS is not just one particular technique. It's an umbrella under which you have different techniques and different machines, as I have tried to show here. Next slide. And we should make sure that we understand all this. Otherwise, we will do what is seen on the right hand side. These kids went into the bank and instead of taking out the ATM machine, they came out with a machine that was printing passports. So this could be a very embarrassing thing for us if we are not careful about what is the implications of molecular oncology today. So we should have the right expectations, the right test, and the right results. Next slide. Just let me tell you one little example of the complexity of the situation. And this is data about BRCA1 and 2. I'm sure that we know the importance of BRCA1 and 2 in breast cancer and other cancers today. And this is a study published in 2018 about 29,700 families with BRCA1 and 2 mutations from 69 centers and 49 countries. Next slide. Now, if you look at a specific variation, this is the sort of information I got when I used this software. And there were 1,998 deleted variants that match your search. So click here to view the deleted data. And I'm sure none of us can remember this large number of data that is constantly changing. Next slide. This is the ethnic variations seen on BRCA exchange from breast cancer 1 and 2. So it's different for Hispanics, Asians, and African Americans, and obviously it is different from the Caucasians. So we cannot just simply take what is published in the West and use it for our patients because that would be a detriment to our patients. Next slide. And this is another evidence of how the distribution of the different mutations is totally different between Asians and Caucasians. If you simply focus on the EGFR mutations, it is 5 to 15% in Caucasians, whereas in Asians it is 40 to 55%. Next slide. And in fact, we have published way back in 2013 that even among the Asians, there is a significant difference in the incidence and the type of mutations seen in just one disease, that is EGFR mutations in non-small cell lung cancer. Next slide. This is how PLB2 germline mutation affects the risk of breast cancer in females. And you can clearly see that this increases with age. Why is this important? When a patient is being discussed in molecular tumor board, the risk of a particular mutation is not the same across the age. And therefore, interactions and the age is extremely important for discussion. Next slide. So tumor board consists of the participants that is mentioned on the left hand side. In addition to that, a molecular tumor board should have a molecular geneticist, genetic counselor, data scientist, and a biostatistician. And because all of these are not available at all centers, it is often required for us to take advantage of a virtual molecular tumor board. And there are many options available both in India as well as international. Next slide. So for a proper molecular tumor board, as usual, we should have a chairperson and secretary. We should decide the frequency of meetings. It could be in person, virtual, or hybrid. Most important is the case details that are necessary for such a tumor. The patient must have molecular testing done and the report available. Details should be circulated in advance to the participants. Oncologist to present the case at the tumor board, and patient may request his case to be discussed but cannot attend the tumor board. Finally, documentation of decision and recommendation is always required. Next slide. Just to give you an example of how the workflow occurs in a molecular tumor board, you can see two critical areas where the committee will decide whether the case should be part of the discussion of the tumor board or not. And this is primarily to ensure that we do not waste the valuable time of the specialist or part of the tumor board. If the patient or the case is not appropriate, or if the reports are inadequate or not reliable, then obviously such a case should not be discussed in the tumor board. Next slide. As you know, molecular tumor boards, molecular biomarkers are already incorporated in NCCL guidelines. This title of this page is Principles of Molecular and Biomarker Analysis. So this is just talking about principles, and it also already includes PD-L1 and circulating tumor DNA. So this is rapidly progressing. Next slide. This is publication in 2019, efficacy of molecularly targeted agents given in the randomized trial Shiva 01 according to the ESMO scale of clinical actionability of molecular targets. As we know, Shiva 01 was a non-significant outcome trial. However, that was not significant because we did not have enough targeted agents to attack those molecular characteristics. If that same data was evaluated today, the analysis would be entirely different and the outcome would benefit the patient. Next slide. This is another example. 715 unique patients discussed in a molecular tumor board between 2012 and 2018. There were 200 meetings and number of physicians who presented more than one case was 58. Next slide. And this is the outcome in the patients. The green line represents when the matching score was 50 to 100%. The red line represents the matching score of 0 to 49%. And matching score refers to what was discussed in the tumor board and the matching available in published literature. And you can clearly see that from this real world data, molecular tumor board decisions has a significant impact on the overall survival of patients. So this is sort of level 1 evidence. Next slide. So matching patients to drug was feasible after molecular tumor board discussion in 62% of patients. Compliance improved overall survival, that as I showed you in the graph, but it also improved progression-free survival, and both are statistically significant. Next slide. High matching score leads to better clinical outcomes. Again, confirming what I have already mentioned in a large number of patients, 429 cases. Next slide. This is the difference in the remission, partial remission, stable disease, and progressive disease when the matching was more than 50% on the left hand side, as opposed to the matching of less than 50% on the right hand side, and clearly showing that all the stable disease, partial response, and complete response are much better when the matching score exists. Next slide. Several publications or other also document benefit of molecular tumor board. This is one publication in Onco Targets, another publication in 2020 in Trends of Oncology. And in fact, this has also become part of the ESCO educational book, and therefore it is widely established and available. Next slide. Is there a downside to molecular tumor board? And this downside, I am saying, assuming that the test results are reliable and done from a quality laboratory. So there is no question about the test result, reliability and quality. So the downside represents that doctors have to find time in their busy schedule Hospitals have to allocate resources in terms of time, space, and data. Patients could have a downside because of anxiety before and after the molecular tumor board, delay in initiating therapy, guilt about not being able to procure the recommended treatment based on the mutation analysis, and the need for additional follow-up and tests which could cost money. For every month, there is a downside in terms that it is a dynamic science with new information becoming available almost every day. And it is often challenging to apply meaningfully to today's patient in the real time. And therefore, I have always been saying that when you ask for a molecular test, please ask for the raw data also, so that you can use that raw data, FASTQ files or FASTX files, to yourself engage a publicly available database, maybe 3 years down the line, 6 years, 6 months down the line, to find out whether a VUS is now having a particular impact on the outcome of the patient. Next slide. So there is another trend of thought is that for now sequencing cancer tumor molds holds more promise than proof, and that is a viewpoint that some of us might also have. Next slide. So in summary, molecular tumor boards help navigate and understand complex NGS reports. They help translate molecular alterations into genuine clinical indications. Video conferencing allows access to global expertise, and there's a more extensive personalized oncology management. Next slide. Goal is to determine and recommend the best possible cancer treatment plan for an individual patient. This is not binding on the treating oncologist of the patient. Making a recommendation does not lead to any medical legal liability to the members of the tumor. Next slide. With this, I thank you very much for a patient hearing and wish the conference on the 4th day continued success, because this has really made a dent in the knowledge that we all have. Thank you very much. Back to the organizer.
Thank you so much, sir. I now request our chairperson, Dr. Dinesh Yadav, to please introduce our next speaker.
Good morning. Our next speaker is Dr. Lalit Sharma. He is consultant medical oncologist at Manipal Hospital, Jaipur. He will have talk on biomarkers to identify long-term responders to immune checkpoint inhibitors. To Dr. Lalit.
Thank you so much, sir. So at the outset, I would like to thank the organizers for giving me this opportunity to be part of this wonderful feast of knowledge. We have had a wonderful first 2 days and looking forward to a blockbuster 3rd day. So the job cut out for me is to evaluate the biomarkers which identify the long-term responders to immune checkpoint inhibitors. Immune checkpoint inhibitors basically came to a rescue when we were kind of plateauing in a fight with malignancies, with the cytotoxic drugs, and we were gradually evolving to identify the underlying molecular biomarkers and targeting them for increasing our responses to these dreaded disorders. So the immune checkpoint, immune surveillance is being evaded by the tumor cells and progress through different mechanisms, include activation of the immune checkpoint pathways that suppress the anti-tumor immune responses. And the immune checkpoint inhibitors come to a rescue by interrupting the co-inhibitory signaling pathways, and they promote the immune-mediated elimination of the tumor cells. Basically, the effector T cells, which are not able to address these tumor cells, are being unable to carry out their cytotoxic activity by inhibiting this particular pathway by these checkpoint inhibitors. So, but when we started evaluating these various molecules to our disposal, we found that they behaved really differently in various disorders. There was a decent response in melanoma and non-small cell carcinoma, a tepid response in the urothelial and TNBC, But on the other hand, a wonderful response in the relapsed and refractory Hodgkin lymphomas, wherein we found even complete responses to the tunes of 17 to 20% in various studies. So gradually we came to know that only a fraction of the patients benefit from the checkpoint inhibitors, and it is not just the benefit, that many of these are going to have severe immune related adverse events also. Now, because basically we are fiddling with the immunity, so the inhibition of the immunity is going to reinforce the normal physiological barriers against the autoimmunity. And therefore, the development of the predictive biomarkers is critical for differentiating responders and responders and to avoid unnecessary adverse effects in these non-responders. So when we start to kind of look at the factors which are going to come into play, it all boils down to the tumor microenvironment and the immune cells which are playing in various permutations and combinations. The tumor microenvironment can very well be divided into three various categories, namely immune desert, immune excluded, and immune inflamed, wherein on one extreme, the immune desert, there is absence of the T cells in the microenvironment and lack of suitable T cell priming or activation. Whereas on the other end of the spectrum, we have immune inflamed tumor microenvironments, whereas there is infiltration of the multiple immune cell subtypes. So it all boils down to that the response of the immune checkpoint inhibitors varies depending on the tumor microenvironment. In the responders, we would find high neoantigen loads, higher levels of tumor infiltrating lymphocytes, especially the effector T cells. So the effector T cell and the T regulatory ratio has to be on the higher side. There should be low myeloid-derived suppressor cell levels and increased secretions of the interferon gamma and other cytokines. So basically, an inflamed microenvironment corresponds with increased inflamed cells, and probably the response to immune checkpoint inhibitors would also be more. Whereas in the non-responders, the tumor microenvironment will have more of the immunosuppressive cells. That is, the T regulatories and the myeloid-derived suppressor cells would be more lower levels of cytokines, NK cells, and activated lymphocytes would be there. So we would be examining these all factors individually. Namely the immune cells, the PD-L1 overexpression, the role of neoantigens, genetic and epigenetic signatures in determining the response to the immune checkpoint inhibitors. So T cell infiltration in various malignancies can be used as a potent predictive biomarker. Now, basically, increased tumor infiltrations with lymphocytes is a major hallmark of the immune inflamed phenotype. And when we studied the response of pembrolizumab in melanoma, we found that tumors which had more of pre-existing CD8 positive T cells had better tumor regression. And on serious sampling, what we saw was there was an increase in the CD8 positive T cells initially at the invasive margin, and then gradually they infiltrated into the parenchyma. Now, this told us that either it was infiltration of the immune cells or an enhanced proliferation of the CD8 positive T cells because of the inhibition of the PD-1, PD-L1 pathway. Similarly, in Keynote 086, we studied correlation between stromal TIL and response to atezolizumab, and there was a significantly higher level of stromal TIL and response to PD-1, that is atezolizumab, in the triple negative breast cancers also. Similarly, with ipilimumab in melanoma, we found that there was a positive correlation. So other than this histological finding of tumor infiltration of lymphocytes, there is also a simpler variant of checking the immune cell activity in the form of absolute lymphocyte count. So studies have shown that patients with a higher ALC value from baseline in the first 2 weeks of treatment had significantly higher overall survival also. There were other parameters which were studied in the peripheral blood other than absolute lymphocyte count, which had a positive correlation with the responses. And this was a low LDH level, low absolute monocyte count, low myeloid-derived suppressor cell counts, or a high absolute eosinophil count. A relative lymphocyte count of less than 10.5% was also uh, positive predictive marker. But then when other studies also studied LDH, we came to know that there were many studies which showed that even patients with an elevated LDH also responded to immune checkpoint inhibitors. And this led us to conclude that LDH can be used as a potential predictive biomarker for overall survival, but not as a prognostic biomarker. So coming next to the PD-L1 overexpression, we have been kind of using it to decide whether to use immune checkpoint inhibitors upfront now for long in many of the oncological disorders, and the PD-L1 overexpression supports tumor escape from the active T cell responses. Now, once we block this particular inhibitory pathway, they can activate the T cells in the tumor microenvironment, and the release of the inflammatory cytokines and cytotoxic granules leads to elimination of the tumor cells. We usually kind of see the level of expression of PD-L1 with the help of IHC, and patients can be divided into immune PD-L1 negative, positive, or high expressors. But the standardization of these processes has been a huge challenge, because various platforms are being used, various criteria for positivity and higher expression are being used, and uniformity is lacking. But one thing which we have been able to see uniformly is that patients with PD-L1 overexpression definitely fared better across almost all trials, across almost all molecules, as compared to patients who were PD-L1 negative. But the other issue is PD-L1 overexpression may not be a robust biomarker, because many PD-L1 negative tumors can also respond to monoclonal antibodies. And therefore, PD-L1 overexpression as a prerequisite for initiation of PD-L1 checkpoint blockade is not very well established. And we need to probably look at various combinations of the factors, not because we do not have any perfect single biomarker. So this particular issue was addressed by Sengar et al. To try and develop a combination biomarker wherein they classified tumors in the categories depending on the permutations and combinations of tumor infiltrating lymphocytes and the PD-L1 expression. So the type 1 which they classified, which had higher or overexpression of PD-L1, along with higher tumor infiltration with lymphocytes, they proposed that probably this is the best class which would probably give us best possible results with immune checkpoint inhibitions. So coming next to neoantigens, acquired mutations during the cancer progression have promise in detecting efficiency and also resistance to the therapies. Now, mutations in the protein coding regions of the DNA generate truncated proteins, and these are known as neoantigens. Now, neoantigens result in a higher degree of foreignness to the cells and help the immune cells readily target and eliminate these tumor cells. Now, various neoantigens that confer therapy efficacy could be potential biomarkers for predicting the clinical activity of immune checkpoint inhibitors. Now, the various neoantigens which have been studied are that one of them was studied in the lung cancer samples, and overexpression of interferon gamma was reported to be a predictor for ipilimumab response. Similarly, resistance to CTLA-4 therapy was observed in patients who lost the interferon gamma signaling in the CD8 positive T cells. Now, neoantigens which have a higher affinity to bind with the immunohistocompatibility complex or T cell receptors are also highly eliminated neoantigens, and they might predict response to immune checkpoint inhibitors also. So acquired resistance to immune checkpoint inhibitors can also be predicted to neoantigen landscapes, and there are now studies wherein we are profiling the tumors before and after exposure to immune checkpoint inhibitors and try to determine which particular landscapes are going to predict clinical activity and also therapeutic resistance also. Then coming to genetic signatures, there could be particular genes which, if overexpressed, might kind of lead us or give us a clue towards more better responses to immune checkpoint inhibitors. Like there was a retrospective study in the breast cancer patients wherein these 5 genes were associated with a better relapse-free survival. Similarly, immune-related gene, if they are overexpressed and basically there is a pre-existing immune reactive or microenvironment, they might predict better responses to immune checkpoint inhibitors. Now, the other genetic signature is PDL1 and 2 copy number alterations. And if the copy number alteration is higher, it is a potential biomarker. This also correlates with mutation burden also. So a higher mutational burden is also predictive of the responsiveness to the immune checkpoint inhibitors. Moreover, if the mutation leads to an expansion of the pre-existing T cells, like one occurs in the lymphomas, that is, if an activating mutation occurs in the JAK3 gene, then definitely this leads to an overexpression of PDL1, and this leads to responsiveness of PDL1 inhibitors. Another genetic signature is mismatch repair. Now, the mismatch repair mechanism machinery is the machinery that protects the cell by repairing mutation during DNA replications. But if this particular mismatch repair is deficient, this is a positive predictive marker for response to immuno-oncology drugs. Now, epigenetic modifications are complex cellular processes that can modify cellular function in response to the prevailing environment without any alteration in the genetic codes. And these are also associated with epigenetic responses to immune checkpoint inhibitors, but there are no validated data at this point in time to identify individual epigenetic signatures, and more studies are required to study these biomarkers. One of the examples here is microRNA levels, and these were found to be associated with better clinical responses, out of which 4 microRNA are positively associated with progression-free survival. Similarly, microRNA 34A has been reported as an inducer of CD8 positive tumor infiltrating lymphocytes and expression of the PDL1 in the non-small cell carcinoma patients. Now, to conclude, immunological response to immune checkpoint inhibitors is a very complex process, and the biomarkers that predict the efficacy of immune checkpoint therapy or its immune-related adverse events should help in patient selection and decision making by distinguishing them from responders and non-responders. Now, the major issue is the development of predictive biomarkers is that the dynamic variation in the cancer biomarker types and the patient's genetic makeup. So, usually what we see is in an ideal patient, if we could evaluate all the biomarkers, the one who would be responsive is the one who has a very high neoantigen load, high levels of tumor infiltrating lymphocytes, especially the effector cells. And if a higher T effector to T regulatory ratio is there, and a low level of myeloid derived suppressor cell levels is there, and an inflamed environment with a presence of higher cytokines such as interferon gamma. Whereas the non-responders would be the one with high levels of immunosuppressive cells and such as T regulatory cells and a low level of NK cells and activated lymphocytes. Thank you for a patient hearing. Thank you.
Thank you so much, sir. I now request Naresh sir to please introduce our expert. Naresh sir, you'll have to unmute your mic, sir.
Thanks, Mr. Kalsis. It's a pleasant duty to introduce our good friend, Dr. Prashant Kumbhaj, who is presently Associate Professor, Medical Oncology Department at the Mahatma Gandhi Medical College, Jaipur. So he will be giving the expert comment and will be dealing with the question and answers if there are any. Dr. Prashant Kumbhaj, please.
Good morning, sir. So, very well discussed topic on the molecular tumor board by Dr. Purvish Parikh, sir. And definitely there is the need to form a molecular tumor board where we can discuss about complex molecular genetic mutations and where we don't have any other options. So definitely it is the need of the hour, and the sir has shown the importance by showing the increase in the overall survival as well as progression-free survival if we take decisions according to the molecular tumor board. And also the VUS, which are updated daily and weekly basis. If we are updated with VUS, so definitely if VUS comes into some targetable mutations, then definitely patient has an option, and we have an option to offer something to the patient. And I also thank to Dr. Lalit Sharma for very well presentation of predictive biomarkers for immunotherapy. Because the immunotherapy is costly as well as the toxicities is high if we use immunotherapy in patient who doesn't respond on who doesn't have any marker that is positive for responsiveness. So definitely these biomarkers are the need of the hour, like Lalit sir has said, that tumor mutational burden as well as PD-L1 overexpression, tumor infiltrating lymphocytes, neoantigens, as well as epigenetic signatures with microRNA level genetic signatures, as well as absolute lymphocyte count. So based on the two markers, we have recommendations to use pembrolizumab, like Keynote 158 trial with tumor mutational burden, as well as PD-L1 overexpression. In tumors, we can use pembrolizumab as a last option who don't have any other
Dr. Prashant, may I request you to please take the questions from the chat box as well?
Yes, sir.
So the question is on your screen, so you can just read that.
Yeah, so Dr. Somani and my other chairperson and the experts can answer, please.
So molecular reports, definitely the decisions are based on the molecular reports, and definitely the molecular labs that are CAP accredited molecular labs. I think these are the standard labs, and these reports that is CAP accredited or internationally recognized lab that the reports of these labs can be reliable for use of various targeted therapy as well as for immunotherapy.
Dr. Rekha is here. Dr. Rekha, any inputs on the reliability of various labs in your experience?
So actually, along with this various type of accreditation, it is data with the lab and how many experience, how many years of experience they have with a particular area, like in oncology, how much they have worked, and what is their data set for that. And this basically, for that, we rely on those labs.
So can I make a comment?
Yes, yes,
so,
please.
so as far as this reliability is concerned, we all know that lot many labs are now mushrooming. Already maybe that at least 50 labs are there in India based on the NGS. And they try to make various packages like so many tests, 20, 30, this with combi this, with the free ship of this particular test, along with the package and so on. So that always raises the eyebrow that how reliable they are. Are they covering everything? So my point is that if we are really going for the NGS, beyond the established predictive markers, like let's say very simple example of the EGFR, ELK, ROS1, BRAF, MET in the lung cancer. If we are really going beyond that in the lung cancer, we should have the broadest possible panel for the individual tumor, rather than sticking ourselves to some sort of the package.
Thank you. Thank you so much. Kashish, over to you, please.
Thank you so much, sir. We'll move on to our next session, which is on hematological malignancies. And I invite the session directors. It gives me great pleasure to introduce our session directors, Dr. Surendra Beniwal, Professor, Department of Medical Oncology at Acharya Tulsi Regional Cancer Treatment and Research Institute, Bikaner, and Dr. Hemant Malhotra, who is in fact also our Program Director, Director of Oncology Services at Shri Ram Cancer and Super Speciality Center, and also the Professor and Head, Department of Medical Oncology at Mahatma Gandhi Medical College and Hospital, Jaipur. Over to our session directors to introduce our chairperson.
Dr. Priyanka Soni as well, please.
Thank you very much, Kashish and Dr. Lalit. I'll just say one quick word of introduction to this session. First, I'd like to, with the permission of my co-directors, introduce Dr. Varsha Gandhi to you. Varsha has been a good friend to me for more than 3 decades. And, she is going to present her next talk in person. It is 12 o'clock midnight at Houston, where Dr. Varsha is. She'll be introduced to you presently. We requested her to record her talk because, it's like cruelty to animals to ask somebody to present at 12 at midnight. But she said, no, I want to make. Can you keep quiet, please? I'm sorry, pardon me for that. So I really want to thank Varsha for her commitment, and she's going to be speaking on a very, very important topic, which you will get to know in the next few minutes. With that, I hand over to Dr. Beniwal and Dr. Priyanka to introduce our chairpersons. Thank you very much.
Thank you, Malhotra sir. I will like to introduce our chairperson, Dr. H.S. Advani sir. There is no need to introduce Advani sir. He is the legend of oncologist in our India. And second chairperson is our great teacher, Dr. Pankaj Saha sir. He is ex-director of GCRI, and Dr. Ravi Kumar Saxena ji, consultant medical oncologist at Global Hospital, Hyderabad. All of us are legend of our medical oncology of India. And now I will hand over to chairperson for starting this session.
Thank you so much, sir. I now request Dr. Pankaj Shah to please introduce our speaker. Over to you, sir. Sir, have you unmuted your mic?
Has Dr. Pankaj Shah connected? Is he online?
Sir, you'll have to unmute your mic, sir. So till that time, may I request Ravi Kumar sir to please introduce our speaker? So it like Hemant sir says, we're really thankful to us keynote speaker, Dr. Varsha Gandhi, for accepting our lecture.
I think Dr. Pankaj Shah is on board now.
Sir, can you hear us?
I can hear you, but there is some problem in the connection. It is interrupted.
Sir, we are able to listen to you, sir. Please go ahead, sir.
Okay, that's good. That's good. So first of all, let me congratulate the Jaipur team and ICON to have this 46th Indian Cooperative Oncology Conference, and we are waiting for the Golden Jubilee Conference. And on the behalf of the organizer, it is a great pleasure for me in inviting Dr. Varsha Gandhi, who is a part of our Indian community. Most of the conference, Varsha is there, and I request her to.
Over to you, ma'am. You just.
May I request Dr. Varsha Gandhi to present her presentation? Okay.
Yes. Can you hear me?
Yes, ma'am. We can hear you.
Yes.
Perfect. And can you see my slide? I have shared the screen.
Yes, sir. Yes, ma'am. We can see the screen.
All right. Perfect. So thanks a lot, first of all, inviting me to present here. It's really, this topic is very near and dear to me, and that's why I decided that I would like to present it in person. So, and if you did go to the ASCO, this was presented at the ASCO educational session, and you may have seen some of the slides that I will be presenting today, or tonight, I should say. So in Houston, it is little past midnight, Saturday night or Sunday early morning. It's 3 degrees centigrade outside and it's raining. So from all aspects, it's not looking that great here. But this, as I said, this topic is really great to me. So the topic is controversy in dose of BTK inhibitors in CLL, and what I will be talking mostly is the irreversible BTK inhibitors, and I'll talk about those before I go into the main topic. So CLL, most of you are aware of, is specifically in the Western world, it is the most common leukemia. It's a B-cell disease. It resides in 3 different components: lymph nodes, bone marrow, and peripheral blood. Chemoimmunotherapy used to be standard of care, but now that has changed, and it has changed because of the targeted therapeutics available to us. And those are either they are targeting BCR, B-cell receptor pathway, or BCL2 family proteins, and the 2 drugs that have become the standard of care are ibrutinib and venetoclax. And either they are used in combination or venetoclax is used with obinutuzumab and anti-CD20 antibody. So what is B-cell receptor pathway, which is shown in here, and after the ligation of the antigen to the B-cell receptor, there is a plethora of events and signal transduction that happens, which I cannot go into detail, except to say that there are many transcription factors that get activated, and they are then responsible for survival, cell death, proliferation, and migration of the CLL cells. In the apex of this pathway is the enzyme Bruton's tyrosine kinase, or BTK. And this is the enzymes that inhibited by ibrutinib. Ibrutinib was pharmacyclics drug, and that's why it has this numbering, PCI 32765. It binds covalently at the cysteine 481 residue in the kinase domain. So this binding is covalent binding. That means it is irreversible inhibitor. So once the drug binds to the kinase, kinase is dead, drug is dead. And that's important regarding what I'm going to talk about. It is a very potent inhibitor, but it does affect other cysteine containing or non-cysteine containing kinases, and that may be responsible for off-target effect. It's an oral agent, which is given at the 420 milligram per day. It's very well tolerated. However, there are bleeding issues or atrial fibrillation issues, but overall it's very efficacious. So efficacious that ibrutinib was one of the drugs that has revolutionized how we treat B-cell malignancies. This is one of the unique and drug that received all 4 positive attributes from the Food and Drug Administration in the United States. It was approved for mantle cell lymphoma, for chronic lymphocytic leukemia, Waldenstrom's macroglobulinemia, and graft-versus-host disease. Specifically in CLL, it is approved for all types of CLL, whether it's a relapsed refractory disease, elderly patients, patients who have 17p deletion where TP53 gene is located, or previously untreated patients. And all these work was generally done either at MD Anderson in collaboration with Ohio State University or Ohio State University in collaboration with MD Anderson. So this is really a phenomenal and fantastic drug for B-cell malignancies. As I mentioned, ibrutinib inhibits BTK and B-cell receptor pathway. And I mentioned that the dose is 420 milligrams. So how was that dose selected? For a drug like this, which binds covalently to its target, then you can use target occupancy assay, which is a biochemical assay, to determine the dose. And what the pharmaceutical and the scientists and clinicians wanted was that drug should bind to more than 95% of the target. And that was determined in a phase 1 study that came from Ranjana Advani's group, and the last author is Nathan Fowler at MD Anderson. What they did was they used many different doses because it was a phase 1 study, and those doses were milligram per kilogram, but I have changed that to milligram per day. So you can see that at the first dose, which is 88 milligram per day, the target occupancy is very heterogeneous, and it is not anywhere close to 90% or more inhibition. But as you go from 175 milligram per day, you can see that almost in all cases, there is a maximum BTK occupancy. The dose which was selected was actually in between here, 350 and 580, which is the 420 milligram per day. So it's clear here that even the lower dose may have done the job of inhibiting or having the full BTK occupancy. What we started to think about is that how is this going to work when the drug is binding covalently to the target? And that stoichiometry should be 1-to-1 because you need 1 molecule of BTK and 1 molecule of the drug, which is ibrutinib. So here is the model for that. These are CLL cells with loss of BTK molecules. When you give ibrutinib, which are these yellow squares, it will bind to BTK, and once it binds to BTK, then it is going to kill the enzyme and the drug is killed also. So if you have at the very start with these standard dose of ibrutinib, more than 95% binding, that means you have killed 95% of the enzyme that's available there. And there is some free drug still available. However, when you start with the next dose, then you do not have any BTK available to bind. So the question would be that the only time you will need more drug is if there is more synthesis of BTK, because whatever BTK is there, it's already killed. So how is BTK synthesized? And that is shown in here. it also uses the B cell receptor pathway. So this is now a linear fashion. I'm showing you BCR to BTK, PLC, gamma, PKC, going into NF-kappa B, which is a transcription factor that is responsible for many gene transcription, including BTK. So if we inhibit BTK with ibrutinib, that means we are going to inhibit this transcription of BTK. And that means there should not be any more synthesis of BTK, or transcript levels of BTK should go down when we treat patients with ibrutinib. Does that happen? Here is the RNA sequencing data, RNA-seq data from my lab in 32 patients who got 1 cycle of ibrutinib. In all cases, you can see that there is a decrease in BTK mRNA or transcript level. Not only mRNA level, but the protein levels also go down when we treat patients, CLL patients with ibrutinib. So BTK level is going down. All of the BTK is occupied by ibrutinib. So question is, why do we need to give more ibrutinib to patients after we have given 1 cycle of ibrutinib? So with that, we started to have an hypothesis that after 1 full dose or standard dose of ibrutinib, we may be able to lower the dose of ibrutinib. To test that hypothesis in collaboration with my clinical colleagues, Prithvi Bose and Michael Keating at MD Anderson, I designed a protocol which is shown in here. So in the first cycle, which is a 4-week cycle, 28-day cycle, we gave the prescribed dose of ibrutinib, which is the 420 milligram per day, 3 capsules per day. On the second cycle, we had 2 capsules per day, and then a third month or third cycle is only 1 capsule per day, 140 milligram. And this was a pilot study just to test our hypothesis that can we really lower the dose after 1 full cycle of standard dose of ibrutinib. So it's like a preemptive dose reduction. At these 3 doses, first cycle, second cycle, and third cycle, that is 3 capsules, 2 capsules, and 1 capsule, there was a dose-dependent plasma levels as well as the cellular levels of ibrutinib were also dose-dependent. So in the cycle 3, it was a much lower dose of much lower plasma and cellular concentration of ibrutinib. So question is, can at that level, it can occupy the BTK at the level that we want, which is more than 95%. So here is the Btk occupancy data in 1 patient with 3 capsules per day, cycle 1 at many different time points, day 1 or day 8 or day 28 and different hours. You can see that it is complete occupancy of the BTK. The ordinate here is 65 to 100%. So we are very stringent in reporting this. In cycle 2, the same patient got 2 capsules per day and it was still fully occupied. 1 capsule per day, it was still fully occupied. So this is the data in 1 patient, but the same data, similar data were there for 7 patients where we did the study of with those 16 patient samples, blood samples. Now the ordinate here is 90 to 100%. So we are looking for 95% occupancy, which you can see that it's available irrespective of the dose, cycle 1, cycle 2, or cycle 3 on day 1 or on day 28, it is same story. So what this data is suggesting that after 1 cycle of prescribed dose of ibrutinib, we can lower the dose. And that basically is the summary here, that in this 3-to-1 ibrutinib pilot study, what we learned from 9 patients is that we can lower the dose after 1 cycle of the prescribed or standard dose It resulted in more than 95% Btk occupancy during all 3 cycles. I didn't show you the data, but biomarkers or immunoblot data with the phospho-BTK, PLC gamma, or chemokine levels, they were equally inhibited at all 3 dose levels. NF-kappa B, which is another biomarker that was also inhibited in all 3 doses. So platelet function, which is resulting to bleeding, that was reduced, the adverse event was reduced at the lower dose. So this is all, everything that I showed you is the biochemical, biological data or pharmacodynamic, pharmacokinetic data. What about clinical results? And we didn't do that because we were just testing our hypothesis. But at the time we were doing, there were 5, or actually now there are 8, 9 different countries. They have data in the real world with the ibrutinib single agent. So you can see here, there are 5 countries that I listed here. They had patients with either treatment naive or relapsed refractory, those disease patients, and they are 70 to 300 patient data. And in those patients, 20 to 40% of patients had to have a reduction in the dose. So how does the data look? When you look at it for the US data, about 200 patients, 160 patients, the blue dotted line with the standard dose, and then the reduced dose is the red line. Progression-free survival, overall survival, identical. We don't even need statisticians to tell us that this is not superimposable. This was the same thing with the UK 300 patient data. And the red and black are the standard and the reduced dose ibrutinib. Again, overall survival, progression-free survival are identical. However, if you do have a break interruption in ibrutinib, and if that is more than 2 weeks, then the efficacy is really decreasing dramatically. So interruptions are not great. However, you can lower the dose after at least 1 cycle of the standard dose. So with that, I can conclude that 420 milligram per day is great for the first cycle, but after that, it appears to be an excessive dose for patients. If we look at the scientific clinical data, the real world data, toxicity data, then it is clearly indicating that preemptive lower dose of ibrutinib after standard dose should be the strategy for ibrutinib use. We should not interrupt the dose because that results into synthesis of BTK, which will have the adverse event for the adverse effect for the patient's disease. Off-target effect as well as the toxicity due to cost of ibrutinib, we can lower if we go with that, that preemptive lowering the dose. So overall, the reason for me to sit here and present this is that I would want someone in India, because that's where we can do something like this, and it will help our patients in India with the lower dose, with less toxicity as well as financial burden, to do a randomized prospective trial of a standard dose versus 1 standard dose cycle followed by the lower dose of ibrutinib. These are the team members. Most importantly, Lisa, who is assistant professor in my group, who did all this work. And I mentioned already Michael Keating and Prithvi Bose, my clinical colleagues. This was all funded with MD Anderson's Moonshot program, and I want to thank patients who gave 16 blood samples so that we can do all those studies. Thank you very much. Thank you for inviting me and for asking me to present this data.
Thank you so much, ma'am. We have some questions. Can I request Naresh sir to please unmute your mic and ask your question? Naresh, are you there? Hemant, sir, can I request you to ask your question? You put it on the chat box. Yeah.
So thank you very much, Dr. Varsha.
I can.
Hi, Varsha, can you hear me?
Yes.
So many thanks for your wonderful talk. I've heard a little bit of gist of this earlier at the last hematology conference which we did at Jaipur. So my question is that why has such a trial not been done in the US or at MD Anderson?
Yeah, that's a very good question. So one thing is that in US, literally no one is now using ibrutinib as single agent. So that is the main challenge, because it's not being used as a single agent. Then it's very difficult to do a randomized study with single agent ibrutinib. If we do lower dose ibrutinib in combination with, let's say, venetoclax or so, then we know that it would be very difficult to determine the efficacy or progression-free survival, overall survival, and with the lower dose ibrutinib venetoclax versus standard dose ibrutinib venetoclax. So that's the main issue. I know that in the other countries, ibrutinib still will be used as a single agent. And I should have mentioned that it's not just ibrutinib. We have similar data with acalabrutinib also. So it appears to be similar for all irreversible BTK inhibitors.
So my next question, if I'm maybe permitted to ask one more, Varsha, is there any evidence of genetic difference in the metabolism of ibrutinib? Genetic difference meaning between Asians and Caucasians? And my reason for asking this is, will we have to do the basic studies again in India to, kind of formulate a trial? I think this is an extremely interesting concept, and it's very, very vital for a developing country like ours that we not only reduce toxicity, but also reduce cost of treatment. Even though we have generic ibrutinib available in our country, it's still important, and it's a big difference on the patient's pocket and also on the payer's pocket. Even if the patient is a CGHS beneficiary or an insurance beneficiary, if you have 1/3 the expense, and these are drugs which go on and on, so it is important to do cost-effective treatment. So back to my question, any evidence of genetic difference in the metabolism of ibrutinib in Asians or Caucasians?
Yes, so when pharmaceuticals provided all the data to FDA initially, actually it was FDA's recommendation also that they ask pharmaceuticals to do a randomized trial with the lower dose, because they, based on all the data that were available to FDA, it was very clear that this dose was much higher than what is needed. And they looked at all the plasma pharmacology data. I would think that we had very limited Asian patients in that study, but among the Hispanics, among the African Americans, and the white, there wasn't any difference regarding plasma pharmacology. So I would hypothesize that probably it won't be different in the Asians also.
Thank you very much. Thank you, Varsha. Thank you again for your time and effort. Thank you.
Thank you.
Thank you so much, ma'am. I now request our session director, Dr. Priyanka Soni, Assistant Professor, Hematology, Pediatric Oncology and BMT, Mahatma Gandhi Medical College and Hospital, Jaipur, to please introduce our next speaker.
Good afternoon, everyone. It is a pleasure to introduce Dr. Naveen Gupta, who is Associate Professor at Department of Clinical Hematology and BMT at Mahatma Gandhi Medical College and Hospital. So he would be speaking on CML CP and suboptimal response with third line TKIs.
Good afternoon to all the distinguished oncologists present, gathered over here, both nationally and internationally. And many thanks to the chairperson and to the organizing team for giving me this opportunity. I shall be presenting my talk on CML, the treatment implications for patients who are resistant to 3 or more lines of treatment.
So will you be sharing your screen, sir?
I hope it is visible now.
Yes, sir, it's visible, sir.
Okay, so it's an ode, it's a tribute to the efficacy of the TKIs in CML that today we are sitting and discussing what to do with patients who are resistant to 3 or more TKIs. So the fact that this question has arisen means we have really efficacious treatment in first line, second line, even up to third lines. So I'll be discussing what are the options that are in front of us when we are faced with this situation. What are the treatment goals? What are the options available to us currently? And any new advancements in the pipeline which may help us in the future. So if a patient has suboptimal response to 3 TKIs, we can assume that the patient might have received at least imatinib with 2 or more second generation TKIs. It is a big unmet need if the patient becomes resistant to 3 TKIs because, first of all, there is no exact definition for how to grade responses when we are giving a third line treatment. So for the first line and second line treatment, these targets for BCR-ABL monitoring are pretty well defined. But that is not the case when we are using it as third line. So when to call a patient a failure on the third line itself becomes a big question. Responses in third line are themselves very poor, and many patients end up being transformed from a chronic phase to an accelerated or a blast crisis. Since I will be restricting my talk today to CML in chronic phase, we end up having very few patients who are actually in chronic phase once they have failed 3 or more TKIs, and a lot of patients have transformed. So the treatment implications and the treatment lines completely differ. There is scant data on these responses or beyond third line therapy precisely because of the reasons I've mentioned before. We don't know how to exactly define a failure. And since we get marvelous responses with first and second lines, the number of patients that end up in this state are not that great. But as we are using more and more first generation, second generation TKIs, the duration of follow-up is increasing with our patients. Then increasing number of patients are coming up who have such issues. A patient who is resistant to 3 TKIs would have a poor disease biology. So any treatment modality that we undertake right now that may not have very dramatic or very marvelous results as we have obtained in the initial lines. So if we have reached a stage where 3 TKIs are not working, what are the goals of treatment? The goals pretty much remain the same as we would have in the first line or second line. We would want the patient not to go into an accelerated or a blast phase. We would want to prolong the life expectancy, improve the quality of life, and avoid long-term adverse events related to the drug. EFR is absolutely not a goal, as we would all rightly assume. Once a patient has resistance to 3 TKIs, that is completely out of the question. Then comes the question of how to monitor. If we have started a patient on a 4th line treatment, what would be the definition of an adequate response? So a lot of data sets, which are older data sets, have used cytogenetic responses as the endpoint. So either a complete or a partial cytogenetic response. MMR is definitely like the holy grail in CML. If we achieve an MMR, no matter what line of treatment we are in, the probability of survival dramatically goes up. So very few patients might achieve MMR, but those who would eventually do far, far better than the others. BCR-ABL, our target of less than 1% has been used in certain trials which have been using drugs for third and subsequent lines of treatment. So that also becomes an important marker, but there is no clear way to define which patient would be called a responder and which patient would be called a failure. What is sure is if there is an improvement from the baseline, then the prognosis of the patient improves. So if we have a decrease in the disease burden by either cytogenetics or molecular methods, then that would be a favorable thing for us. Moving on to the treatment options, once we have failed 3 TKIs, we can go for another TKI. That is an option in today's world. We have novel agents coming up. We can go back to the future and back to the older agents, which we had been using in the pre-TKI era. And another treatment that was being used extensively in the pre-TKI era and was sort of fallen out of favor is allogenic stem cell transplant. And this would represent an opportunity where these treatments can become much more important than going for a further novel or a TKI-based treatment. So I shall be discussing these one by one. So use of a fourth TKI, once a patient has failed TKI, it may feel like we are pushing against a wall which is refusing to budge. But still, there is data to support that bosutinib and ponatinib may have certain benefits in such a scenario. With bosutinib, there is certain retrospective as well as prospective data on this. A data set of 62 patients on fourth-line bosutinib after either resistance or intolerance to imatinib, dasatinib, and nilotinib, in which 38% had KT mutations, but not those with bosutinib resistance were not included. So those patients who were already in a complete cytogenetic response, a lot of them converted to a major molecular response. That was 41%. But those without a complete cytogenetic response, the 24% could be converted to an MMR. But still, we can see that there are patients who can attain an MMR even when we are operating in the fourth line of treatment. This also tells us one important thing about all treatments in the fourth line, that if a patient has had a significant response previously, but not a complete response, then that can be augmented by our fourth line treatments. But if a patient who is there is completely refractory and the disease has not budged at all, then probably it would be difficult to expect any good responses. So a prospective study beyond, it's a single arm phase 4 study using bosutinib. We had patients in this which were resistant to 1 or more TKIs, and there were a significant number of patients who were resistant to 3 TKIs as well, nearly 1/4 of the patients. This study had excluded T315I and V299L because these mutations render the disease insensitive to bosutinib. And at 2 years follow-up, 56% patients were in MMR and 38.5% of those who were not having a cytogenetic response. So again, this study also shows that bosutinib can have certain benefits in such a scenario where things might seem very desperate. The ASSEMBLE trial, the most famous trial in the last 2 years, asciminib versus bosutinib. So I'll be discussing the bosutinib arm here. I'll be discussing the asciminib part later. So in the bosutinib arm, the responses obtained in this trial, which is the only randomized trial in such a setting, they were not that great as we had observed in the previous one. So MMR at 24 weeks was only 9%, and 46 out of 76, and nearly 2/3 of the patients were on a fourth line treatment in this arm, and this was the same for the asciminib arm as well. So asciminib performed better in such a setting as compared to bosutinib. The adverse events, all of us are familiar. GI toxicity with diarrhea is something which can be very difficult to manage. Then we've got other grade 3-4 toxicities like transaminases elevation, lipase elevation, cytopenias, and pleural effusions. Moving on to the other TKI, ponatinib. Ponatinib has specifically been tried in these indications only, T315I mutated or relapse or refractory to 1 or more TKIs. And I'll be discussing 2 trials. One was the initial CASE trial, which had enrolled both advanced phase, chronic phase, as well as pH positive ALLs. But amongst the chronic phase CML patients, out of 270 patients, 57 were on fourth line treatment and 24% had T315I mutation. In this trial, 45 milligrams ponatinib was used, and subsequently, because of arterial occlusive events, there was a dose reduction being employed. 40% MMR rates were seen, which is quite a significant figure in such a setting, with a 5-year PFS and OS of 53 and 73% respectively. So the efficacy is there with ponatinib, no doubt about it. But the biggest drawback that we had observed in this trial was the presence of really concerning adverse events like arterial occlusive events. And this was one of the major limitations why the drug really fell off favor initially. So accelerated hypertension, cerebrovascular and cardiovascular events, peripheral vascular events, venous thromboembolism, myelosuppression, these were much more serious and much more significant side effects. And we can see a very large percentage of patients had serious adverse events, like 26%, nearly a fourth. And almost half of these patients had multiple arterial occlusive events. So it becomes really unmanageable to use such a drug when we've got such concerning toxicities coming up. In the OPTIC trial, what was tried was to modify this treatment a little bit and to go for a dose de-escalation. So instead of using 45 for all, we use 45 milligrams initially. And once we have achieved a target of less than 1% BCR-ABL, dose reduction to 15 milligrams. So this was done solely with the aim of preserving responses while decreasing the arterial occlusive events. And to some extent, the results that we obtained in this were better than what we had observed in the PACE trial in terms of decrease in arterial occlusive events. It also showed that the 15 milligram dose of ponatinib can also be effective, although not as effective as the higher doses of 30 and 40 milligrams. This also had 282 patients with 54% of the fourth line treatment, a quarter with T315I mutation. And as we can see, a significant proportion of patients, 51%, obtained the target and went for a dose reduction. The arterial occlusive events were seen in 9.6% in this arm, which is less than what we had observed, nearly a quarter of the patients in the PACE trial. We can see that the responses can be seen at the doses of 30 milligrams and 15 milligrams as well, with lower arterial occlusive events. So in continuation with the previous discussion on ibrutinib, again, we have seen that lower doses of TKI can work, and it can maybe not as efficacious as the other dose, but definitely with lower side effects and some degree of efficacy. The asciminib new kid on the block, the new shiny toy in the CML game. It is a STAMP inhibitor, specifically targeting the ABL -12 pocket. Acts as a pin in the grenade and inhibits the BCR-ABL through a mechanism different from the usual TKIs. So in the phase 1 dose escalation study, heavily pretreated patients were there, and it was observed that complete hematological response and complete cytogenetic responses were seen in quite a lot of patients. Again, 70% with 3 or more TKIs, 1/5 of the patients with T315I mutation. Heavily pretreated, bad disease biology, but we were able to obtain good responses, 36% MMR and 34% MMR in those patients who had received more than 2 prior TKIs. Another real-world data from the Spanish CML group was also published, a small series of 31 patients. They also observed MMR in roughly a third of the patients who were heavily pretreated. Then the ASSEMBLE trial, which had compared asciminib and bosutinib in patients who had been treated with 2 or more TKIs. And so the primary endpoint was MMR at week 24, and a significantly higher rate of MMR was seen with the asciminib arm as compared to the bosutinib arm, 25%. And in terms of adverse events, also asciminib scored slightly better in terms of lower grade 3-4 toxicities.
So 2 minutes left, sir.
Yes, I'll just start. The adverse effects elevated lipase, hypertension, thrombocytopenia, but not too concerning. Just 2 minutes about allogeneic stem cell transplant also. In the TKI era, the use has markedly declined. In this setting, there is per se no randomized trial to compare use of a further TKI or to use stem cell transplant. So most of the data that we have is meta-analysis in which we've used transplant data from the 80s, 90s and TKI data in this century. So it's not exactly a fair game to compare in that manner. And so that introduces a lot of bias. The transplant survivals in general, because of better supportive care, have been improving. So we may have better outcomes with allogeneic stem cell transplant in CML in today's world than what we would have had in the 90s. And this remains a very valid and very viable option because particularly in India, some of the drugs that I have discussed, ponatinib, asciminib, the availability and the cost of these are going to be a challenge in the long run. So other than bosutinib, something which is readily, more easily, frequently available would be an allogenic stem cell transplant. Also, in Indian patients who tend to be younger as compared to the Western patients, when we are looking for durability of responses, we don't know if these drugs like ponatinib and asciminib may fare that well in the longer run. So again, allogenic stem cell transplant would present a better option. We can go in very desperate situations where we don't have access to any of these, we can go for the older agents. So hydroxyurea, interferon. There's data in China and US on omecitaxine, but that is also not used and available in India. And there are several new agents in the pipeline, which are TKI based and other mechanisms also, PPAR gamma agonists, immunotherapy, PD-1 inhibitors, JAK2 inhibitors, hypomethylating agents. So all these agents are there being trialed in certain scenarios in third and fourth line treatment. And hopefully we can combine these with the TKIs or combine these with other drugs to obtain better responses. So this decision is never a straightforward decision. It has to be always individualized, and disease-related features and patient-related features both have to be taken into consideration. So stage of the disease, presence of mutation, the patient's age, comorbidities, fitness for a transplant, fitness for maybe ponatinib if the patient is having cardiovascular issues. What are the patient's wishes, whether they want to go for an oral-based treatment or a transplant, and obviously finances become a huge concern. And based on these, we have to individualize each and every decision. In this setting, there are no clear answers. There is no one answer for any patient. But with the introduction of newer drugs, we are hopeful that we have a bigger basket to choose from. So multi-TKI failure is an unmet need because of lack of standard definitions and lack of standard treatment. Everything has to be individualized. The old modalities of particularly allogenic stem cell transplant is not an obsolete modality, and it can be specifically used in this scenario. Disease and patient-related factors will inform our decision. If the patient is in chronic phase, then that is the best time to go for any further treatment, because once a patient has progressed, the prognosis markedly worsens. And asciminib, lower dose ponatinib, and advances in stem cell transplants are a ray of hope in the future. Thank you for your patience here.
Thank you so much, sir. We'll now move on to our next session. This is going to be a panel discussion, and I invite our chairperson, Dr. Ravi Kumar Saxena, to please introduce our moderator and the panelists. Sir, you'll have to unmute your mic, sir. Ravi, sir. Yeah.
Good afternoon, everybody. So for this panel discussion, our moderator is Dr. Manju Sengar, and he will invite his panelists, Dr. Upendra Sharma, Dr. Sudhir, Dr. Jaiswal, Dr. Soumya Saurath, Dr. Ganesh Jashatwar, Dr. Prakash Singh, and Dr. Vishnu Sharma. I invite Dr. Manju Sengar to take over and do this panel discussion on CML CP case-based discussions.
Will you allow me to project from my end? That will be helpful.
Sure, ma'am. Sure, ma'am. Please go ahead.
Thank you. I hope it's visible.
Yes, ma'am.
Thank you so much. So thank you, organizing team, for having me here for this interesting discussion. Really enjoyed the previous talk. We have 20 minutes with us, and we have 7 panelists. So I'll try and keep the questions to one panelist, one question, and we may not have more than 2.5 minutes per person. So we need to be doing this little quick. But if anyone wants to chip in for answering any question which they feel they have a difference of opinion, please feel free to do so. So this is a case-based discussion, and I'll begin with this case scenario. So this is a 40-year-old male who's a stationery shop owner who presented with constitutional symptoms and priapism. Constitutional symptoms have been there for more than 1.5 months in terms of fever, weight loss, and decrease in weight, decrease in appetite, and early satiety. The priapism started 2 days back, and that's when somebody evaluated him outside, found to have raised CBC, and he was referred to an oncology center. He's a known hypertensive on telmisartan, 40 milligram once a day for last 3 years. On clinical examination, his performance status 1. There was pallor present. There were no lymph nodes. Spleen is around 10 centimeters below costal margin. This was the initial blood counts. Hemoglobin was 9.8 gram per deciliter. TLC was almost 2.8 lakhs and platelets were 3.3 lakhs. Peripheral smear showed shift to left along with basophilia and the blast percentage was 3%. Biochemistry was more or less normal and except for the uric acid, which was elevated, rest, liver function test and renal function test and sugars were within normal range. So my question to Dr. Upendra Sharma, how would you proceed when you get to see a male who's young and comes with priapism, high counts?
Thank you, Dr. Manju, for that question. So now we have a young person and he main emergency in this situation is he's having priapism because if for long standing priapism, patient may lose his vital organ and it will impair its further sexual life. So our main intention is that now patient is having leukocytosis and leukostasis, features of leukostasis. So adequate hydration is very, very important. We have to give full dose of hydroxyurea, say 1 gram twice daily. If facilities are available, we can go for leukophoresis for patient and surgical intervention for penile detumescence is very, very important in such scenario. First is how we can protect this, reverse this priapism. That is the main concern in this scenario.
Sure. Any further workup? Would you suggest why we are managing the priapism?
So once we have tied over the crisis of this emergency crisis, we'll proceed further for we'll do a bone marrow aspiration biopsy for this patient, cytogenetics, and then BCR-ABL quantitative with interventional standard ratio. And we'll risk stratify this patient to say high risk local score or ELTS, high risk or low risk. Accordingly, we'll plan our further line of treatment.
Thank you. So, as we know that this is a medical emergency, and if we do not handle this immediately, there is a high chance of erectile dysfunction for the life, and therefore priapism needs to be managed quickly, along with investigations which should go on parallelly to see what is the reason. Very high likelihood, given this peripheral smear with basophilia and the clinical picture of splenomegaly, high likelihood of chronic myeloid leukemia. So agree leukophoresis, hydroxyurea, investigations quickly to establish the diagnosis. Dr. Upendra mentioned that we would want a quantitative BCR-ABL. Just seek an opinion from Dr. Ganesh, what do you think, whether we need a quantitative at baseline or you'd be happy to have even qualitative PCR?
Thank you, madam. So in this case, most all the CML cases, diagnostic bone marrow cytogenetics and qualitative PCR is what we look for. Quantitative PCR is not, we don't opt at diagnosis, just the type of the BCR-ABL transcript is enough to monitor the transcript level subsequently through quantitative PCR. So I'll be focusing on cytogenetics and qualitative PCR.
Sure, thank you. So I think everyone agrees that a bone marrow aspiration along with cytogenetics, if you have facility, do the conventional cytogenetics or FISH and PCR. And I would agree to the point that looking at qualitative PCR is more important, because that's where it will help you in subsequent monitoring. Once you know the type of the transcript, it will help. More so if there is atypical transcript, it has value in terms of if you are thinking of treatment-free remission later on. So that's the reason why we should have a qualitative PCR. So this patient underwent a bone marrow aspiration, and it did show features which were consistent with the myeloproliferative neoplasm, and same was true with the bone marrow biopsy. The FISH was consistent with BCR-ABL fusion and 95% of the interface cells. However, the karyotyping was not feasible because of the lack of the metaphases. And here the qualitative PCR showed BCR-ABL transcript P210, which is E13A2 type of transcript. So we did establish the diagnosis of CML, chronic phase, and this is a typical transcript. So the next question comes in: which prognostic score would you prefer in the current era of TKI, when you have multiple TKIs and almost all patients receive these either imatinib or newer generation of TKIs at frontline? So my request is, Dr. Sudhir, if you can take up this question, how would you prognosticate? Do you prefer one over the other, or they are all the same?
Sudhir sir, you'll have to unmute your mic.
Yeah, sure. Good afternoon. There are the prognostic indexes are like Sokal score or ALTS or UTOS and newer ones also. So therefore the TKI, the Sokal score is basic for the first prognosticate that. And now the ALTS score is more useful for the newer TKIs for the patient.
So any difference of opinion? Okay, so we know that we have evolved in terms of prognostication from Sokal, Hasford, and UTOS, and now ELTS score. The advantage, though most of the trials which have addressed TKIs in chronic myeloid leukemia have used Sokal score for risk stratification, but ELTS is something which is better over Sokal, and it has been shown in studies that ELTS performs better because Sokal identifies a significant number of patients in the intermediate and high risk group. If we use the same scoring, same set of patients and score them with Sokal risk and ELTS score, ELTS puts a significant proportion of patients in the low risk category as opposed to what we look at in the Sokal risk. And and it has been shown in these studies that it is much better when we are talking in terms of TKI-based treatment. So more and more emphasis over a period of time would be on ELTS as opposed to the Sokal risk score. But you're right, many in the clinics we do use Sokal, but this is a thing which we need to keep in mind, that ELTS performs better in terms of prognostication as opposed to Sokal by putting a smaller number into intermediate and high risk, and majority goes into low risk. I could see a question in the chat from Gaurav that whether there is any role of doing winter shunt in this case early. So if the conservative measures like leukapheresis as well as aspiration is not working, then answer is yes, you can try one of those shunts which can help in taking care of the priapism. So we move on to the next question, and this is what I was talking about, that how ELTS performs better as compared to the Sokal risk. So what would you consider as frontline treatment for this patient, given the options which we have, and how would you decide one over the other? So may I request Dr. R.M. Jaiswal please to take this question?
Yes, ma'am. I am the not right person to take the therapy because I am from the transfusion medicine and this to see the molecular response. But just I would like to take my response here. When we are talking about the leukapheresis, we have treated 2 or 3 patients where their count is more than 3.5 lakh. And it gives the immediate relief to the patient, and in the meantime, you can give other drugs to act on. And in reference to you also mentioned the treatment, this monitoring point of the different response. So just I would like to add, because as a side we have to see the complete hematological response and cytological response, as well as this molecular response, early molecular response. So these are the very important factor to see the response of the TKI in the early phase of disease. We have to see the early molecular response, because when we are seeing there's a less than 10% of transcripts, we are in comparison to international standards, then we can see my patient is responding. So my more part towards for the diagnosis and giving the supportive role in case of any emergency. Over to you, ma'am.
Thank you so much. So may I request Dr. Soumya to take up this question?
Thank you, madam. So that is a very important part, that what is the frontline therapy? Because there are multiple factors when we look at the frontline therapy. We have to look at the options. I think all the trials, starting from the IRIS, DASISAN, NSTENT, we have got the options of imatinib, nilotinib, dasatinib, and bosutinib with us. We have to look into the age of the patient. We have to look at the score, the prognostic score. What is the it is a intermediate risk or a low risk or a high risk. Then we have to look at the comorbidities of the patient, whether the patient is a hypertensive, diabetic, lipid profile. According to that, we take a call. And if the patient is in a high risk score, then we will prefer a second generation TKI. For a low score, we will go with a imatinib. So the EMR and the early molecular response and the deep molecular response are achieved better with the second generation TKIs compared to the first generation. But whether that is making a OS impact, answer is still we have failed to have a OS impact with that. So I think we have to take multiple considerations before choosing the frontline therapy.
So this patient has an ELTS of intermediate risk. Would that help you in narrowing it down? And as I said, he's 40 years male. He's otherwise having hypertension, which seemed to be well controlled for last 3 years. So would you, think of any specific TKI while you are counseling this patient?
So he's 40 years and he's having an intermediate risk. Probably I'll go to the second generation TKI if finance is not a issue.
Okay, so anyone has any difference of opinion? And if we are talking in terms of second generation TKI, which second generation TKI and what dose?
So, so the options of nilotinib and dasatinib is there with me, but he's a hypertensive. So probably I'll go with the dasatinib in this case, madam.
So the reason why I was, trying to instigate in terms of dose is the low dose dasatinib data, which is there in the form of phase 2. So if you're preferring dasatinib in this patient, given that he's intermediate risk, would you consider using a low dose?
So low dose still, I'll wait for the longer data to come up. He's only 40 years and salvage options are not many in India. So I won't consider the low dose for him.
Sure. Anybody has any different thoughts? Okay, so just suggestion here. Though he's intermediate risk, we would think in terms of second generation TKI. He has priapism. Our intention would be to get the cytoreduction as quickly as possible and a quicker response. So that may give us another reason to use something which is more potent, so that we get a quicker response. So higher dose of imatinib. Any thoughts on higher doses of imatinib here in the beginning instead of second generation TKI?
So, ma'am, there were studies looking into the dose versus a conventional dose of 400 versus 800, and definitely higher responses, faster responses were achieved with the higher dose, but at the cost of toxicity. So, more of edema and more of gastritis, more of fatigue was there in the high dose.
Sure. So I guess using second generation TKI, dasatinib, as you have said that he's 40 years, you want to give second generation because he's intermediate risk. That's a reasonable option. However, I would still not leave the imatinib, given that there is still no overall survival benefit with any of the novel second generation TKI. What it does result in early responses, early molecular responses. However, there is no OS benefit as of now. And many of these second generation TKIs, especially in long run, if you look at nilotinib, very high incidence of cardiovascular events, almost as high as 33% if you look at the 10-year follow-up data. And even dasatinib, has an issue in terms of pleural effusion. Though low dose seems promising, we do need longer follow-up before we switch over and start using the low dose dasatinib for all the patients. So moving on to the response monitoring, may I request Dr. Vishnu, if you can tell us that how would you monitor this patient and how often?
Hi, ma'am. So actually, I would like to do CBC after 15 days of starting TKI to look for the hematological response, and definitely at 1 month after starting TKI. Then I expect that he achieved complete hematological response by 1 month. After that, 3 months qPCR at 3 months, followed by 3 monthly qPCR for first 1 year. Then if he attained major molecular response at 1 year, then every 6 monthly. Quantitative PCR at 6 months interval.
Sure. Does anyone look at cytogenetics any longer in these patients for assessing response? More so if there was some additional cytogenetic abnormalities at baseline, would you be interested in looking at cytogenetic response too, instead of just looking at PCR?
If his PCR is more than 1% at 1 year, then I would definitely like to go for cytogenetics also.
Sure.
Otherwise, not.
Sure. So you would recommend 3 monthly PCR, and after a year, if he is in major molecular response, you would come down to 6 monthly PCR.
Yes.
Okay. Anyone has any difference?
Yes, ma'am. Just I would like to add here one thing. Myself, Dr. Jaiswal. Now there is a sensitive method by digital Dopplet PCR, which are more sensitive to detect deep molecular response, failure of the deep molecular response. And in recent paper published on the niche of stem cell CD26, if we are also include in our monitoring program, because there is a always presence of CD26 stem cell, which tells earlier failure than this RT-PCR method. So I think thanks to Malhotra sir, who is giving me opportunity to join this panel discussion, and under his guidance, we are developing such kind of lab, which is integrated with all the latest facility, NGS, RT-PCR, so that we can collect the data and we can give some contribution for the monitoring and effective planning of the further trials. Thank you very much, ma'am.
Ma'am, 2.5 minutes left, ma'am.
Yeah, I will just have 2 quick questions and then we will.
I would like to add one thing just here. Yeah. Concerning massive spleen count and uric acid 10, and I have lost a patient with terrible TLS, although very unlikely. So I would like to add a TLS screen after 7 to 10 days in this case, at least. Just.
Yeah, so I totally agree with you. Uric acid was high, which is an indicator that this patient is prone for developing tumor lysis, especially if we are thinking in terms of effective cytoreduction, which brings down the counts quickly. So anti-TLS measures should start, irrespective of whether he has other biochemical abnormalities or not. They should start in the first week, and we need to be careful in monitoring the tumor lysis syndrome. Thank you, Dr. Prakash, for bringing that very important point. So my question is, everyone wanted, BCR ABL at 3 months. So if this patient fails to achieve an EMR at 3 months, meaning the BCR ABL still remains more than 10%, how would you act? Dr. Prakash, to you.
Practically, in my experience, there are many patients who don't achieve, and I still continue with the same TKI which it was going on. Means it's too early to jump at 3 months. I would wait for another 3 months.
Correct. So you do have, a strong data to support your recommendations that, at 3 months, this is prognostic. But changing therapy, if you don't achieve EMR at 3 months, is not really recommended. In fact, if you have the same situation persisting at 6 months, then you would start thinking in terms of changing your TKI, looking at, imatinib resistance mutation in these patients, and changing over to another TKI based on your IRMA report. Because then the likelihood of somebody achieving a CCYR at 1 year is low, and that is associated with lower overall survival, progression-free survival, as well as overall survival. So absolutely with you there. So I think I'm just going to take something which is very important nowadays, and everybody's talking and everybody's discussing. So when and how would you consider, planning a treatment-free remission? And I'll come back to Dr. Ganesh here.
Yes, ma'am. So TFR being a realistic goal for most of our young patients below the age of 45, 50 years, who are in ELTS low and intermediate risk group, who on initial diagnostic evaluation have no additional chromosomal anomalies, and who are willing to be compliant for monthly qPCR monitoring after at least 7 years being on TKI, and after being at least three years of good deeper molecular response with MR 4.5. These are the subsets where I will strongly consider looking at the patient preference and patient willingness.
Sure. And in what proportion do you think that we achieve success if we are talking in terms of second generation TKI and imatinib? So what proportion we are successful in achieving TFR?
About 40 to 50%, ma'am.
Okay, so I think it's lower with imatinib. It's roughly in the tune of 25 to 30%, a way little higher with the second generation TKI in the tune of around 40%. So absolutely right, and that's why here we need to know whether it was a typical transcript or not, whether there were any additional cytogenetic abnormalities or not, and monitoring response, as everyone wanted a PCR every 6 months, is for the same reason that MR4 for at least 3 years or MR4.5 for at least 2 years. And somebody on TKI for more than 5 years is the candidate where we can think in terms of TFR. So I guess that's my last slide, and I think we have finished our time. I did see a question from Dr. Lalit Mohan in terms of few patients we see BCR-ABL less than 5%. I'm not sure whether you're talking about diagnosis or we are talking in terms of during response assessment. So if it is a diagnosis, and we are talking about this as a PCR, which is showing less than 5%. If somebody has done the quantitative, I would seriously go back and look at whether there is conventional cytogenetics and FISH has been done or not. And if that is negative, then the likelihood that something which is false positive is what we are looking at, because these low copy numbers at diagnosis cannot support a diagnosis of CML chronic phase. And we need to really look at the assay as well as other methods to support the diagnosis. So with that, I thank you all my panelists for being in time, keeping your questions crisp and clear, and keeping your answers crisp and clear. So thank you, everyone. And thank you, organizers, once again. And I did read Dr. Lalit Mohan's comment that I'm a strict teacher, and my reputation really has gone bad. So I think I need to work on that. Thank you, everyone.
Thank you so much, ma'am. I now request our chairperson, Dr. Ravi Kumar Saxena, to please introduce our next speaker. Sir, you'll have to unmute your mic, sir. Ravi, sir, you'll have to unmute your mic, sir.
Yeah, our next speaker was everybody knows Dr. Noopur Raje, and the topic is Denovo High Risk Myeloma treatment options. So I invite Dr. Noopur Raje to please go ahead with the talk.
Thank you so much, sir. Over to you, ma'am.
Thank you so much for giving me this opportunity to present at the ICON meeting. I wish I was there in person, but unfortunately I am sending you a recorded version. I was asked to talk about de novo high-risk myeloma treatment options, which is what I'm going to do over the next 15 minutes or so. Here are my disclosures. As you all know, defining high risk in multiple myeloma can be in several different ways. At the time of diagnosis, obviously genetic high risk features make a difference, and typically we consider 414, 1416, 1420, as well as P53 mutations to be high risk features. More and more data now suggests that anything to do with chromosome 1q abnormalities also portends a high-risk phenotype to multiple myeloma. Other clinical features such as extramedullary disease, renal involvement, plasma cell leukemia, or amyloidosis can also contribute to the risk presentation of a patient. At the time of relapse, again, defining high risk is important. High risk disease at presentation continues to be high risk at relapse as well. The one thing which you can acquire at the time of relapse, however, is deletion 17p or mutations of P53, which is why it's important to re-look at risk stratification. And again, clinical high risk includes early relapse after prior therapy, that is less than 2 months following an autologous stem cell transplant or less than a year after the most recent prior therapy. Clinical relapse and extramedullary disease at the time of relapse also constitute high risk disease. The challenge with high-risk disease, obviously, is the effectiveness of treatment is certainly less as compared to normal risk disease, and as patients relapse, the durability of response also decreases. The incidence of end organ damage is higher, the incidence of extramedullary disease seems to be higher, and most patients, even at first relapse, tend to be refractory to both the proteasome inhibitors as well as the immunomodulatory drugs. And with every treatment, you see attrition in the number of patients who get treated, which keeps going down with the next line of treatment. I think it's important to acknowledge that evaluation in the case of high-risk disease is not any different, but it's really important to do imaging with PET CT scans or whole body MRIs because of the incidence of extramedullary disease in the context of high-risk disease. Again, at the time of relapse, we always recommend repeating a bone marrow biopsy because of what I mentioned earlier, that is acquisition of the P53 or deletion 17p mutations over time during the course of the disease. The principles of treatment I don't think should be any different for standard risk or high risk. I think our goals of treatment are simple. You have to improve the symptoms, obtain a deep response, and specifically in high-risk disease, you want to try and achieve MRD negative disease and use your best drugs up front because you want a really long and durable first remission. Always, always, always consider trials. This is a summary of high-risk subsets in newly diagnosed multiple myeloma patient trials. And on average, depending on whichever trial you look at, the combination approaches tend to do better. So triplets are better than doublets, and we're soon going to be talking about quadruplets as well. The numbers of patients with high-risk disease tends to be less, but the triplet in all of these studies is better than the doublet. And the quadruplets, such as in the Cassiopeia trial, also seems to be better than the triplet, and therefore we should be considering using combination approaches, certainly in the high-risk patient population. This is a single center experience, the Emory experience, and I wanted to highlight this because they've used RBD induction followed by consolidation with a transplant and maintenance for high-risk multiple myeloma, where they have used dual maintenance in this patient population. And with the dual maintenance, with even ISS stage 3, modified ISS stage 3, you see a median duration of response of 31.5 months, suggesting that in high-risk multiple myeloma patients, you should not just be using lenalidomide maintenance, but these are the patients who should be getting the proteasome inhibitor in the context of maintenance as well. What about the role of carfilzomib in high-risk multiple myeloma? Here are a few trials wherein KRD has been incorporated in the treatment of multiple myeloma, and I think the one which I will highlight most is the one by Francesca Gay, which is at the bottom in this table here. This was the Forte Trial, and the reason I wanted to highlight that is it's really enriched for high-risk disease, and KRD with a transplant followed by KR actually had the best outcomes in this high-risk patient population. What about the role of daratumumab in high-risk disease? Well, it doesn't matter which clinical trial you look at, either in the newly diagnosed space or in the relapse refractory space. What you can see here is the fact that all of these trials tend to have, with the addition of daratumumab, as you can see, the hazard ratio favors a combinatorial approach, suggesting that you should be using combinations in the context of high-risk multiple myeloma. This is the Griffin trial, so we've moved on from triplets now and we're all using quadruplets. This was presented at this year's ASH. This is the Griffin trial combining RBD with the addition of daratumumab versus RBD alone. And what you can see out here with the quadruplet is a very high complete response rate of 82% compared to 61%. Translated into a very high MRD negative rate at 12 months of 44% versus just 13%. Again, this did not have a lot of high-risk patients, but the bottom line is whether you had high-risk or standard-risk features, the combination approach of 4 drugs almost always does better. So in a patient with high-risk disease, I would use my best drugs up front, including 4 drug combinations. This is what the overall survival and progression-free survival with the 4 drug combination looks like, and if we can achieve this in a high-risk patient population, I do think this is going to be something which will really impact the outcome of these patients. I did want to mention another trial. This is the MASTER trial. This is daratumumab, carfilzomib, lenalidomide, and dexamethasone. This is the first trial which actually used MRD to try and tailor therapy, and they defined MRD sure as 2 MRD testings 12 weeks apart, and if patients were MRD negative, they ended up actually stopping treatment. This is where you had limited duration treatment. What you can see out here is MRD data, and if you look at MRD data in the high-risk patient population, the rates of MRD negativity, specifically if you look at 10 times minus 6, was a little bit lower, and if you look at this patient population in the ultra high risk, stopping patients because of MRD sure status was not a good idea. And specifically in the high-risk patient population, I think it's important for us to continue treatment and continue treatment with both the proteasome inhibitor and the IMiD. The question of daratumumab or CD38 monoclonal antibody, at least continue it for 2 years or so based on the Griffin data. So a little bit of extrapolating in the high-risk patient population, but this MASTER trial is the first trial where we've used MRD to try and tailor therapy, and I think what we've learned is just the 12 weeks apart MRD sure not good enough. I would use the IMWG criteria of sustained MRD negativity of at least 1 year of MRD negativity, and in the cases of high-risk patients, my sense is this is the one subset of patient population which is going to need to remain on continuous therapy. What about some of the emerging treatment strategies for high-risk disease? These are all the drugs that we have used in the context of myeloma. I'm going to specifically focus on some of them. This is a bunch of clinical trials, phase 3 clinical trials in the relapsed refractory setting, and the combinations are always better compared to the control arm, with nearly doubling of the progression-free survival. These are where the control arm was a proteasome inhibitor and dexamethasone. If you look at the IMiD dexamethasone control arm, again with the triplets, you're seeing doubling of the progression-free survival. Again, in the relapse setting, we are testing 4 drug regimens, and I think specifically in the high-risk patient population, you should be studying 4 drug combinations, specifically if you've started using them in the upfront setting as well. What about some of the new drugs? And we're going to talk about some of the immunomodulatory treatments out here. This is iberdomide. Iberdomide is a new oral novel cell mod which ligates cereblon E3 ligase, and it targets the same Aiolos and Icarus, and it also has immunomodulatory function. Tested this in combination with dexamethasone in patients who are refractory to both lenalidomide and pomalidomide. We're seeing overall response rates of close to 55%, and if we can bring some of these immunomodulatory drugs earlier on in the course of high-risk disease, I think we will be able to change natural history. There's data on IBER combinations, so IBER has been combined with bortezomib and dexamethasone, as well as with daratumumab and dexamethasone as well. What about other approaches? Well, we're all excited about BCMA-directed targeted approaches, and at least for the high-risk patient population, the sooner we incorporate some of these, the better the outcomes of patients. We'll start off with belantamab mafodotin. This is an antibody drug conjugate, as you all know, which is approved in the context of multiple myeloma. myeloma. And as of right now, we are testing combinations of belantamab mafodotin either with IMiDs or in this case with a proteasome inhibitor because of some of the ocular toxicity that you see with belantamab on its own. What about CAR T cell therapies? Well, this is a schema of CAR T cell therapies. It's not an off-the-shelf therapy. It requires a little bit of planning because you have to go through leukapheresis, you have to modify your T cells, then give them back to patients. But the important thing to remember, we've talked about high-risk disease and we've talked about extramedullary disease. And this is what you see with strategies such as CAR T cells. A lot of extramedullary disease, but by month 6, you're seeing resolution of the extramedullary disease. So in high-risk patients, if you can actually use these strategies earlier in the course of the treatment, I do think we're going to make a big difference. And this is something we did see in the Karma trial, wherein we saw that ide-cel was able to yield very deep and durable responses in patients with high-risk disease and also extramedullary disease. We were able to actually control the disease better with CAR T cell. So there is an ongoing trial right now. It's designed specifically for high-risk multiple myeloma and high-risk, which is defined by either as revised ISS-3 or genetically high-risk disease, wherein patients are getting initial induction treatment and instead of a transplant are going on straight off to a CAR T cell approach. This is an ongoing trial. This is accruing as we speak, and we will see how this translates into outcomes in this high-risk patient population. There's another high-risk trial with the other CAR T cell drug product. This is cilta-cel and has several different cohorts, again addressing high-risk multiple myeloma, and we'll wait and see how the responses with this patient population does in the high-risk setting. What about bispecific T cell engagers? Well, this is an exciting platform, and we have several different bispecific T cell engagers which are being tested in the context of multiple myeloma. The important thing to remember out here is these are all of them which have been presented at recent meetings. And importantly, we are seeing very high response rates, as high as 60, 70, 80%, with about 30 to 40% of patients achieving a complete response. So this is in quad refractory and penta-refractory patients. So in the high-risk patient population, if you can bring it up earlier, which is an off-the-shelf approach, our hope is that the high-risk disease actually does quite well with this. The rate of CRS and neurotoxicity does exist, but it's certainly less than what you see with CAR T cell therapy. So in summary, I think if a patient has not had a prior CD38 monoclonal antibody, you can use combination approaches, daratumumab, pomalidomide, daratumumab, carfilzomib, or cetuximab. If they've had a prior CD38 monoclonal antibody, combine carfilzomib, pomalidomide, use cytoxan with dexamethasone, but all consider other combinations or other approaches such as CAR T cells, selinexor combinations. The one thing I will say is if they have the 11-14 translocation, think about venetoclax, think about belantamab mafodotin, and always, always, always think of a clinical trial in the context of high-risk disease. So I think based on all of this, our current understanding is that high-risk multiple myeloma still remains an unmet medical need. You know, unlike some of the standard risk patients, the high-risk patients who will relapse within the first 2 or 3 years of their initial induction treatment. I think using the power of immune strategies is going to be critical. Trying to use CAR T cells early on in this patient population, I do believe is going to change the natural history of this drug. There are novel targets which are already under investigation, like GPCR5D and 5CRH5, which are exciting. And then drugs with different mechanisms of action in combination is going to be critical. And I think specifically for high-risk disease, our goal should be to try and achieve MRD negative state. And we at least have the tools now wherein we can begin to identify high-risk disease. And we also have the tools in the way of all of these different drug combinations. So use them early, use them in combination, and try and get to that MRD negative disease status. For the future, I think we have to continue to search for novel targets because this is the patient population which will actually relapse. We have the power of immune strategies which still remains to be completely harnessed, and I do think sequencing CARs, BiTEs, dual targeting strategies is what's going to transform somewhat chronic, and it's the high-risk patients where we haven't seen chronicity, but this is where we want to use these strategies early so we can first begin to see some chronicity in high-risk patients, which will ultimately be the platform for a curative strategy. So with that, I'd like to thank you all for your attention, and I hope you all have an excellent meeting. Thank you so much for this invitation.
Thank you so much, ma'am. This session was supported by Johnson & Johnson. With that, we'll move on to our next panel discussion. Can I invite Ravi Kumar Saxena sir to please introduce our moderator and our panelists. Over to you, sir.
That was a very interesting insight into new treatment options of high-risk myeloma. Now we progress to the panel discussion on very high-risk and high-risk myeloma. I invite Dr. Gaurav Prakash, who will be moderating this session. And his panelists are Dr. Pankaj Tantia, Dr. Ashish Verma, Dr. Hari Menon, Dr. Jitendra Kumar, Dr. Prashant Mehta, Dr. Shweta, and Dr. Hemant Dadich. Over to you, Dr. Gaurav Prakash.
Gaurav sir, please note Dr. Pankaj will not be able to join us. All the rest of the panelists have joined us.
Okay. Thank you, Chairperson, and I thank all the organizers for this opportunity. I'm lucky to have a great panel to discuss. And we just heard Dr. Noopur Raje deliver an excellent lecture. She gave us peep into the future, which seemed to be a therapeutic wonderland to us. However, when we sit in the clinic, the reality is much different. So to bring out that reality with context to high-risk myeloma, I invite all the panelists on the floor. They have been introduced. We have 20 minutes or so. So let me begin with the sharing of my slides first. Just a second.
So would you like us to show?
No, I hope you can see that.
Yes, sir, we can see your screen.
Excuse me for that. Yeah, thank you very much. Right. So let me start the discussion with Dr. Shweta, if Dr. Shweta is around, and I will request all my panelists to open the unmute as well as open the video so that we can see each other. So I think the basics start from how do we define high-risk multiple myeloma. Myeloma is quite heterogeneous. Yeah, myeloma is quite heterogeneous, much more than what we expect it to be. There is clonal, subclonal variations, which are always there and keep surprising. So Dr. Shweta, can you just put some light on how do you define high-risk multiple myeloma?
So the high-risk myeloma, sir, we would define with the high-risk mutations like translocation 414, 1416, and the P53, the 17P, 1P, 1Q gains. Other than that, if the patient is having RISS3 or ISS3, patient is having explorative index increase. So these will be like the patients who will be having high-risk myeloma.
Right. Shweta, may I ask you that in the day-to-day practice, if you see a patient, a newly diagnosed multiple myeloma, up to what extent do you investigate that particular person for these high-risk parameters?
So, I honestly send a fish panel for everybody.
Okay. And
but
usually,
beyond,
That is outsourced, I believe.
Yes, yes, sir. But beyond that, I mean, I do the LDH and I do the RISS staging, but the plasma cell S phase and the GPs are not done, sir.
Okay, so I think that is a valid point because GEP, anyway, within the US also, it remains in the realm of clinical research. The turnaround time is huge and not clinically possible. I spoke to my laboratory regarding plasma cell S phase. So this is a flow-based parameter in which a special staining dye is needed. It can be done, however, it needs to be standardized across the different laboratories, and then only you have to use it. So is anyone in the panel, especially Professor Menon and other seniors, are using this plasma S phase? The other point is that it is only the M-SMART, which is the Mayo Group recommendation, which include high plasma cell S phase as a high risk marker. We understand that this is a marker of more proliferation among the plasma cells. But so any comments on that?
Thank you, Gaurav. No, I don't think we are using that, but the important thing that we do to ascertain cytogenetic abnormalities is to do it in cell-sorted plasma cells. Otherwise, we are likely to miss the cytogenetic abnormalities, which are close to about 80% in plasma in multiple myeloma. So that's the extent to which we go. And in order to interpret it with conviction, it should be done on cell-sorted plasma cells, the cytogenetic identification of cytogenetic abnormalities.
So that's a very important point for the trainees, that because plasma cells are mature cells, so they have a very low propensity to divide. So when you are going to do a conventional karyotyping or cytogenetics, a sorting has to be done. Otherwise, the much immature cell, they will take over your cytogenetics and the results will be not representative. So now in today's time, we all have access to the software and devices, so no need to remember all the translocation. However, there is a common confusion because they look so similar. All of them are almost involving IGH, which is chromosome 14. So we need to remember that 614 and 1114, they are standard rather good risk, where the median survival is around 7 to 10 years. So this is something which is very much easily available, but we need to be cognizant of the same. Now, from this, there is a derivative, and the derivative is called, I'll take to double and triple hit myeloma, sorry. And may I invite Dr. Jitendra to just put his thoughts on double and triple hit multiple myeloma. How do you use this information in your day-to-day practice?
Sir, as we know that double and triple hit are defined on the basis of available mutation, which are high risk. If 2 mutations are there, it is double hit, and if 3 or more are there, then it's triple hit. But to my belief, there is no data which suggests that they do differentiate in between each other. So we need more data, and we have to treat as high risk research.
So for the student, I would like to just mention that as of today, we are doing mainly one mutation, which is TP53 mutation, and most other are translocations or deletion, chromosomal aberrations. So therefore, FISH is the best techniques. Conventional karyotyping is, if available, it is excellent because, as Dr. Menon said, 80 to 90% people are likely to have some abnormality. But however, reality of our practice is we do FISH to pick up these specific chromosomal aberration, translocation, or deletions. Mutation is only one. And as true for CLL, TP53 and del17P, they are not synonymous. So if you have to look for really the worst of the worst group, then you have to do both, because there are around 5 to 10% cases which may harbor one but not the other. So with this, I move to Dr. Ashish, who is also from Jaipur and with us, regarding, do you think that is there any hierarchy between the poor prognosis prediction in these parameters? Is there something which is the most worst parameter, or something which is less worst?
Well, usually I used to do if I was to do one marker, then 17p deletion is one of the most important, which decide the treatment regime. If 17p deletion, if patient is positive, then I think he is at high risk, whether they are more than 2 or not. So 17p deletion from my point of view is one of the most important we have to do if we decide.
Absolutely. So you can see, I think this is almost arranged in the hierarchy of their poor prognosis prediction potential. 17p deletion or TP53, you can see the hazard ratio is very, very low, 0.447, and very closely is gain of 1Q. So if we have a limitation of panel, so at least these two and maybe 414 are the couple of parameters we must do in all the patients. If possible, definitely, because now FISH is very easily accessible in most laboratories, in larger center as well as outsourced laboratories, we can do that. So with this, I think we have discussed the initial part of it. This graph very well shows that double and triple hit lymphoma, multiple myeloma, they are really having a abysmal outcome. You can see nobody is practically surviving beyond 1 year. However, this is not a very large data. This graph, blue graph, shows the standard risk myeloma, and these graph are double hit and triple hit multiple myeloma, which is definitely a large area of unmet need we heard in the last talk. Now, in this also, you can see with each hit, like 1 high risk, 2 high risk, and 3 high risk, you can see the hazard ratio. If the hazard ratio, hazard of death or progression is 1 for a standard multiple myeloma, for triple hit, it is 7 times, which is a huge number and makes me worried that why we still call multiple myeloma as one disease. It doesn't look like a one disease, although because it is related to plasma cell, we call it myeloma. Okay, so now coming to more conventional and more day-to-day. We know the Achilles heel of multiple myeloma is renal dysfunction. So do you consider patients who come to you with renal dysfunction upfront, newly diagnosed, and extramedullary disease as high-risk multiple myeloma? Or do you use this information to treat them differently? May I ask Dr. Prashant for that? Prashant, are you there?
Hello, yeah, I'm there, sir. Hello, how are you, sir?
Yeah. Yes.
Yeah. So extramedullary disease and renal dysfunction, it does, portend, worse prognosis to my mind. And also the renal dysfunction is to be labeled as either correctable or non-correctable. Like if it is a correctable deficit, like hypercalcemia or dehydration induced or some infection underlying, that is corrected with management. So that should not be a problem. But something which is, a residual, non-correctable dysfunction, that does, confer, poorer survival.
So, all right. But do you include these cases traditionally as high-risk multiple myeloma, or
not traditionally? Not traditionally.
Sir, Dr. Menon, what are your views?
So, so the thing is, always extramedullary disease is and plasma cell leukemias are probably going to behave more or less the same, and they're just indicating the myeloma has gone beyond the confines of the marrow. So it's just like talking that it's like a metastatic disease, if you want to use an analogy with. So they also tend to harbor more cytogenetic abnormalities, which will again put them on the high risk group. So with conventional therapy, they don't tend to respond as well, and the outcomes are vastly different from those who do not have an extramedullary disease. At the same time, as like Prashant had mentioned, that renal failure is at baseline is a poor prognostic factor, but if it's corrected and if if it does not correlate with any cytogenetic poor prognostic features, then they would be treated just like any other myeloma, provided they are corrected with the primary treatment. But if the renal failure persists, then there are going to be problems in terms of implementing all the types of therapies that we have at our disposal for myelomas, and including the option of doing high-dose chemotherapy and stem cell transplant to a certain extent. But renal failure definitely, persistent renal failure definitely has a poor prognostic outcomes in myeloma.
Absolutely, yeah. Thank you for that. I think the title of this paper also says the same, that it is a genotype-phenotype issue. What does the molecular panel, FISH panel, tell us is that a patient is having a disease biology which is not very favorable, and having more extranodal disease, more circulating plasma cell, more plasma cell leukemia-like presentation and kidney failure. They are a phenotypic manifestations of those changes. So therefore, they are overrepresented in these subset of patients. It is important for us to also understand that patients who are presenting with these dysfunction, probably even if we are in a busy practice, we should try to look for an optimal prognostication of these patients, because that can help you in deciding the optimal therapy. So this is a paper from Saad Usmani, and it clearly shows that the patients, regardless of the treatment of the therapy they were given, the patient who had extramedullary disease, they were associated with shorter progression-free survival as well as overall survival. So not only it is prognostic, it is also predictive, which is like regardless of therapy, or should we call it predictive? So the second is renal impairment, the Achilles heel, and the data is very much clear. This is a large data cohort for 1,825 patients. And you can see patients who had renal dysfunction, they all have poor outcome. However, as the time is improving, we are having access to better drugs. So we are able to circumvent this kind of problem to some extent, not fully yet. Now coming to the most important aspect of this thing, we saw the presentation from Dr. Noopur Raje. She showed so many drugs, and most of them unfortunately are not available to us. So in the practice, in the outpatient practice in India, what should be our approach? So let me invite the panelists who are not yet participated. Dr. Hemant is there.
Yeah.
Hemant, can you take up your approach? Initial approach, you are sitting in clinic, you have a patient with a FISH report, and the patient is having high risk. You can choose any of the high risk parameter you want to.
Yeah, for patient for high risk, I will use means according to patient's condition, whether patient eligible for transplant or ineligible. If patient is eligible for transplant, I will I will do induce by 3 drug regimes like VRD or DRD. DRD, I think my setting is very costly. So VRD I will try, and I will send for the if patient is for transplant, I will send for a transplant. If patient is ineligible for transplant, I will give 8 to 12 cycle of VRD to the patient, and then I will perform the maintenance therapy.
And what will be your maintenance strategy, Dr. Ashish?
In high risk PI, I will definitely include, or low dose VRD I will give.
Okay. Can I also ask the same question to Dr. Shweta?
So, as sir has said, most of the times we at least give them the option of daratumumab, Lendex. We have not really tried quadruplet therapy as yet. But then, as sir said, most of the times patients are not really affording other than the CGHS or the ASI patients, and they land up with VRD therapy only. And if they're transplant eligible, we push them for autologous transplant post 4 cycles. Otherwise, we continue as sir has mentioned.
I think this is an important question. So let's take view from all the panelists. Prashant, what do you feel about using quadruplet upfront in a patient who is transplant, say, eligible?
So this is a very, it's a very customized question actually. So I don't use it for everyone. They're very highly selected few patients which I consider a quadruplet, and obviously it has cost implications. So somebody who has not responded to the initial 2 months of therapy well, and I want to achieve a deeper response, I have in 2 patients now I have incorporated DARA later as a quadruplet and try to achieve a deeper.
That's an important point.
I use it for a very short period just to achieve a deeper response and do it on autologous consolidation.
Okay, so should I take it that you are not yet convinced with upfront use of quadruplet in a patient who is not having otherwise other problems, young and fit, and VRD is an option?
So yes, I am not using up for everyone. I am not convinced with that. Although there is one meta-analysis which favors it, but there is one which is against it. So I'm not sure of that as of now.
So this is the
I response adapted kind of protocol.
Okay, fine. So this is like a tweaking you do after giving 1 or 2 months of initial induction, which is a triplet. And your preferred triplet is
VRD.
VRD. Okay, so looks quite good because this is the latest from ASH, ESCO educational book, not ASH. And this is pretty much what Dr. Hemant narrated to us, that the patient is eligible, you give VRD. They also keep options of DARA VRD, which is a quadruplet, or KRD for the sake of completion. So they all are option. In the subsequent slide, we will see the merit of each one of them. However, if you're having given 4, you do auto, after that consolidate versus maintenance. And almost everybody is convinced that the maintenance in high risk group has to be a proteasome inhibitor base if the neuropathy is not very severe. On the other hand, you just give continuation therapy, you give induction, either you put on maintenance if the remission is complete, or if it is partial, you may continue the same regimen till the patient can tolerate the same without much additional toxicity. Now, slightly taking a digression from the therapy regimen. Now, there is a mention about consider tandem autotransplant in this subset of patient, and there they have not written any single transplant. They just said consider tandem transplant after this. What are the views, especially the transplanter, Dr. Menon and Dr. Prashant? I would like to focus with on both of you for this.
So I will just answer. It's a difficult question. I have not done even a single tandem auto till now.
Okay, so
I've done one allo, which is a fully matched sibling. It's a young plasma cell leukemia.
We will come to that.
And
yeah,
yes,
we will come to that.
But I've not done a tandem auto till now.
Okay, and Dr. Menon, what do you think about it?
Sir, 2 minutes left, sir.
So the thing is, the thing about the whole is that a whole as a situation is that how can we achieve the deepest possible response over here? So the need to do a tandem transplant depends upon what is the upfront kind of therapy that you have used. So generally, the current understanding is that if you have used a daratumumab-based regimen, perhaps you don't need to go in for a tandem transplant because the depth of MRD achievement with that is much more superior. But if you have not used a daratumumab-based regimen in a high-risk myeloma, there is enough data to show that doing a tandem transplant improves the progression-free survival in these patients. It is a challenge to do a tandem transplant. And also there is some data that after the first transplant, if you have achieved an MRD negative status, doing a second transplant after that in a high-risk myeloma may not be that important. But it is about the sequencing of your therapy. But the bottom line is that tandem transplant, if there is a place for tandem transplant in myeloma, it is for high-risk myelomas.
Perfect. In fact, I will come back to the MRD part later because we have some data from Griffin study. So just to make the discussion more interesting, this is a similar kind of algorithm, which is from the Mayo group, Dr. Rajkumar, and they just consider autotransplant, and the American group, especially the Mayo group, is not convinced with the data of tandem transplant. If you are in Europe, you are more likely to agree with that because probably it emerged from that part of the world. So here we come to the daratumumab part, and I think we have already discussed this. So let us see what the literature says. As of today, the data of final outcome data of quadruplet being superior to triplet or other regimen for high-risk myeloma is not yet out. Whatever we have, it shows that there may be some trend of benefit. However, the use remains off-label. To support this, I'm going to show you this data from Griffin Trial. Griffin Trial is the latest most trial of quadruplet versus triplet, DRVD with VRD for multiple myeloma. I just want to draw the attention to this arrow, which shows that if you are using Dara-VRD for high-risk patients, then the benefit is not statistically significant. If you see rather, it is tilting towards RVD better, although since it is crossing the line, it does not matter much. So in high-risk group, adding DARA to VRD did not help as far as the stringent CR is concerned after autotransplant. Dr. Menon, maybe we can...
Sorry to interrupt you, sir. We are running short of time, sir. Can I request you to conclude?
It will conclude in 2 or 3 slides maximum.
Sure, sir.
Yeah, so I think so because time is short, I'll also show this data. Now, there are 4 trials which are DARA based versus their counterpart without DARA. All phase 3, 1 phase 2, and they are showing very clearly that in all 4-5 of them, there is no advantage of the endpoint by adding DARA in high-risk group. So this last column is high-risk group. Rather, we will be surprised that in Griffin trial, with DRVD, the CR rate was 18%, and without daratumumab, it was 30%, although it was not statistically significant. So I think we probably need to deep dive into the data because high-risk multiple myeloma is also very heterogeneous. We have now 8 translocation which may impart different prognostic value. So this is kind of an eye-opener, and probably after this, I will be really skeptical. And I like Prashant's idea of using a tailor-made regimen. If the patient is having suboptimal response to initial VRD, probably we can add. But I will be skeptical in starting DRVD as a front-line regimen as suggested by the Mayo Group more.
Yeah. So can I put in one comment?
Sure, please. And we are almost done.
So in ALL, we used to have a lot of factors initially which were important, but now MRD has emerged like the most important factor in ALL for deciding on a transplant or not. In myeloma, there is a huge meta-analysis now which has shown that MRD negativity improves OS. It has correlated with OS.
Yeah.
So now, do you think that all these translocations might matter less now, maybe later when we have more MRD adapted protocols?
You are right.
The response will matter more than achieving a MRD negativity will matter more than what the baseline translocations were actually.
I had similar views, Prashant, but when I heard the talk from Dr. Noopur Raje, the last two slides showed regarding Forte Trial, in which after giving induction, almost everybody was going from upfront CAR T therapy, which is almost not almost always, but is likely to have a very high MRD negative rate. So
we are far behind in the CAR T.
We are So that's the way I think the healthcare moves. So while we are refining our prognostic models, the speed with which newer therapy are coming, not only CAR T, we have 2 bites around the corner, as well as a couple of oral proteasome inhibitor, newer one. So I think we will keep learning. And if there is any last from my senior Dr. Menon and teacher, sir, can you just conclude? I will be grateful for that.
No, it's just to say that in high-risk myeloma, again, even though it is classified as high risk, you need to individualize the treatment based on the age of the patient, whether the patient can go in for a transplant, a tandem transplant, what are the characteristics of the cytogenetic abnormality which makes it a high-risk group, and then tailor the treatment accordingly. And of course, as Prashant said, MRD, even in high-risk myeloma, is coming back as is an important aspect, which is predicting for long-term outcomes in these patients for whatever treatment that we can use. And it's like a surrogate endpoint for also identifying newer drugs for better outcomes.
Absolutely true. So whatever, as of today, while we conclude, triplet remains the standard of care. Proteasome inhibitor, we have both the option. Most of us prefer bortezomib for the cost as well as ease of using it. And IMiD of choice is Len. Fourth drug, I think we can conclude, as of today, we can say it can be an option for younger, eligible, fit patient. It helps you to attain deeper response. However, there is no major impact of survival with whatever data do we have as of today. So there is no role of upfront daratumumab for patients who are ineligible, because these patients are not going to be cured. Keep daratumumab for future. Start with a doublet or triplet in this subset of patients. And lastly is, in this subset, please do not forget allogenic stem cell transplant. If young and fit, then in tandem, I think there can be a good place for doing an auto and tandem allogenic stem cell transplant. Probably this is the only therapy as of today which can give you a cure from multiple myeloma. There are limitations with that, we agree. However, please do consider whenever it is possible. With this, I thank all the panelists for their excellent engagement and hand it over to the organizer.
Thank you.
Thank you so much, sir. Thank you to all the panelists.
Thank you, sir.
We'll move on to our next session. It gives me great pleasure to introduce our speaker, Dr. Pratibha Dhiman, who's a consultant hematologist and BMT physician at Gitanjali Medical College and Hospital Udaipur. And she'll be talking on the topic maintenance therapy in AML, oral ASA. And this session is sponsored by Adley Oncology. Over to you, ma'am. Ma'am, can I request you to unmute your mic? Ma'am, are you there?
Yeah, I'm there. Can you hear me?
Yes, ma'am, we can hear you.
Okay. So first of all, good afternoon, everyone. I will like to congratulate the organizing committee for arranging this academic feast, and thanks to them to give me the opportunity to exchange my thoughts over a topic in this forum. So today I will be discussing about maintenance in AML with specific...
Ma'am, have you shared your slides?
Yeah, I have.
Ma'am, it's not visible on our screen, ma'am.
Oh my God, just a sec. Can everybody see that?
Yes, ma'am, it's visible now. You can make it full screen.
Sorry for that. Actually, the laptop is not working fine. Sure. Okay, so today I will be discussing about maintenance in AML with a specific focus on oral azacitidine. So, as we all know that current AML treatment paradigm, it consists of achieving remission through induction, and this induction can be non-intensive or intensive chemotherapy depending upon the age or the comorbidities and performance status of the patient. After we achieve this remission through the induction chemotherapy, we usually go through consolidation. And this consolidation can be chemotherapy in the good risk patient, and in the poor risk and the intermediate risk patient, it can be autologous or allogenic stem cell transplant, depending upon which part of the country the patient is residing. But after this, of course, the next question remains that is it enough or should we go further to treat these patients for further time so that the patient can remain in the remission? As we all know that being a treating physician, the road to cure is not so easy in AML. Usually we get the detouring after maybe refractory disease or relapse after chemotherapy or after transplantation. So we are lucky that in the last few years, there has been some development in the diagnostic and the prognostic testing in AML. So now with the help of NGS, with the help of multicolor flow cytometry, there are various tests which we can conduct to measure the leftover, the residual malignant cells in acute myeloid leukemia. And if we go through these studies, it has shown us that even if the patient has achieved a CR, approximately 30% of the patients, they have the presence of these persistent AML mutations, which can multiply further and can give rise to the relapse in the later stages. So this has given the concept of maintenance in AML, which should be necessary or has to be necessary nowadays to keep the patient in remission, as we know that the small chunk of leftover cells can multiply and expand further to give rise to the relapse. But with this maintenance therapy, there has been some challenges because already these patients who were treated for AML, either they have received high dose chemotherapy, induction and consolidation, or they have received stem cell transplant as a consolidation. So in these patients, already they have undergone quite a bit of cytotoxic therapy along with frequent admissions, transplant toxicities. And giving a maintenance to these patients should be given a thought because adding further chemotherapy to these patients has to be at the rate where the patient can tolerate the chemotherapy. At the same time, we can target the residual leukemic cells. So for the maintenance therapy to be designed in the ideal world, it has to be a convenient therapy, easy to administer, most probably an oral formulation, should not be requiring any caregivers or frequent hospitalization or frequent visit to the hospitals. Then of course this chemotherapy has to be tolerable to the patients because as already the organ function may be deranged in quite a bit of patients because already they have received chemotherapies. And third and the foremost is the chemotherapy or the therapy has to be affordable to the patients. So in the early days, there has been, not too early, of course, in 2000s only, there has been some early maintenance approaches which has been conducted in the form of low dose Ara-C, histamine dichloride, lirilumab. But unfortunately, none of them has shown any impact on the overall survival and no significant impact on the disease-free survival in most of the studies. So that has led to one of the factors that because targeted therapy is one of the group of therapies which specifically helps in the stoppage of the multiplication of the cells which contain a specific molecule. So in this range, as we know that approximately 30% of the AML patients do have FLT3 mutations. So there has been the Ratify trial which has been conducted where midostaurin, which is the FLT3 inhibitor, has been included upfront from day 8 of induction with the chemotherapy, leading towards the consolidation also, and in the maintenance also up to 12 cycle has been given. And these patients have shown significant benefit in the median overall survival. if you can see that the midostaurin arm has approximately 74.7 months of overall survival in comparison to the placebo of 25.6. And whether the ITD ratio is high or low, or even the TKD mutation, the midostaurin arm fared better in comparison to the placebo. The other molecule which has been targeted is, of course, in the phase 1 study is the IDH one. So ivosidenib IDH inhibitor has also been studied in phase 1 for safety and tolerability in the patients. And in this study also, the drug was included upfront with the toxic chemotherapy and continued till the maintenance. Approximately 72 to 77% of the patients, they were having the overall complete remission in the primary AML. And in secondary AML, the CR rate was approximately 44% of the patient. But this drug needs further trials to be seen in the upfront setting or in the maintenance setting in AML. So as we know that AML as such is a disease of genomic and epigenomic complexities. So hypomethylating agent which acts on the epigenetic mechanisms has been remained the most interesting factor to be studied in the maintenance phase of AML. And already we have proved that these agents are much safer in their tolerability and the frequent admissions are not required. So the trials has been conducted for different hypomethylating agents. The decitabine has been studied both in randomized and non-randomized trials versus the conventional care. And sadly, this has not shown any impact on the overall survival of the disease in the maintenance phase, although the drug was well tolerated. One study which was done by the European group, which has been unfortunately not completed because of the incomplete number of the accrual of the patients, but it randomized the patients in clofarabine arm, and subsequently the maintenance step 3 phase was the decitabine arm and observation arm. This study has shown some impact on the overall survival, but because of the reduced number or not the optimal number of accrual of the patients, the weightage of the study has been questionable. After this, the other agent that is the azacitidine has been used in the maintenance phases, and the IV formulation of azacitidine with a dose of 75 milligram per meter square for 5 days has been used by the UK trial and the Dutch trial. But in both the trials, there was an impact on the disease-free survival, but there was no benefit on the overall survival as such. So the OS benefit was completely absent from both these trials. Seeing all these previous trials and the safety of the hypomethylating agent and targeting at the same time the compliance of the patient, an oral agent has come into the picture, and that is the CC486 or the oral azacitidine. So this drug, because it has the same molecule as the IV azacitidine, but the bioformulation is as such not the same, and the dosing schedule is not the same. So this drug is tried in the maintenance phase for the AML patients. So considering that it's an oral formulation and the compliance will be better, the idea of giving the drug for a longer period with the reassessment of bone marrow was adhered, and the trial was conducted for that. So QUASAR was the trial which has been conducted to study to analyze the oral azacitidine versus placebo arm as in the maintenance phase of AML. So in these in this trial, patients who were more than 55 years of age with de novo or secondary AML in first CR or incomplete CR, they were after induction chemotherapy were taken randomized to the randomized trial as oral cytidine for 14 days in a 28-day cycle versus the placebo. So both the intermediate, the poor risk cytogenetics patients who were ineligible for transplant were taken into included in the study, and the drug was continued until the death or the withdrawal of the consent or the patient has the progression of the disease. So in this trial, the response assessment was done every every 3 cycles, and the bone marrow was also repeated. And along with this, the dose escalation arm was also there if the patient has the progression of blast from 5 to 15% in the period of time. So the Quasar trial has shown a clear-cut benefit on the overall survival. So there was a difference of 10 months in the overall median overall survival in comparison to the placebo, with the 31% lower risk of the mortality. And along with this, the relapse-free survival was also 5 months longer. Both these benefits were there in all the arms, even if the consolidation is not adequate, if the consolidation is less than 2 or less than 1 or more than 1 or more than 2. So irrespective of the number of consolidation cycles, the benefits still remain there. And as we can see here, that irrespective of the cytogenetic risk category and irrespective of the baseline MRD status, the arm with CC486 fare well. The other aspect of the trial, which has been addressed quite thoroughly, was the quality of life. So in most of the trials, the quality of life has not been addressed previously, but in this trial, considering the patients were more than 55 years of age and the sub-arm was more than 75 years of age also, so the health-related quality of life index was studied, and patients who were treated with oral azacitidine has been shown to have the adequate overall health-related quality of life. There has not been any breakthroughs. The safety of the medicine has along been the CR rates also been studied, and the adverse events along with the dose modifications and treatment discontinuation has been seen. So the most common dose modification reason was neutropenia, and the other adverse events were GI events. These GI events, they after first 1 or 2 cycles, then they started showing a reduction in the occurrence, and otherwise the safety has been similar to the injectable azacitidine. So,
ma'am, 2 minutes left, ma'am.
Okay, already 2 minutes. Okay, sure. So the thing is that injectable has not shown any benefit on the overall survival in comparison to the oral azacitidine. So this has been contributed by the fact that the patient was taking the medicine regularly, the adherence was improved, and the patient was more compliant to the medicine. So NCCN guidelines has included oral azacitidine as the maintenance therapy for less than 60 years of age in intermediate and poor risk patients. The subgroup analysis, which also had shown one more important thing, was there was independent benefit to the overall survival and relapse-free survival, even if the patient is MRD positive at the baseline. But of course, the patients who were baseline MRD positive, they were significantly associated with shorter overall survival and RFS. NPM1 and FLT3 mutations were also studied adequately in the group. They were adequately represented. And again, the oral azacitidine has shown improved overall survival independent of the mutational status. So in GIST, the MRD status, the cytogenetic risk factor, and the age were identified as the significant independent predictors on the overall survival arm. And along with MRD, cytogenetic, the number of consolidation cycles and the prior MDS has played a significant predictors for the improved RFS. Just one thing about the escalated dosing regimens: the patients who has shown progression of blast from 5 to 15%. These patients, for these patients, the dosing schedule has been escalated from 14 days to 21 days. The patients had tolerated the drug well, and approximately 1 out of 4 patients has shown the reduction of blast to less than 5%. And the safety of drug in the older patients who were more than 75 years of age has also been proved. They've been studied thoroughly. The major side effect, the major adverse event which happened in this population was constipation, GI adverse effects, and the quality of life were maintained in this subgroup of the population also. So this has actually given us a very encouraging data regarding the oral drug, which can be given in a maintenance phase to decrease the risk of relapse. And this has encouraged further more studies in other settings regarding the oral azacitidine. So one of the study has been done by the US group in the post-transplant setting, although the number was 30 patients, but they have shown that the relapse-free survival was significantly impacted in 7 days and 14 days dosing regimens in the post-transplant setting, and the median overall survival was not reached. Along with this, the grade 3 acute GVHD and chronic GVHD experience was acceptable with the acceptable toxicities. So, but we still have long way to go because oral ASA maintenance after transplant has been, a trial has been going on, the Amadeus trial, and it will be concluded by June 2024. The other trial which I will be keen to just address is the VIALE-M trial. It is not oral azacitidine, it is IV along with oral venetoclax, but it is also going on, will be concluded by 2027, just to show the impact on the RFS. So I think so that with this, we can take a message of optimism for the AML patients, because from the last decades, we have been treating the patients on the same guidelines. But now with the newer refiner technologies to capture the minimal residual disease, so that we can see the cells, we can see the leftover malignant cells, which can proliferate to give rise to the relapse. This can give us a vision so that we can give a more personalized touch or specific risk adapted therapy to the patients, so that the patient can remain in a remission for a longer period. And along with this, that the storm of the medicines which has come in the AML treatment, it has actually make a revolution in the disease guidelines nowadays. I hope that along with all these medications which we are now having access to, we can give a more specific strategy to the patient for the treatment along with the improved quality of life. So thank you so much for your kind attention. Thank you.
Thank you so much, ma'am. I now request our chairperson to please introduce our expert. Over to you, sir.
So that was a very interesting development in AML treatment. And for long, AML has been very difficult to understand from the maintenance point of view. There were so many controversies, so many drugs failed. But I think we have got something of promise now, so we will be looking forward to the future trials. I now invite Dr. Reena Nair to conclude this session with her expert comments and observations. So over to you, Dr. Reena Nair.
So nice being a part of a really good presentation on hematological malignancies. And I think from the very word go, we have learned so much today. I enjoyed Dr. Varsha Gandhi's lecture on reducing the amount of ibrutinib which we give. And we do have patients who have a lot of problems at the end of 1 month. So I think what she has suggested to the whole hematology faculty over here is to plan the randomized trial, and that's a really good suggestion. CML was well covered. The panel discussion was great with a lot of very fine tuning and good points that were made out by Manju and her panelists. We also had Noopur speaking on high risk multiple myelomas. Happy to see that we are not doing too badly with the 3-drug combination, and maybe we can still reserve the 4-drug induction chemotherapies for some time, except in the very high risk patients. And the role of transplant remains despite all our efforts with the new drugs to kind of get away from the old chemotherapy. We still have to respect the old drugs as well. The last presentation on maintenance gives us more hope in AML, which has been like a status quo for the last 30 years, and now beginning to look at the subtypes of AML and actually having a maintenance for the FLT3 patients, as well as the oral azacitidine making so much of a difference as shown by Pratibha, is a lot to add to our clinics and our practice when we go back next week back into our outpatients. So I will not take more time because I know you are running late. And I thank the organizers for having put up such a lot of effort to find the most relevant topics to be covered, which actually have so much meaning in our clinical practice. Thank you, everybody. And with that, once again, appreciate the effort of all the speakers, the panelists, and the audience for the questions they have asked. Thanks a lot.
Thank you so much, ma'am. Thank you to all our faculty members, our chairpersons, our panelist speakers, and moderator. We'll now move on to our next session. This session is sponsored by INTAS, and our speaker is Dr. Viraj Lavingya, who's a consultant, Department of Medical Oncology at HCG Cancer Center, Ahmedabad. Over to you, sir, for your session.
Hi, Kashish. Thank you. Good afternoon, everyone. So, Kashish, if you can share my slides.
Sure, sir. We'll just share the slide.
Right. So today I'm talking something very different. Usually I stick.
So sorry to interrupt you. Sophia, can you reshare the slides without the optimized screen sharing? Sorry, sir. You can go ahead now, sir.
Okay. So thank you once again, organizers, and thank you, Kashish, for having me here. My name is Viraj Lavingya, and I am a GI medical oncologist. Usually I speak only on GI cancers, but this time this is something very different. It is chemotherapy-induced thrombocytopenia, and we'll see in over next 10-15 minutes that why this topic concerns oncologists like me in GI, and as well oncologists across the board who treat solid tumors. Next. So what is chemotherapy-induced thrombocytopenia? It's more of a nuisance rather than a problem. It's a very, very common problem, especially when we are treating solid tumors. I don't treat hematological malignancies, but I'm sure everybody treating hematological cancers also face the same problem of low platelets. And this can result from different aspects. Is it because of your drugs, or it can be because of the radiotherapy, especially if it is given in the pelvic area, or just merely the disease itself, like the breast cancer or prostate cancer affecting your bone marrow, and that can dramatically reduce your platelet counts. Now, the platelet count, why are we worried about? The most obvious reason is the risk of spontaneous bleeding. And there are various levels for various disease. Like for ITP, you would be comfortable at 10,000, but for solid tumors, less than 10,000 raises all eyebrows. And that's when the risk of spontaneous bleeding is increased. However, there are other reasons as well. Like, as I said, it's more of a nuisance. You cannot do a surgical procedure if your platelet count is not beyond a certain threshold, or even you cannot do a radiotherapy to a pelvic area, especially in the CA cervix, when the platelet counts are low. So managing low platelets or thrombocytopenia is a very, very important aspect in treating solid tumors. And of course, when you have to give them platelet transfusion, that adds to another risk of transfusion-related complications. Next slide. So there are mainly two types of thrombocytopenia. Can we go back one slide, please? There are mainly two types of thrombocytopenia. The one, which is the nadir thrombocytopenia, means you just give one cycle of chemotherapy, and after 7 to 10 days on nadir, the platelet count just zooms down. Typically one cycle in the middle of the between the two cycles, your platelet just drop down to the very bad levels, less than 50,000. The other type of thrombocytopenia is persistent thrombocytopenia, where the degree of thrombocytopenia is not much. Typically hovers between 50,000 to 1 lakh, but because of this, your subsequent cycles and the dosages are not adequately administered, and there are dose delays. So next slide. So what are the consequences of this thrombocytopenia? What do medical oncologists or hematologists do when they face this? Next slide. And as you can see, that because of the increased risk of bleeding, especially in patients who have baseline less than 75,000 platelet counts, or as we discussed, that some disease who has bone marrow metastasis, or just poor old age and poor performance status. But most importantly, when you are using a multi-agent chemotherapies with platins like carboplatin, or alkylators like carmustine or lomustine, and to something that is related to me is the gemcitabine. As we will see, gemcitabine is very, very notorious to causing thrombocytopenia. Next. And what we do, next slide, please. And generally, what does community oncology practices do is there is dose delays or dose reductions, and effectively the recommended dose intensity are reduced dramatically, especially in old patients or obese patients. This is a major problem. You cannot give chemotherapy as planned. Next slide. Now, one may argue that, is there any problem, if you just, instead of giving a weekly chemotherapy, you just give at 10 days or 11 days, and does this dose delay cause any problem? Next slide. And you can see one of the important colorectal cancer patients, cancer trials in an adjuvant area showed that if your drugs, if your RDI, recommended dose intensity, was not more than 70%, then your survival dips down tremendously and statistically significantly. And hence, especially in the adjuvant area, it is very important to maintain your recommended daily dose intensity as per the advised, and do something about these low platelet counts. 20-30 years back, we had the same problem with neutrophil count. Nobody talks about it now because we have GCSFs, and we all have learned how to manage them. Next slide. So what are the key offenders? And next slide. And as we discussed, there are drugs which can reduce bone marrow, causes direct hit to the bone marrow, like alkylators or endoxan or cisplatin. And there are certain drugs which directly affect the platelet counts, either by immune mechanism like checkpoint blockades or oxaliplatin, which is a very common offender in my practice. And microangiopathy is caused by gemcitabine, again, a very, very common problem. And there are other drugs like venetoclax and some TKIs as well, as sunitinib, dasatinib, and imatinib. Next slide. And if you see all the retrospective meta-analysis, you see the commonest problem comes with gemcitabine carboplatin to the tune of 50% plus grade 3 or 4 chemotherapy-induced thrombocytopenia. The more agents you combine, the more likelihood of you getting a CIT. Even in hematology, you see the MAID and ICE regimens have CIT in the tune of 30 to 50%. Next slide. So how do we deal with it? Apart from delaying your chemotherapy, is there a way to deal with it? Next slide. And there are two drugs essentially available, TPOs, thrombopoietin receptor agonists. One is the oral pill, L-Trombopag or Rivolade, and the other one is Romiplastim, which is a subcut injections available now in India, manufactured in India. So we have essentially two armamentariums to induce your platelet counts. Next slide. And we will see that how do they work is just exactly like how GCSFs work. We have a megakaryocyte and a cell membrane, and there are TPO receptors. Thrombopoietin is important. When they attach to the receptor, they they activate the MAP kinase pathway and JAK-STAT pathway, causing signal transduction, and that is how the platelet counts are revived and the platelets come into the circulation. Next slide. Next slide. Next slide. So, do we have any data of using this TPO receptor agonists for management of CIT? There is a lot of data for ITP and other thrombocytopenia, but for CIT, there is a reasonable amount of data, many retrospective data, and 4 at least prospective studies, all from US, studying that can we use these TPO arrays for management and maintaining the RDI during our chemotherapy for solid phase cancer. Next slide. So one of the important study which came was this one, Romiplastim for CIT. Next, it was presented a couple of years ago in JCO. Next slide. This was from Memorial Sloan Kettering group. They took all the patients, predominantly GI cancers, who had thrombocytopenia or less than 1 lakh, and they randomized them actually to either do what physicians would do, just observe, or give them a romiplastim subcut injections every weekly. The dose was between 1 microgram to 3 microgram, depending upon the weight. Next slide. And they saw how much platelet counts is increased. And you could see the majority of cancers were GI, 33%, and maximum patients were advanced stage, 60% being in stage 3 and 4. Now you could see the baseline platelet count before enrollment was around 55 to 60,000. Next slide. And when they gave the romiplastim, you could see the 15 patients they gave romiplastim and 8 patients they did not. And you could see out of those 15 patients, 14 patients, means 93%, could actually resume their chemotherapy on schedule, and not only resume it, but go back to the full dose. So the bottom is the cartoon of one of the patient's example who was on FOLFIRI. And as you can see in the blue curve, the platelets were dropping. And the pink curve is what would be the expected platelet reserve. But when you give them romiplastim, the platelets went up. And even with that, the dosing went up. You can see the blue and the red bars. So not only the chemotherapy was maintained in the intensity, but also the duration and the dose. Next slide. So this was a very important phase, a randomized study showing that you could actually give romiplastim and maintain your dosages. It is also important that these 8 patients who did not receive romiplastim, when they crossed over to get romiplastim, as you can see in the bottom curve, their platelets again started rising up. So it is not that if you don't use it in first round or first few cycles, you cannot use it in later cycles. Whenever you face this problem, it is wise to use this romiplastim and increase your platelet count to make sure your chemotherapy stays in time. Next slide. Other secondary endpoints of this study showed very similar things. 64% resumed the same chemotherapy, 36% got changed to another regimen, 60% nearly got full dose, what was initially planned. Next slide. A very recent study, again a prospective study of a large 150 patients of solid tumors and liquid tumors for using romiplastim in chemotherapy-induced thrombocytopenia. Next slide. And you could see all type of tumors were there: breast, CNS, colorectal, gastroesophageal, head and neck, lymphomas, myelomas, and what all you have. So they studied 2 strategies. The first strategy was give romiplastim during the chemotherapy, just like we use GCSF the next day of chemotherapy. And the other strategy is to give it during the interim, means the middle of the cycle. So if you have a 14-day cycle, give at day 8. If you have 21-day cycle, you give at day 8 and day 15, and like that. So they wanted to compare what strategy of romiplastim induces a better dose intensity. Next slide. And you could see whatever strategy they used, most important is almost 80% of patients avoided chemotherapy dose reductions or delays, and almost 90% of patients did not require any platelet transfusion. Next slide. And between the 2 strategies, you could see the dark blue color is the one which is during go back please. The dark blue is the one where the romiplastim was given at the dose of chemotherapy, means once you complete chemotherapy, before they go home, you just give them 1 shot. And the sky blue one is the strategy where you give them at the interim. And you could see that it is better to give during chemotherapy rather than at the interim and wait for thrombocytopenia to settle in. So this is what even I do in my practice, especially with the weekly gemcitabine in hepatobiliary pancreatic tumors, where invariably by the 2nd or 3rd cycle the thrombocytopenia settles in, and we give it after the chemotherapy on the same day. Next slide. There is another prospective study for glioblastoma. Patients who are treating CNS tumors would relate to what I'm saying. Next slide. That after chemoradiation or the Stoops regimen, with temozolomide and radiation and giving them adjuvant temozolomide, thrombocytopenia is a problem, and quite a few patients do not end up getting the full dose. At least in the published literature, it is almost 20 to 25% of patients who face this problem. And this study wanted to study effect of romiplostim in those patients who have thrombocytopenia. Next slide. So they took 20 patients who had thrombocytopenia during their radiation or adjuvant, and they assumed that only 10% of patients would actually complete the full dose of approved temozolomide. And by just using romiplostim, they saw that 12 out of 20 patients could actually complete the full 6 cycles of temozolomide. Only 4 patients could not benefit from this. 2 patients had progression and 2 patients had side effects of TMZ. So 60% could complete, which otherwise we all know only 10 to 20% of patients could complete full dose of temozolomide. Next slide. So again, this is a prospective study which showed that using romiplostim in certain areas, especially with the alkylators, does help to maintain your RDI. Next slide. A very important randomized study which we are waiting for is a phase 3 study where we have almost 160 patients. All of the patients have oxaliplatin. FOLFOX chemotherapy is notorious to have thrombocytopenia, especially as the cycles go on. And this is a 2:1 randomized study with romiplostim versus placebo. And within a couple of years, we should have a proper RCT phase 3 data. Whether should we use romiplostim as a prophylactic, like we use with GCSF, or so that is very important study. Next slide. So to summarize, the data is very, very promising. I have almost now 50 plus patients, exclusively all gemcitabine based therapy, and I have enjoyed the period where I don't have dose delays or dose reductions. I'm able to manage 1,000 per meter square gemcitabine with this strategy. You could use this for wide range of solid tumors and wide range of chemotherapy, and I'm sure this would benefit all of these drugs and all of these strategies. There is an important aspect that, especially in the curative setting, maintaining RDI is very important. And I think so using these TPORAs may be important. One important point is, before romiplostim was launched in India, even I used to do this strategy with Rivolate. There is a very nice paper from Sloan Kettering where they use tablet of Rivolate just Monday and Thursday as a prophylaxis. 50 milligram Monday and 50 milligram Thursday in between your chemotherapy cycles, and the results were amazing. Your platelets would just stick to 81 lakh, and you are able to give all your weekly doses in time. Most important question mark still remains that by doing this, we have no prospective study which has shown any improvement in survival, or because we have not studied it, or any improvement in quality of life or transfusion reactions. Thank you very much. Kashish, back to you.
Thank you so much, sir. We'll now move on to our the oral paper competition finals. And I invite our 2 judges, Dr. Purvish Parikh and Dr. Prashant Mehta, to please announce the final participants.
Thank you very much. Prashant and I were delighted to be part of the qualifying round, where we had to evaluate 50 plus presentations. And it was a real difficult time to shortlist for the finals. But as is necessary, we have to do the duty of the judges and do so. Prashant, would you like to say a few words before we invite the first finalist? Okay. So
hello, sir.
Go ahead, Prashant.
So all the presentations, first of all, I would like to say that all were good, and there were some which were which are shining out amongst all of those, and those we have which we found that would be more impactful for our country. That was also one of the important criteria for us. So clinically useful, and obviously the content and the the methodology was also important. But yes, relevance to our country is something which we actually found more important. So I think you can announce further.
Excellent, excellent, sure. So I'm going to invite one by one the three finalists in alphabetical order. Okay, this is not according to the marks that you have got; it is in alphabetical order. And we also have two on the wait list in case somebody is absent. So for the first finalist, may I invite Abhilash Menon to make his presentation.
Good afternoon, sir. So my topic is prognostic significance of serum ferritin in acute myeloid leukemia. Now, AML is a hematological malignancy where treatment is mainly guided by molecular risk groups rather than other factors. But most of the centers do not have the infrastructure to define this risk. So practical biomarkers are limited. So this led us to the search for the same, and we believe that serum ferritin will be one. Serum ferritin is an iron storage protein, which is also an acute phase reactant. And ferritin is mainly secreted by hepatocytes. But in malignancies, being a pro-inflammatory state, macrophages, especially tumor-associated macrophages, secrete ferritin. And this extracellular ferritin has a role other than being the iron metabolism. It has a role in proliferation, in antioxidant, in angiogenesis, and as well as for the immunosuppressant microenvironment. This antioxidant effect is having a role in therapy resistance, and ferritin as a growth factor will stimulate the proliferation of leukemic cells. Now, even though serum ferritin as a prognostic factor was studied in many malignancies like Hodgkin's lymphoma, breast cancer, there are very few limited studies in acute myeloid leukemia. Be precise, one pediatric study from Poland, one study from Japan, one from Germany, and one from France. All these studies showed that long-term survival of these patients with high serum baseline ferritin is bad. But there are no Indian studies to guide us. Next slide, please. So this is a prospective study on newly diagnosed AML patients treated with curative intent in our Department of Medical Oncology, RCC Trivandrum, from 2020 to 2021. We have excluded APML, and the baseline serum ferritin was estimated, and a level of more than 1,000 was taken as high ferritin level. Clinical pathological parameters, post-induction remission rates, relapse rates were correlated with the baseline ferritin level. Next slide, please. So the objectives were to assess the serum ferritin level in patients with AML and its association with other non-prognostic factors, and to correlate the ferritin level with post-induction remission status. Next slide, please. So in this study, we have recruited 62 patients. Median age of the study population was 41 years with a range of 14 to 61 years. The gender distribution was almost similar, with 53% being females and 47% being male. Hyperleukocytosis was present in 24.2% and pancytopenia was present in 22.6%. Next slide, please. Coming to patient characteristics, distribution of ferritin, that is, those with high ferritin was around 37% and with low ferritin was around 63%, with median ferritin of 863 ranging from 112 to 5,160. Many believe that this ferritin is because of the transfusions, but the median number of transfusions prior to estimating this ferritin was only 1, ranging from 0 to 3. Next slide, please. 5 patients had translocation 821, 1 had inversion 16. The complete AML molecular panel was not done in our institution during the study period. Coming to FAB subtypes, most common FAB subtype was M4, being 45.2%. Next slide, please. The post-induction response rate, out of the 62 patients, 47, that is 76%, achieved post-induction remission. To each ferritin subgroup, in high ferritin, there were more failures, that is 39% failed to achieve remission compared to 15 in the low ferritin group, which was statistically significant also. Next slide, please. And for those who achieved remission, in the high ferritin group, 57% relapsed. Now, this correlates with the role of ferritin in the antioxidant pathway, and one reason may be this antioxidant pathway resulting in therapy resistance also, and that is why more number of lapse rate was seen in high ferritin. Coming to next slide. 11 patients died due to refractory disease, 6 due to relapse and progressive disease, and even 3 due to sepsis during consolidation. And all these deaths due to sepsis was seen in high ferritin, and this suggesting us that high ferritin subgroup they are more prone for infection also, despite achieving remission. There was no association for serum ferritin level with age, hemoglobin, total count, platelet, LDH, and albumin. Next slide, please.
30 seconds left, sir.
So to conclude, high serum ferritin level was associated with low remission and high relapse rate. And this is more relevant when we speak about in our setup where we don't have the molecular panels, and high ferritin levels, one third we cannot achieve remission, and for those who achieve remission, around half can relapse also. So we should tailor based on this. Thank you.
Thank you very much, Abhilash. For attendees, if you want to ask a question, please put it in the chat box. All panelists are welcome to raise hand and ask a question if necessary. Abhilash, now that you have established that there is a good prognostic indicator, if a new patient of AML comes to you with high ferritin, would you alter the treatment that you are giving to them?
Yes, sir. I will not change the treatment, but I will think twice. For example, if a patient in an elderly population between around 60 to 70, where we are in a dilemma whether to go with a radical inject or whether we go for a hypomethylating agent, and the patient is having a high ferritin level, then we are off with this study. We suggested that around 1/3 will not achieve remission, and those who achieve remission also half will relapse. So correlating everything like the performance status, if we have the molecular stratification if possible, that and with the high ferritin also, I may tailor my treatment.
Ferritin is also associated with hematological parameters, right? It has a role to play in iron status. Do you think that this is an indirect effect on AML or is it a direct effect?
That is why the median number of transfusions received in our patient population was only 1. And the iron overload resulting in high ferritin level, actually around 10 to 15 number of transfusions are required to create a high ferritin level above 1000. But in our study, we have seen that only maximum number of transfusion received was 3 before this ferritin estimation. So iron overload, the direct effect may be less, and we believe that it is because of the pro-inflammatory state created by the AML and other contributing factors.
Right, Prashant, what about you? Any questions?
Prashant, sir, you'll have to unmute your mic.
I have unmuted.
Sir has a question.
Yes.
Abhilash, tell me, was the TRM also higher in the high ferritin group? The TRM, the treatment-related mortality.
Yes, sir. Yes, that's why all the.
It was higher. Yeah.
In the high.
So I think this could be like an acute phase reactant only. I don't think this is related to transfusion. So this is upfront ferritin before you started treatment. So I think this could be useful. And in fact, I'll tell you our own institutional experience from All India Institute, my data of 300 odd patients. I found that, and it is real world data. I did not, exclude patients who were poor risk or who were dying of induction or whatever. I included everybody. And so I found that the cytogenetic risk stratification was not actually as convincing as in the Western data. So their population is much more controlled and they have lesser of disease burden. So such biomarkers may be more important for us actually, rather than totally blindly following the molecular risk stratification and the cytogenetics from the Western world. We also need to, and probably the data collection initiative going on from HCC on all AML inductions and AML data from, I think it's about 10-15 odd centers now. So we'll get such answers from that data, and we are also contributing to that data from our center. So good work, Abhilash.
Ashish, you said somebody had raised the hand.
Sir, I think Dr. Stalin had raised his hand.
Please unmute him.
Yes, sir. Sir, I want to know from Abhilash that is there any difference in the duration of symptoms to the presentation to the hospital? So if the disease process has been started a long ago in the patients with the high ferritin group, that may be the cause of high ferritin in them. So is the median duration of symptoms, the right from the start of the symptoms to the presentation to the hospital is the same in the both low ferritin and high ferritin groups?
Exactly, sir. Actually, we have assessed that because ours is a referral center. For many patients are after getting treatment from peripheries, they are reaching. So there was a lag period, and we assessed that, but like we couldn't find a statistical significance on the median number of days from presenting symptom to the diagnosis. That is at the point where we estimated the ferritin level, we couldn't find a statistical significance, even though non-statistical like there was a more number of days was seen in the high ferritin group, but it was not statistically significant.
Thank you very much, Abhilash. We'll move to the next presentation in alphabetical order. It is by Chinnu Jomi.
Good afternoon, everyone. I'm Dr. Chinnu Jomi. I'm a second-year resident in medical oncology at Manipal Hospital, Bangalore. The paper I want to present today is lenvatinib in combination with everolimus in metastatic renal cell carcinoma that has progressed on immunotherapy plus anti-angiogenic targeted therapy, a real-world experience. Next slide. So as we know that the treatment of metastatic RCC is evolving tremendously over the past few years, with the favorable risk patients according to the IMDCC being treated with either TKI alone or immuno-TKI combination, and the standard option for intermediate or poor risk patients being immuno-TKI or immuno-immuno combination. So the question arises as to what to offer to these patients once they start progressing on this first line setting. The available treatment options are cabozantinib and lenvatinib everolimus combination. Next slide. So the data about the presently approved second-line treatments are all coming from the TKI era treated patients, with various trials showing a median PFS of ranging from around 4.9 to 14.6 months and an objective response rate of 1.8 to 43%. Hence, the aim of our study was to determine the efficacy and safety of lenvatinib everolimus combination in patients with metastatic RCC who had previously treated with immuno-TKI or immuno-immuno combination. Next slide, please. Ours was a retrospective study which included patients with metastatic RCC who underwent treatment at our center between October 2018 to October 2021 and had disease progression with immuno-TKI and immuno-immuno combination. We started our patients on lenvatinib dose of 18 mg per day and everolimus dose of 5 mg per day. But due to poor tolerance after 5 patients, we decreased the starting dose of lenvatinib to 14 mg per day with further dose adjustments according to the tolerance of the patient. Next slide. We had a total of around 20 patients, which included 2 females and 18 males, and the median age of the population was 53 years. According to IMDCC risk stratification, we had 6 patients in the poor risk category and 14 patients in the intermediate risk category. Out of our patients, 9 patients received lenvatinib everolimus as a second-line treatment, while 11 patients received the same as a third-line treatment. Next slide. So when we analyzed the responses among our patients and recorded the best response according to the RECIST criteria, we found out that 11 out of 20 patients, that is 55% of our patients, had partial response, while 5 out of 20, that is 25%, had stable disease. 4 patients had a disease progression. When Kaplan-Meier curve analysis was done, then we found out that the median progression-free survival was 8 months and overall survival at 1 year was 55%. We had a disease control rate of 80% and an objective response rate of 55%. So what we really wanted to highlight here is that 5 of our patients completed treatment of 2 years without progression, with the longest follow-up being 34 months. And in this, 2 patients had disease progression with immuno-TKI followed by immuno-immuno combination, and even they showed a partial response as a third-line setting with this combination. Next slide. When we assessed the grade 3 toxicities according to the CTCAE criteria, we found out that 4 patients had hypertension, 3 had mucositis and diarrhea each, 2 had hand foot syndrome. Other lesser grade toxicities of note were dysphonia, fatigue, and skin rash. Among our patients, only 2 patients were able to tolerate lenvatinib at 18 mg per day, and the rest of them required a dose reduction. Next slide. The limitation of our study is that it was a retrospective study and it was a small sample size. We concluded that lenvatinib everolimus showed meaningful clinical activity in pre-treated metastatic RCC patients, even after disease progression with immuno-TKI or immuno-immuno combination. And as a regime, this is generally well tolerated with appropriate dose adjustments of lenvatinib. So the importance of our study was that in this present scenario where any ideal patient would receive an immuno-TKI or immuno-immuno combination in the first line setting, the available treatment options in the next line is either cabozantinib or lenvatinib everolimus. There is no studies to directly compare these two treatment options, and cabozantinib is only recently been launched in India, while lenvatinib everolimus is there for some time, and we have experience in giving this treatment regime. Hence, lenvatinib everolimus as a combination is a very good option as a second line treatment for patients progressing on metastatic patients with metastatic RCC progressing on immuno-immuno or immuno-TKI combination. Next slide. Thank you.
Thank you very much, Chinnu. Can you tell me, between the published literature and your study, what are the differences?
So mostly the published literatures come from the patients treated in the TKI era, the lenvatinib everolimus combination. After progression on immunotherapy, the literature are not very too much. So
Is there a difference or there is no difference?
So in among the published literature, the objective response rate which we saw was around 43%, while we had around 55%. And we had patients who had got the treatment for 2 years without progression, completing the treatment without progression.
How many of your patients were lost to follow-up or discontinued treatment before while they were on follow-up?
So, most of our patients, the highest toxicity grade was grade 3 hypertension, which was managed with aggressive antihypertensive measures and regular cardiology team involvement. So we didn't have any patients who were stopped on treatment.
And were there any lost to follow-up?
No, all these 20 patients were followed up, sir. There is no loss.
Okay. Okay. Prashant, over to you.
So, Dr. Channu, I really appreciate the study because it has relevance, like cost relevance to India mainly. So, would it be possible for you to publish the whole paper? And what kind of dose adjustments did you do? Can you clarify on that on lenvatinib?
So mainly the dosage was only for lenvatinib, sir. Everolimus 5 mg was tolerated well. So lenvatinib, initially we started with an 80 mg per day dose, but after 5 patients, due to the hypertension grade 3 and all, we had to decrease the starting dose to 14 milligram per day. Most of our patients tolerated this 14 mg dose quite well, but the lowest dose we had to give was around 12 mg. That was only for 2-3 patients. Otherwise, most of them tolerated 14 mg per day very well.
Thank you.
If there are no more questions, we can move to the third presentation.
So Lalit sir has a question, sir.
Please, Lalit, go ahead.
It is not a question, sir. It's a comment that we are using IO, in fact, in upfront setting of metastatic RCC quite often. So after challenge with IO, this remains very good drug, and we also started using the same combination, and patients are very happy, healthy, OPD-based treatment, and very well tolerated. We don't have 20 cases right now, but we are happy with the combination. And thank you so much, for your excellent presentation.
Thank you,
Great,
sir.
Lalit. So, Chinnu, you have validation of your study from India as well. Congratulations.
Thank you, sir. Thank you, sir.
Okay, we now move to the third presentation in alphabetical order. It is by Sri Gopal Mohan. Unmute yourself. Yeah.
Good afternoon, respected judges and delegates. I'm Sri Gopal Mohanty. Will be presenting my study, phase 2 randomized study of carboplatin plus capecitabine versus 3-weekly cisplatin in locally advanced inoperable head and neck squamous cell cancer patients undergoing definitive chemoradiation. Next, please. So, as we know, definitive chemoradiation using 3-weekly cisplatin is the current standard of treatment for inoperable locally advanced head and neck squamous cell cancer. And due to higher rate of toxicities associated with high dose cisplatin, like nephrotoxicity, electrolyte imbalance, vomiting, ototoxicity, neurotoxicity, significant proportion of patients remain ineligible for this 3-weekly cisplatin. And if you look at alternate regimen like carboplatin 5-FU, which is also category 1 recommendation by NCCN, in our average Indian setup, this continuous infusion for 4 days is quite difficult to reproduce. and longer hospital stay, and also associated toxicity. If you look at other regimens tried in other trials, like carboplatin or cetuximab, all are not coming equivalent, similar efficacy, and also like for cetuximab more toxicity, and for carboplatin efficacy also not that good like 3-weekly cisplatin. Even weekly cisplatin also from Tata study, it is not equivalent to 3-weekly cisplatin. So oral, in the other side, we see oral capecitabine has a good tumor selectivity due to high activity of thymidine phosphorylase in hypoxic tissue environment, and reduction to potential effect of capecitabine by stimulating this enzyme. And capecitabine also has shown some good reduction sensitizing property when used along with cisplatin in many phase 2 trial. And but there is a phase 1 trial with Thomas et al. They tried this carboplatin with capecitabine low dose 850 mg, and they found that median tolerable dose was 850 mg per meter square. Based on that finding published in Anti-Cancer Research in 2009, based on that study finding, we conducted a randomized control study to compare this carbo-capecitabine combination with 3-weekly cisplatin. Next, please. So our study phase 2 double-blinded randomized control trial registered in CTRI and conducted at Department of Medical Oncology, Radiation Oncology in Kilpatrick Medical College, Chennai. Study duration 2 years from August 2020 to August 2022. Study participants are histologically confirmed squamous cell cancer, oropharynx, hypopharynx, larynx, TNM stage 3-4, ECOG performance status 0-1-2 with adequate organ functions, hemoglobin 10%, total count 4,000, platelet count 1 lakh was taken cutoff, age group 20 to 69 year, not received any prior treatment. Underwent block randomization 1:1 into the experimental control. Experimental arm was concurrent chemoradiation with carboplatin AUC 1.5 weekly plus capecitabine 850 mg per meter square per day on radiation days. Versus in the control arm, concurrent chemoradiation using 3-weekly cisplatin 50 mg per meter square per day for 2 days. Our primary endpoint was objective response rate and progression-free survival investigator assessed. Secondary endpoint was grade 3 and higher toxicity, treatment interruption rate. Next, please. So we can see here baseline patient characteristic. Patients are equivalently distributed to arms as per the age, sex, performance status, smoking, tobacco history, comorbidity, stage, site, and grade. Next, please. If you look at the primary endpoint objective response rate, the overall objective response rate was 97.5%, including complete and partial response. And in the control arm, it was 94.8%. If you look at complete response, there was 15% added increased complete response in the experimental arm, which was 57.5%, whereas in control arm, 42.1%. 1% progressed in the control arm, but there is no progression in the experimental arm. Next, please. Looking at the progression-free survival, median PFS at the median follow-up 6 months was 6 months in the experimental arm, whereas 5 months in the control arm. Although p-value not significant at this interim finding of 6-month follow-up, we can see some tail and some separation of curves. So we are waiting for the final report. Next, please. And looking at the treatment characteristic in the experimental arm, in the weekly chemotherapy arm, we got patients got median 6 cycles of chemotherapy, whereas in the control arm, 2 cycles of 3 weekly chemotherapy. Median radiotherapy dose was 66 gray in both the arm. Next, please. We can see at the grade 3 and higher toxicity, most common toxicity in the experimental arm was mucositis, which was only 20%. Next common was neutropenia, grade 3 higher neutropenia, 17.5%. Remaining all toxicity we can see here in the experimental arm was less than 10%. Whereas in the control arm, most common mucositis 68.4%, then nausea, vomiting 65.8%, 55.3%, then neutropenia, nephropathy, fatigue, anorexia, electrolyte imbalance, all we can see significantly higher compared to experimental arm. Next, please. There is no treatment interruption in the experimental arm. Control arm, 3% withdrawal treatment and 11 delay for chemotherapy, 10 delay for radiation. It was significant. Next, please. So concluding our study, carboplatin plus capecitabine was found as an effective chemotherapy regimen with lesser toxicity compared to 3-weekly cisplatin. So it is our a pilot study. So we want a phase 3 randomized study to get a proper validation of our finding. Can be considered as an alternate chemotherapy regimen in chemoradiation for inoperably locally advanced head and neck squamous cell cancer. Thank you.
Thank you, Shri Gopal. Did you submit this protocol to the ethics committee?
Pardon, sir?
Who submitted the protocol to the ethics committee? You did it? What was the time interval between the start of the writing of the protocol and the approval by the ethics committee?
Sir, because of practically because of COVID issue,
yes.
There was a 1 month delay, sir.
Okay.
And,
any ethical or scientific questions were asked to you?
Sir, actually, initially I was not sure about the continuation of the study and the duration of follow-up because of the COVID time. So it was very challenging. So initially, I was looking for the objective response rate. Then after ethical meeting, they asked me to pick the PFS also into the primary endpoint. So, so I took PFS also as a co-primary endpoint, sir.
I'm very happy that you took the PFS.
Yes, sir. I was initially I was looking for that, but because of COVID, I was thinking whether it will be practically possible or not.
Okay.
Somehow, sir, we are proceeding.
Over to Prashant.
So your data is interesting, and you've done a good study. Only thing I want to ask you is how many, what's the percentage of patients who completed both treatments, like compliance?
Yes, sir. Yes, sir. So in the carboplatin capecitabine, sir, 100% completion of treatment, sir. And of those 100 patients, sir, BSA 1.1 only, 50-year lady with CL larynx, clinical T.
No, I'm asking on the other arm, what percent were able to
side,
complete?
yes, sir.
How
So
many?
other 3%. 3% would do treatment, sir, in the control arm.
So what percentage of patients were not able to complete in the control arm?
So it was almost sir, 7%.
7% patients are not. So tell me one thing, with this 3-weekly cisplatin, did you face more challenges? Did you ever consider that you would, if you use a weekly regimen, the cumulative dose of cisplatin delivery would be more?
There are studies showing that more
Just,
the cumulative dose of cisplatin.
Because if out of 3 you leave 1, then the cumulative dose really, your fall back on the cumulative dose.
Sir, for 3
But
weekly
out of 7 or 6, if you leave 1, the cumulative dose is still reached.
Yes,
The
sir.
desirable dose. Tell me.
The cumulative dose, sir, for the median 2 cycles, and most of our 3-weekly cisplatin completed 2 cycles, sir, except those who didn't continue. Remaining all patients, sir, completed 2 cycles of 3-weekly.
Okay.
3 patients completed 3 cycles, sir. And
thank you. Good.
The patient, there was a delay, sir.
Okay.
Thank you. Thank you, sir.
Great. Thank you, Sri Gopal. Any other questions? Okay. So the 3 shortlisted ones have presented today, and they will get either first, second, or third award. In addition, we are going to give a certificate of appreciation to 2 other people who were on the wait list and who really did a great job. But there was a fine small distinction between the first 3 and the 2 waitlisted ones. So I'll just share the names for the waitlisted ones who will get the certificate. One was Aparajita, who spoke about system errors in gynec radiotherapy onboarding. And I think this is very important for the Indian context, as Prashant and I had discussed. The other one who will get a certificate is Sindhu Kilaru, whose data was on PDL1 and head and neck squamous cell carcinoma. So I congratulate both of them on behalf of the judges, and we will inform the winners of the first 3 winners shortly. Thank you very much, and back to the organizers for the next session.
Thank you so much, sir. We'll now move on to our next session, which is on colorectal cancer. And it gives me great pleasure to introduce our 2 chairpersons. If I can request Lalit Mohan Sharma, sir, to please introduce our 2 chairpersons. Sir, are you there?
Yeah, Kashish, I'm here. So thank you, Parikh sir, and thank you, Kashish and team. So our first chairperson is Professor Btk Kapoor sir. Dr. Kapoor is well-known figure in the field of pancreatico-hepatico-biliary surgery. He has been ex-head of the department of the same department in SGPGI Lucknow, and one of the top persons in world, in fact, in the GB area, especially gallbladder stones and gallbladder cancer and other areas. We are proud to have Professor Btk Kapoor here with us. Another chairperson is Dr. Ankur Punia. Ankur is senior consultant in the Department of Medical Oncology at Mahatma Gandhi Medical College Hospital in Jaipur. Over to you, Kapoor sir, please.
Thank you, Dr. Lalit, and thanks, Icon, for inviting me. I would request my co-chairperson, Dr. Ankur, to kindly conduct the session.
Yeah, thank you, sir. So for the next talk, which is on the microsatellite instability testing, whether it's still the gold standard for targeted therapy in colorectal cancer, I would like to invite Dr. Rajiv Vijaykumar. So please, over to you, sir.
Good afternoon.
First, at the onset, I'd like to thank the organizers for inviting me for this session. It was a very nice presentation by the PG students. Congratulations to them. And congratulations to Parikh sir and Dr. Prashant for conducting it very well. Hello, are my slides seen?
Not yet, sir. We can see that you started the screen sharing, sir, but we can't see the slides. Now we can see the slides. Please go ahead.
Seems to. I'm sorry that there's okay. Fine. I'm Dr. Raje. I'm a medical oncologist from Bangalore. So the topic that we have right now is microsatellite instability. Is it the gold standard for choosing targeted therapy for metastatic colorectal cancers? So we are all aware that we have multiple targets for colorectal malignancy. This topic deals with microsatellite instability. What would be the best method? Now, what are we aware of? We are aware of immunohistochemistry, which we all commonly use. We use tumor mutation burden. We use PCR method. Then we use PDL1. What should be used? Is it a combination of everything, or what is the best for starting immunotherapy? So just for the sake of introduction, MSIs or microsatellites are also called short tandem repeat sequences, consist of repeated sequence of 1 to 6 nucleotides. They're widely distributed and located near the coding region and may be located in other regions like introns or non-coding regions. The normal tissue DNA repair system called the mismatch repair, it can correct the process of DNA replication errors. Due to the lack of these mismatch repair genes in the tumor cells or defects in the process of replication repair, there are certain gene mutations which increased. MSI is an important factor in the occurrence and development of the tumors. In line with the frequency of MSI, we can have high MSI, we can have low MSI and MSI stable. So this is just a small diagram I just put to just showcase what are the microsatellites. We have mini satellites and macrosatellites. This is depending on the number of base pairs. Microsatellites, like we've told, is between 1 to 6. So now this is again just another cartoon showing that you have a DNA mismatch repair intact, and if there is a deficiency, it keeps changing as and when there is a change. So what are the, how do we identify microsatellite instability? Precisely that we know that there are 3, there's a 4th one as well. So we can use immunohistochemistry, which is commonly used, and it has an accuracy of up to 90 to 95%. The PCR is the gold standard, which has an accuracy of around 100%. And we have next generation sequencing, which is we are using on a much more routine basis these days. And then afterwards, you have single molecule molecular inversion probes, or SMIPs. These are also, they come to around 95 to 96% is the accuracy of these. Now for all of us, just a reminder, we know between the right side and left side colon cancers, it's well known that microsatellite unstable tumors are seen in around 20 to 25% of 15 to 20% of right-sided colon cancers. It's seen in less than 5% in left-sided. So 15 to 20% in the right side. So then I was going through different papers to identify how to actually address this. What is the best? Then I realized that ESMO's done a good job at this as well. What they have done is they have pooled in a large number of, they've done a meta-analysis and meta-analysis of different meta-analysis they have done as well on this. So to define the best practices to implement the detection of deficient MMR tumors in clinical practice, ESMO has made some recommendations. Well, they put forth some definitions related to the concept of microsatellite instability or deficient MMR. They have enlisted the methods of MSI MMR testing. They have also spoken about a very important entity, relationships between MSI, tumor mutation burden, and PDL1 expression. So now IHC for the mismatch repair proteins MLH1, MSH2, MSH6, and PMS2. This is the first action to assess microsatellite instability. It came with a very strong agreement in the consensus statement. The second method is by doing PCR-based assessment of MSI, where you use 5 microsatellite markers. We will come to that. The third option is using NGS, where you can couple microsatellite instability and tumor mutation burden analysis as well. So this becomes a much more good tool, so that you have 2 markers that you're getting, MSI and TMB, when you're using NGS. So this is very, very important for selecting patients for immunotherapy for common or rare cancers belonging to the spectrum of the Lynch syndrome. We're all aware of what the Lynch syndrome cancers encompass. Now, this is a very complex interplay between MSI, TMB, and PDL1. We will look at that as well. So let's look at some definitions. What is the definition of a microsatellite instability? It is a condition of genetic hypermutability resulting from defective DNA MMR, that is mismatch repair. It's characterized by clustering of mutations in microsats, typically consisting of repeat length alterations. The presence of MSI represents the phenotypic evidence that MMR is not functioning normally. So it is a surrogate marker. MSI is a surrogate marker that MMR is not functioning normally. What is the definition of a DNA mismatch repair? DNA mismatch repair is a highly conserved mechanism used to restore DNA integrity after occurrence of mismatching errors. So what are the 4 genes? MLH1, MSH2, MSH6, and PMS2. So there are, in these, we have primary and then secondary partners. So the MLH1 and PMS2 are one partner, and MSH2 and MSH6 are the other partner. So inactivation of one of these genes. So if you have MLH1 or MSH2 inactivation, PMS2 and MSH6 get inactivated too. So now it's important to know the concept of primary secondary partners. So mutations in MLH1 are associated with IHC loss of both MLH1 and PMS2. They're like 2 to tango. And mutations of MSH2 are associated with IHC loss of both MSH2 and MSH6. So one can't be without the other. It's like 2 lovers with each other. So that's the reason why I'm just harping on the primary and secondary partners. So, but if MSH2 and PMS2 and MSH6 are like Bevafa partners, mutations occur in genes of the secondary proteins, that is PMS2 and MSH6. The heterodimers may remain stable and there is no concurrent loss of the partner protein. This is because this role of PMS2 and MSH6 can be taken over by MSH3 or PMS1 as well. So therefore, it doesn't matter. So primary thing is, we need to remember the primary partner MLH1 and MSH2. These are the 2 important guys. Now, what is the definition of a MSI deficient MMR tumor? A deficient mismatch repair tumor is a tumor that accumulates thousands of mutations, particularly clustered in the microsats and consisting in repeated length. So what is the consensus recommendations by ESMO on MSI testing? For the majority, both IHC and molecular tests were utilized to define microsatellite instability status. Where immunohistochemistry was used, all the 4 MMR proteins are always tested in these studies. When PCR-based molecular testing was employed, one of the 2 panels, each comprising 5 microsats, was used. In the first panel, you had 2 mononucleotide and 3 dinucleotide repeats. That is BAT25. We don't need to remember the names, but just you need to know that there are 2 mononucleotide and 3 dinucleotide. The other, that is panel B, had 5 poly mononucleotide repeats. So with these, you could use it to, like, it's like we use like SP263 and SP142, something similar to that. So you through these panels, you would be able to identify whether there is a MSI instability. MSI was defined as loss of stability in 2 or more of the 5 microsatellite markers. So now we realize that there is a lot of variations in methods used in clinical trials. All of them were different, having different time frames. They were all using different standards. So there was a fall in the standards. There was no exact equanimity. So even the IHC nor the molecular tests were indicated as the preferred methods. This is what we found in the whole meta-analysis. We didn't know what is the exact method, like similar to what in clinical practice, which is the best method. So finally, after going through sorting this out, ESMO came with a recommendation A. That is, the first method for MSI testing is immunohistochemistry. So again, we use the four markers, 4 proteins, and this is a very strong grade of consensus. It was 8.7 by 10. So this use of IHC for the 4 MMR proteins is required to assess deficient MMR in any sporadic cancer belonging to the spectrum of cancers found in Lynch syndrome. This mentioned specifically only for Lynch syndrome types of cancers, that is immunohistochemistry. For the others, NGS is preferred. The B recommendation is, that is, microsatellite PCR molecular testing is indicated whenever there is a case of indeterminate IHC results. Like suppose you have the secondary partners being affected, sometimes you might miss, it might come as false positives or false negatives. So even if you have a disagreement in the interpreting the IHCs, go ahead and do the PCR. So again, this is the same thing. We have the two panels for the PCR channels. So now an important thing, what do you call it? Do you call it MSI high, MSI low, MSI stable, like I had given in the initial graph, or do you call it stable and unstable? So the terms MSI high or MSI low should be abandoned. We should be calling them as MSI stable or MSI unstable tumors. That should be that is what the recommendation in the revised Bethesda guidelines for colorectal malignancies. So they also saw that almost 10% of patients had been enrolled in immunotherapy trials and experienced failure due to false positive, deficiency MMR or MSI PCR results as assessed by local labs. Hence, the recommendation is to use both IHC and PCR to assess the eligibility to treatment with immune checkpoint inhibitors in this. So in our practice, what did I understand from this? IHC is good, PCR is also good. If one is for prognostication, the second one is for I am starting a patient on therapy, it is better to do both and have concordance between both. So therefore that solves our issue. The third recommendation from the ESMO guideline was regarding NGS. So it represents an alternative molecular test to assess the microsatellite instability. The biggest advantage is, along with coupling the macrosatellite instability, you are also able to determine the tumor mutation burden. You can identify different targetable mutations like KRAS, BRAF, BRCA1, BRCA2. So this NGS-based MSI testing has the potential to become the method of choice of all tumor types in the future, including cancers in the Lynch and cancers out of purview of the Lynch syndrome. This has a very strong consensus grading of 9 out of 10. Very interesting thing I found was relationship among MSI, PD-L1 and tumor mutation burden. Is there a potential association? How can we use these 3 markers to choose patients for immunotherapy? So then there was a mega meta-analysis. Multiple 17 articles were sourced, they were identified, and which had already pulled in various studies. So and then out of these, around 14,000 is a massive 1,48,000 patients were studied. So the data of all these patients was accrued, and colorectal cancers accounted for almost around 60% of these patients. So here they studied MSI by IHC, PCR, and NGS in different proportions. Tumor mutation burden was studied by whole exome sequencing in 29%, and now the recent multi-gene panels in around 70%. So this data is all pretty fresh, last 3-4 years. The TMB high, if you have more than 17 to 20 mutations per MB, then it was considered to be high TMB. And PD-L1 was assessed by SP142 in 47% of the patients. Overall, we had around 4,000 patients who were positive for at least one of the analyzed biomarkers. The simultaneous expression of all the 3, that is tumor mutation burden high, high MSI or unstable MSI, and PD-L1 expression was observed in around 12.8 or 13% of colorectal cancers when compared to around 3% in all the cancers. So imagine, so if you have to have all 3 high, this concordance is only around 13%. This is something very, very interesting. Although we know, but the value is like, it's very small value. So, and they found that if you take only TMB high and MSI high, then it was seen in around 44% of the colorectal cancers. So now this is just a diagram which shows this. So here you can see that this is for all the cancers. You can see that all the 3, PD-L1, MSI high, and tumor mutation burden is seen all together in this Venn diagram, only 3% of patients. This is colorectal cancer as an entity. It's coming around 12.8. Maximum was seen in the esophagogastric, that G junction tumors. It is seen in around 14% of patients. So I found this to be very, very exciting. So I've just zoomed in for our viewers for colorectal, because we're talking specifically about colorectal cancers. That is PD-L1, MSI high, and tumor mutation burden high is seen in around 13. The concordance is seen in around 13% of CRCs. I found this table to be very useful and exciting as well, where the prevalence of microsatellite instability in different cancer types using the different methodologies. Here we can see that in colorectal cancers, it's around 17%. That's the prevalence. And the very interesting thing is like this table also showcases which subtype, histopathological subtype. If you find, you can definitely push your pathologist to ask to get the MSI testing done. That is medullary, mucinous, and poorly differentiated neuroendocrine carcinomas of the colorectal. We'll have to, these are the histopathological surrogates. I just put across the other cancers as well. So finally, what are the perspectives that we get? Due to the recent successes of IO in several cancer types, clarifying the MSI landscape in cancer is an urgent clinical necessity. The relationship of MSI with tumor mutation burden and PD-L1 expression is different in different neoplasms and is completely varied. So you can't actually say that TMB in one high in one actually means therapy. MSI unstable in most cancers means response to immunotherapy, but whether TMB high and PD-L1 positivity, whether it is actually a surrogate marker to say that they will respond, it's a big question mark. For MSI tumors, further analysis for tumor mutation burden or PD-L1 expression is not required to receive immunotherapy. I found this to be very interesting. If you find MSI, you don't need to do TMB, you don't need to do PD-L1. That's sufficient. So what do we gather at the end? IHC currently represents the first test to determine deficient MMR that's associated with microsatellite instability in cancer belonging to the spectrum of Lynch syndrome. Knowing its advantages and limitations is the most important aspect, because we know that we can have some false positive and false negative reports as well. So then, like we mentioned, we can club both the IHC as well as PCR in case we have a doubt. And as and when feasible and when affordable, NGS is the next potential, because not only do you get MSI, you also get tumor mutation burdens and some other targetable mutations as well. So an estimation of the TMB can be made with targeted panels. So you don't have to do whole exome sequencing, cost, time, everything comes down. And this seems to be the most promising tool to test MSI in the near future. And very interesting thing, also circulating tumor cell study by NGS, you can help monitor and predict response to immuno-oncology as well. This is another thing, the recommendation which has been given. So the combination of TMB, MSI, and PD-L1
Sir, can I request you to conclude, sir? We're running short of time.
Yep. So this is the last slide. So they predict a higher rate of response to immunotherapies. It's possible to have TMB high in absence of MSI, whereas MSI high with TMB low is rare. So this is what I would like to, apart from this study, this is what I've understood, that if you have MSI high, you don't need to do PD-L1 and you don't need to do tumor mutation burden. So the gold standard right now for microsatellite instability, the methodologies are we do by immunohistochemistry and PCR, and if feasible, get an NGS done. You get a lot more information with that. PD-L1 and tumor mutation burden we need to see how we can include them in the algorithm. Thank you.
Thank you so much, sir. I now request our chairperson to please introduce our debater.
Yeah, Dr. Ankur, please.
Yes, sir. So now that was a very informative talk and a very simple and crisp talk about the importance of MSI. Thank you, Dr. Raje. So now next we are going to have a debate about the role of short course chemoradiation, whether it's a standard of care in the T3 rectal cancers. So for first, for the favor of this short course chemoradiation, Dr. Indu Bansal. Over to you, ma'am.
Hello, good afternoon, everyone. Can you let me share my slides? Give me a minute. Is my slide visible?
Yes, ma'am.
Okay. Yeah. So thanks everyone for having me here. And I'm going to speak in favor of is less enough or is more better. So we all know that short course in T3 carcinoma rectum has proven its role. And in next few minutes, I'm going to prove it. Okay, so we all eat lice when our hearts are hungry. We need to look at the obvious, the subtle, the hidden, and the unspoken. And I want Dr. Bharat to unlearn the rules today. So the flow of my talk is going to talk about how long course radiation has not proven to be better than short course in T3 rectal cancer, either in improving survival or in preventing local or distant recurrences. And the main purpose is to preserve the function, and at the same time, we have to minimize the morbidity. So we all know that prior to TME era, 10 to 40% patients required permanent trauma, even for tumors in the middle rectum. And pre-op short course radiation reported local control rates of 20 to 30%, even with surgery. Pre-op long course RT improved the local control, but no disease-free survival or overall survival. So these are the differences between short course radiation and long course radiation. We all know them. The BED for early effects is almost the same. For late effects is almost the same. Earlier, we used to think that long course radiotherapy definitely leads to better downsizing and downstaging. But now it has been seen that for short course, it was not seen until the surgery was delayed by 10 to 12 weeks or chemotherapy is incorporated. So with incorporation of chemotherapy, even this disadvantage of short course is in favor of short course. We cannot give concomitant chemotherapy with short course because it is not proven to be benefit, but added to toxicity. Acute toxicity can be obscured if immediate surgery is not done, and late toxicity is almost the same. Earlier, we used to think that long course radiotherapy leads to decrease in distant metastasis rate, but actually addition of chemotherapy is helping in short course also. So we used to traditionally think that long course radiotherapy leads to early, because if we are losing it, it leads to early partial treatment of micrometastasis. It may prevent repopulation during RT. There is potential for organ sparing or curative resection or use of brachy boost, and it avoids surgery for resistant progressive disease. But the disadvantages was that because it leads to delivery of less than full systemic chemotherapy, delays full systemic chemotherapy by 18 to 20 weeks, and at the same time, it is very, very expensive. While short course has an excellent compliance, it is cost effective, it allows early and effective chemotherapy after surgery, and if combined with chemotherapy, it improves the local control, can be used even for elderly or frail patients. It's a preferred protocol during COVID, and local control, disease-free survival, overall survival, all are same as that of long course RT. So let's see that. So I want to ask my worthy friend, does long course RT actually lead to better local control, disease-free survival, overall survival, or better sphincter preservation rates? I would say, I'm sorry, that's not the case. If we see all these trials, whether the Swedish rectal trial, ductal colorectal cancer trial, MRC, Polish rectal cancer trial, TROG trial, all of those have seen that the local recurrence rates are to the tune of 10% with short course. Distant recurrence is to the tune of 30%, and overall survival rate is to the tune of 70%. In fact, in Swedish trial, it was shown that there were equal effects even for mid and lower rectum. Now let's see, does long course RT due to addition of concurrent chemotherapy leads to better distant metastasis control? So let's see the long course trials. So these are the EORTC trial, FFCD trial, NSABP trial, and CO trial. All these trials, they are showing that local control rates are to the tune of say 20%, or in certain groups it's 10 to 20%. Distant recurrence rate is almost the same, 30%. Overall survival is still the same. So if we see both the trials, the short course and the long course, the results are almost the same. Long course was always preferred because we thought that it leads to better pathological complete response. But does it really lead to less API rates or less toxicity? That's what I want to ask my worthy friend. So we have seen that the pathological complete response after surgery and short course RT within a week is not seen. With delayed surgery, it is seen in 11 to 11.8% of the patients. In Polish trial, it was seen in 16% of the patients. And after pre-op long course RT, it is seen in 15 to 20% of the patients. But if we see the latest Rapido trial, which has T4 patients, in those cases, even with short course and combination of FOLFOX, the path response was 28.4% versus 14.3% with long course RT. So even in this path complete response rates, long course is not favorable. And in fact, with this combination, non-operative management or wait and watch policy is possible in some patients. There have been different ways which have been used to improve the pathological complete response rate. More intensive chemotherapy regimes concurrent to radiation is oxaliplatin, irinotecan, bevacizumab, but they have not proven to be beneficial. Addition of targeting agents to concurrent chemoradiation, escalation of radiation doses, or the use of altered fractionation as hyperfractionation, sequential use of chemoradiation. But I think the only thing that has worked is total neoadjuvant therapy. So let's see this trial, TROC trial, which was specifically for T3 rectal cancers. And there they compared short course RT with long course radiation. 3 or 4 field techniques were used. And here you can see that the graphs are absolutely hugging each other for recurrence-free survival or for overall survival. And in fact, the late toxicity was 4.5% in short course versus 5.8% in long course. For distal tumors, the local recurrence rates was seen in 6 out of 48 patients in short course versus 1 in 31 patients. So maybe for a distant tumor, long course might be a little preferable, but if we see the distant mets or overall survival, they are same for short course versus long course. So pathological complete response may be better with long course, but APR rates are same even for distal tumors. Now let's see, does delay in, so actually long course is not helping in pathological complete responses, but what is helping is delay in surgery. So let's see that. This was first proven in Stockholm 3 trial, where they had these 3 groups, 25 gray followed by surgery within a week, 25 gray followed by delayed surgery, or 50 gray. And in fact, they closed the long course therapy arm after some time, and it was not analyzed. So what they realized was that if you delay surgery after short course, then the DWARC regression score was higher. It was 14.9% compared to 2.6%. Pathological complete response improved to 11.8%. The complication rates remained almost the same. So
Ma'am, 1 minute left, ma'am.
Yeah. So this has been proven in effect of interval between surgery and radiation among all these trials. So what the lessons learned have been that downstaging is more in short course RT if interval for surgery is more than 1 week. Toxicity is more if surgery within a week. Long course may help in sphincter preservation is same between 7 and 11 weeks, but high morbidity if interval is more than 11 weeks. So a Polish trial also showed no difference in local control, disease-free survival. In fact, distant metastasis also seen because of addition of chemo in short course RT, and there were no added late complications. So does the short course RT with addition of chemotherapy and delayed surgery yield better results? Yes, definitely. But it's very, very important. Or with EL1. And even in this study, they realized that short course radiation with chemo and delayed surgery useful even for advanced disease without adding to any toxicity. So these are the various trials. The Stellar trial also showed that the pathological complete response was better with short course versus long course. And so have been the OPRA trials also. So I want to ask my friend, does long course RT has better toxicity profile? It has not been proven because now we are using IMRT. Is the superiority of long course supported by any of the standard guidelines? So if we see these guidelines, St. Gallen's, they recommend long course radiation only for high risk cases. If we see the ESMO guidelines, they also recommend long course radiation, even CRT, even for advanced disease, T3 with any MRF involvement, CT4B, if levators are threatened or lateral nodes are positive.
I think you will have to conclude.
Just finishing. So in rest of the cases, short course or chemoradiation, they are equal. Same with the ESMO guidelines. And NCCN guidelines recommend both. For frail patients, definitely short course is better. Short course is much better and cost effective. So the only group where my friend can add value with long course RT is CT3 with MRF involvement.
Okay, no, I think I'll have to cut you
last slide,
because the organizers are asking us to request you to stop.
So I'm done.
We have to give time to the other.
I rest my case. Yeah. I rest my case. Thank you.
Thank you so much. And over to Ankur, sir, to introduce our.
Yes, sir. So now, for speaking against the short course chemoradiation, I would like to invite Dr. Bharat Patodia. Over to you, sir.
Yeah.
So thank you very much. Since the time is less, I will not waste too much time in presenting too much guidelines, which are already everybody is aware of. And I will keep my case limited to the slides which are worth to mentioning it. So few slides are definitely overlap. So this slide madam also presented, and as a part of disclaimer, I am a medical oncologist, not a radiation oncologist. And madam herself is saying that the benefit of many the short course, since they received chemotherapy, probably the difference in the outcomes are not there because of the chemotherapy. So that is the medical oncology part. Anyhow, coming to this slide, which Rapido madam has quoted, Prodige madam has shown that the results are quite comparable, whether you give a short course or a long course. In this, if you see, the Rapido trial has taken advanced cases, so T4, T4B, and not exactly T3, which is the topic of today's question, today's debate. So T3 with node positivity or CRM threatened, that is not exactly answered there. Plus, what are we achieving here in Rapido? So we are saying that rate of distant metastasis or distant disease-related treatment-free were lower in short course. Okay. The rate of loco-regional failure was comparable in both the arms. So I can offer both without having too much of T3 in the trial. The rate of pathological complete response was higher in short course, agreed, but overall survival is same. And chemotherapy, you will be receiving chemotherapy. So are the surgical outcomes are better? No. Are the resections are same with short course or long course? And there is, madam has quoted data regarding the toxicity, but short course toxicity sometimes in some patient is actually higher. Now, coming to the Prodige 23, where TNT was total neoadjuvant therapy was studied, they have not offered short term. They have offered 50 gray per 2 grays per fraction, along with the chemotherapy. And what we are trying to achieve, if it is T3 and clear CRM, are we trying to achieve organ preservation, or we are trying to achieve with the tumor reduction? So maximum experience is with long course radiation, where we have increased pathological response and disease-free survival. And if the CRM is positive, we want the maximum reduction where long course chemoradiation along with the chemotherapy is being practiced. Now, what is more important is we should know our tools and which enemy we should use. If it is an early T3, CRM not involved, node not positive, then why to go extra? And if it is an advanced stage T3 where we want a maximum tumor reduction, it is important to give an adequate therapy because the cancer specific survival reduces drastically. Now, coming to the conclusive slides from my side, this is a recent publication where this particular question of today's comparing the neoadjuvant long course chemoradiotherapy versus short course radiotherapy is directly being studied, and they have included T2 node positive or T3, T4 patients. And what they found is no difference is observed in DFS or OS. Now, does madam want to offer organ preservation at present? Because at present organ preservation is basically under trial. Clinical practice we really cannot offer upfront. So with this limited useful slides and data, I rest my says that patient who are pure T3, no high risk features, probably yes, we can offer short course as madam says, but if patient are at high risk, then it is a long course along with the medical oncology chemotherapy.
Okay. Am I permitted a rebuttal?
Yes, please. 1 minute.
So thank you so much, Dr. Bharat, for making my work easier. And you also said that, I think the one mistake that you did was you clubbed all T3 together. They are not the same. T1, T3, A, B, C, and D all are different. And if Rapido trial could show benefit of short course, even in advanced cases than T3, T4, then definitely it is going to be beneficial for younger cases. So all the slides have clearly shown that for T3, B, C, if there is CRM is not compromised or there is no extra MBI, then whether you use short course or long course, both are equal. But if you want to give better results in advanced cases, then short course and early initiation of chemotherapy is the key. Total neoadjuvant. So TNT is not for all T3, and we cannot work without my medical oncologist. And I think it's
thank you very much,
where we
madam,
have
for
to join our
acknowledging my
hands
part.
together.
Also, I was feeling so odd because everybody is radiation oncologist and I'm the only medical oncologist here.
So we are handing over the stage to you by giving a short course radiation and handing over the case to you. In fact, so we have to work together.
We have to work together and know our enemy.
Okay, yes. Debate apart, Dr. Indu, may I ask that in which cases you will give a long course?
Okay, so I put that in my last slide. The only situation where I would be preferable, I would be inclined to give long course, if you ask me, would be if the CRM is close, less than 1 millimeter, it's an advanced case, levator and eye muscles are involved, or if there is a lateral pelvic node involvement or extramural venous invasion. These are the situations where I would prefer long course. For all the rest cases, short courses is equally good in terms of local control, disease-free survival, or recurrence-free survival.
And Dr. Bharat, if the results of short course and long course are by and large equal, then why unnecessarily expose the patient to more radiation for a longer duration?
Sir, the group, as we have discussed, if it is a long course, if it is a CRM threatened node positive, then definitely I'll prefer a long course followed by chemotherapy.
That Dr. Indu also has agreed.
So in such situations,
other cases, in those cases who are suitable for both regimes, where equal results have been shown, on a philosophical note, why expose them to more radiation for a longer duration of time?
True, sir. I'll not, for the sake of debate, I'll not go for our center, which is the AJ hospital. We are actually following short course because majority of our patients are from Northeast Bengal side. So we want to cut down their stay. So we have actually shifted our therapy.
Thank you, Dr. Bharat. So you spoke in my favor. Thank you.
No. This is not
debate apart. Science has to come forward. So just a food for thought for all radiation and other oncologists. That is this philosophy that a short course radiation gives almost as good results in a good number of cases. Is it going to change our radiotherapy regimes in other cancers also? Just a food for thought for everyone. Dr. Ankur, any points, any comments?
Sir, before Dr. Ankur says, can I ask Kapoor sir a few questions, sir, if you allow me?
Yes, please. I'm not the speaker though.
Thank you so much, sir. Wanted to ask you, sir, about the impact of all these molecular markers.
Yeah, I saw that question you posted in the chat.
On surgery, in fact, do you feel any difference?
No, it's not going to make any difference as far as the primary treatment is concerned, because in colorectal cancers, as we all know, even in presence of metastasis not only in the liver, but even in the lungs, the primary treatment still remains surgery. And that is the primary intent is, of course, to achieve a local R0 resection. But even if that is not possible in majority of the cases, even a non-curative palliative kind of resection is indicated. So it's not going to change our decision as far as the primary treatment is concerned. But yes, once we have done the surgery, either as a intent to cure or as a palliative procedure, the adjuvant treatment definitely, as Dr. Rajiv pointed out, has to be individualized. It has to be targeted. I presume that in our clinical practice, IHC probably would remain the gold standard for some time. The other more sophisticated, more expensive investigations will probably still remain a research tool in institutions, but for clinical practice, definitely immunohistochemical studies should become a part of it as a routine.
And sir, as surgeon post-RT, short course versus long course, do you find any difference in the operative issues?
I personally do not have a very large experience, but when I talk to my colleagues who do more colorectal or rectal surgery than me, they said that after the short course, the radiation-induced tissue edema actually helped in dissection because it opened up the planes. Whereas if if either after short course or long course, when they wait little long, in some patients, the radiation-induced fibrosis did offer some resistance to dissection. And more importantly, that fibrosis or the desmoplasia sometimes makes it difficult to differentiate whether it is tumor or whether it is desmoplastic infiltration. So I suppose if the results are equal in large majority of cases, I think most groups would now change to short course with or without chemotherapy.
Thank you. Thank you so much.
Longer interval.
So before we move to Dr. Ankur, can I request our expert, Dr. Kostov, he can give his expert comments on the debate. Over to you, sir.
Yeah, so it was a great debate. Dr. Indu and Dr. Bharat, I think you stood your grounds, and I both of you have come out with some very pertinent points. Let me, short course, of course, there has been a drift in the recent years. That is because of the delayed surgery also. Your pathological complete response rates are much better. Rapido results have utilized systemic therapy with short course, and that has definitely helped. Few points I would definitely like to remember. Do not omit long course at all, completely, because as Indu has said, for CRM closed patients, for levator NI muscle involved patients, and one more group, if the tumor very low or ultra low tumors, long course still holds a ground. We also have to remember that in Bergeson's paper, Swedish rectal cancer trial, we also have a communication with them from the Tata group when I was in Tata. Their late effects came as late as almost a decade, and they had the patients who underwent fistula, underwent short course, had higher incidences of fistula and obstruction. And Indu has rightly said that those may be circumvented by the radiation techniques today, IMRT, and we are using image guidance. But before adopting short course completely, of course, we have to adopt short course, as Dr. Kapoor has said, that it saves time. We are not unnecessarily exposing patients to long course. But what I would say is select patients rightly for ultra low, muscle involved, CRM positive or closed tumors, go for long course. For lesser bulky tumors, little higher up tumors, short course probably is the way to go. And that is where I would conclude. Thank you.
Thank you so much, sir. Now I'll move on to Dr. Ankur Punia for his expert comment and Q&A.
Yeah, one more thing I'd like to ask is whether the type of histology, whether it's a mucinous or a signet ring cell, whether it will make any difference in choosing whether we'll give a long course or a short course radiation.
At my knowledge, in my knowledge, trials have not sub-stratified, but probably extrapolating from other studies, we can.
So for mucinous and signet, long course is better.
Yeah.
Yeah.
Yeah, that is right, Indu. That's right. Yeah.
So do we have any other questions we can ask? For final comments, I would like to ask Kapoor sir to please provide the final comments regarding this.
No, I think Dr. Kostov has very beautifully summarized what we can take home message, that in select cases, long course may still be indicated, but by and large, the clinical practice should probably shift towards short course with systemic treatment and a longer interval between the completion of the neoadjuvant treatment and surgery.
Thank you so much, sir. Thank you to the debaters, our expert, our chairpersons, and also to our speaker. We'll now move on to the next session, which is on non-colorectal cancer. And I invite our organizing secretary, Dr. Lalit Mohan Sharma, to please introduce our session director.
Thank you. Thank you so much, Kashish. Thank you, Professor Btk Kapoor, sir, and my previous speakers and participants. Let me introduce Dr. Rajgovind Sharma. Dr. Rajgovind Sharma, sir, is a well-known figure in the field of surgical oncology. He has established the Department of Surgical Oncology at SMS Medical College Hospital. He has started the MCH course there, and currently we are lucky and we are proud to have him here with Mahatma Gandhi Hospital. He is currently senior professor and head of the Department of Surgical Oncology at Shri Ram Cancer Center in Mahatma Gandhi Medical College Hospital, Jaipur. Thank you so much, sir, for sparing time on Sunday afternoon with us. Over to you, sir. May I request Professor Rajgovind sir to introduce the chairpersons?
So good afternoon, and we will have a good interaction on the GI session, non-colorectal. And I welcome the chairperson, Dr. Naresh Chakotia, who is a consultant in the Department of Radiation Oncology at Bhagwan Mahavir Cancer Hospital and Research Center. Dr. Atul Sharma is Professor, Department of Medical Oncology, All India Institute of Medical Sciences, New Delhi, and Dr. Umesh Khandelwal, who is a consultant medical oncologist at Santokba Durlabji Memorial Hospital in Jaipur. So the topics are advanced CAGB, MSI in gastric cancer, debate on G-junction tumors, and then expert comments by Dr. Maka. So over to you, chairpersons. And thank you for having me as the session coordinator.
I now invite our chairperson, Dr. Naresh Chakotia, to please introduce our first speaker. So you'll have to unmute your mic, sir.
Very good afternoon to everybody, and thanks to the organizing committee, Dr. Lalit Mohan sir and Dr. RG sir for doing this wonderful conference. I would like to invite the speaker, Dr. Rakesh Pinti, for session treatment of advanced gallbladder cancer in the real world. He is consultant medical oncologist at American Cancer Institute, Hyderabad. Over to Dr. Rakesh ji, please.
Yeah, good afternoon to all. Thank you, organizers, for this opportunity. It's a real privilege to discuss gallbladder cancers in the under the presence of Dr. Atul Sharma sir, today's chairperson. So let me discuss very briefly practical aspects of treatment of advanced gallbladder cancers in the real world situation. So let me start with a slide that actually understanding the burden of
Sir, sorry to disturb you, sir. The slide is blank, sir. It's black in color. So can I request you to reshare the screen?
Yeah. Are you seeing my slides?
No, sir. We
No,
don't
sir,
see your
it is
slides.
not.
So with your permission, can we share the slides, sir?
Please, please. You have my slides, right? Yeah, thank you. So first slide, please. So let's understand the burden of this condition in the community. Unfortunately, India has a distinction of having the highest incidence of gallbladder cancers in the world. Nearly about 18,000 to 22,000 new cancers of gallbladder are diagnosed in India every year. And we are losing nearly 70% of these cancers patients every year for this cancer. So basically 15,000 to 18,000 new gallbladder cancer patients are unfortunately lost in their lives to this gallbladder cancer. So again, in India, the incidence of this gallbladder cancers varies variedly from the geographical location and racial ethnical groups. I think the more important concern here is that we don't understand why these differences are there. And most of these patients are diagnosed in a very advanced stage. Only about 10% of the patients are suitable for curative surgeries. Next slide, please. So let's understand what is the unmet medical need in the management of advanced gallbladder cancer patients. Despite rapid progression in molecular characterization of tumors, there is a dearth of newer techniques and newer treatments in the gallbladder cancers. The prognosis of these patients is pretty poor. We don't have biomarkers for stratifying patients to particular first-line therapies, and most published series are very small and consist of heterogeneous mix of patients, which includes gallbladder cancers, cholangio cancers, and even sometimes in some trials, pancreatic and hepatic cancers, and these tend to respond differently to the systemic therapies. Finally, the goals of palliation for gallbladder cancers will be relief of pain, jaundice, bowel obstruction, and also prolongation of life. Next slide, please. Coming to the first-line chemotherapy, the optimal regimen has not been defined categorically in the randomized trials, and no single chemotherapy or combination chemotherapy has been recommended uniformly across standard of care for all the patients. Reported objective responses with chemotherapy around 10 to 60%, and we have only limited data evaluating the impact of systemic therapy on survival of these patients. Next slide, please. So this is in fact the only randomized trial comparing the best supportive care versus chemotherapy. This comes from AIMS. Professor Dr. Atul Sharma sir was the lead author of this article. And basically it was testing best supportive care versus systemic therapy. It included 3 cohorts. Cohort A was best supportive care. Cohort B was basically 5-FU leucovorin. And cohort C was a modified dose of GEMOX. So basically, the median overall survival was significantly better with GEMOX at 9.5 months compared to the other 2 groups, which was only 4.5 and 4.6 months. Toxicity were increased, but these are manageable. Next slide, please. So in patients with at least a good performance status and no or minimal hyperbilirubinemia, it is suggested that we should be using a gemcitabine-based combination chemotherapy rather than gemcitabine monotherapy or a non-gemcitabine-based regimen. And further evidence comes from the UK ABC02 trial, which is basically testing the superiority of gemcitabine plus cisplatin over gemcitabine alone. It's a multi-center ABC02 trial, and the study intervention include a combination of gemcitabine and cisplatin day 1, day 8 every 21 days versus gemcitabine alone weekly for 28 days. So this is the final follow-up. Median follow-up of 8.2 months, the median overall survival and PFS was significantly better with the use of GemCis compared to that of gemcitabine alone. Toxicities were obviously increased, but these are manageable. Next slide, please. So coming to the further combination of gemcitabine. Gemcitabine in combination with S1 was tested in Japanese population in the FUGA-BT trial, and it was shown to be non-inferior to the GemCis with respect to median overall survival as well as to the overall response rates. Again, what about GEMOX, which was initially tested in this prior trial? Again, this was a randomized phase 3 trial from AIMS, again under the lead author of Dr. Professor Atul Sharma sir. It is basically testing modified GEMOX versus GemCis in unresectable gallbladder cancers. It was a non-inferiority trial with a equivalent study with 2 months of equivalence margin. After the end of the study, the median overall survival was numerically superior in GEMOX at 9 months versus 8.3 months in GemCis. However, the median difference was around 0.8 months, and the upper limits of confidence intervals was crossing the pre-specified 2 months margin by 2.7 months. So non-inferiority was not claimed. So these results of this trial has confirmed that 8 cycles of GemCis were not equivalent to 6 cycles of GEMOX. Next slide, please. Further, in patients who are frail general condition with biliary obstruction, it is preferred that we use a non-gemcitabine-based regimen such as leucovorin 5-FU or FOLFOX. The response rates are pretty okay at 0 to 34%, but median overall survival is typically less than 6 months. There was another phase 3 trial which is testing the non-inferiority of CAPOX versus GEMOX. It has shown a similar overall survival, but the response rates in GEMOX were around 30% compared to CAPOX, which is only 16 to 18%. Next slide, please. So this is the application of trial information to the real world. This is a consecutive series of locally advanced metastatic gallbladder cancers who were treated with gemcitabine, cisplatin, and GEMOX as first-line palliative chemotherapy from January 2013 to 2015. This is from TMH data. It was retrospectively analyzed. Patients who were able to continue chemotherapy beyond 68 cycles were separately analyzed compared to those patients who have potential candidates for this approach but choose not to continue chemotherapy. What we need to understand is that median overall survival for the entire cohort was 1.65 months, which was at least 40% lesser than what we have seen in the trial data of around 10 to 12 months. What this data illustrates is that the average trial patient is much more, average real world patient is much more sicker than the trial patient. They are having higher comorbidities, higher disease burden, and also there is higher chance of having hyperbilirubinemia. However, those patients who are receiving continuation chemotherapy has a statistically improved median overall survival compared to all other patients at 14.88 months. Further, in the multivariate analysis, the lesser burden of disease, lesser number of metastases, ability to continue chemotherapy, and fit and able to continue second line chemotherapy, these are the factors which were found to be having prognostic factors for improved overall survival. Next slide, please. So this is second line treatment. Again, the selection of patients and the optimal regimen are not suitably established. Generally, physicians choose a second line regimen that do not overlap with the agents used in the first line. This is the recent data that's come from ABC06 trial, which was published in Lancet Oncology in May 2021. Again, an open labeled randomized phase 3 controls trial that was testing FOLFOX versus active symptom control. Again, we can see that FOLFOX was associated with significantly better overall survival at 6 months, at 12 months, with the median overall survival, which is modestly improved at 6.2 months versus 5.3 months in the active symptom control. Hazard ratio is statistically significant. Next slide, please. So this is again data from India. We can see a multi-center phase 2 randomized clinical trial, which collaborated between AIMS and TMH. This is again testing a combination of capecitabine with irinotecan versus irinotecan alone. The conclusions of this trial is that there was no significant difference in overall survival between those patients who have taken capecitabine versus irinotecan alone. And final conclusion is that single agent irinotecan should be the preferred treatment choice for these patients. Again, the evidence for single agent irinotecan comes from an abstract which was presented in ASCO 2021. Better overall survival paper of that. Next slide, please. So finally, coming to the molecular targeted therapy and future directions, we can see that there are several ongoing trials that are using NGS of multiple genes to identify molecular abnormalities, like MATCH trial and as well as ASTRO-TABOO trial. What we can understand is that the most common molecular alterations in gallbladder cancers are KRAS, EGFR, and BRAF and HER2 overexpression. HER2 overexpression was found to be more common in the GB cancers than cholangiocarcinomas. Alterations in the FGFR and IDH were much more common in the intrahepatic cholangiocarcinomas than in the GB cancers. Coming finally to the MASCOTO-01 trial, this was a trial that included advanced cancer patients who were refractory to systemic therapies, and out of the 1,035 patients which were enrolled, 43 patients were having biliary tract malignancies. Among those 43 patients, 34 patients were having a potentially actionable molecular aberrations, making overall percentage of 68% with the molecular aberrations which can be potentially targetable. Out of those 34 patients, 28 patients would actually receive a targeted treatment. However, the median progression survival was only 5.2 months, no better than the best supportive care. What we can understand and what this illustrates is that we have a long way to go to understand the molecular mechanisms of gallbladder cancers and targeting them. Finally, concluding with the application of immunotherapy, which is a flavor in the past decade, we can go by a biomarker-driven strategy or non-biomarker-driven strategy. If you go by biomarker-driven strategy, we have the Keynote pembrolizumab tissue agnostic approval, wherein MSI high histology patients have had shown a better median duration of responses. If you go by biomarker non-driven approach, then a combination of nivolumab plus ipilimumab can be tried, and those having responses which is better than the supportive care alone. However, this is again a very controversial and experimental topic. Let's wait for further trials. Next slide, please. So I would conclude my brief presentation on the advanced gallbladder cancers in real world setting. I would welcome any comments and suggestions from the chairpersons. Thank you very much.
Thank you so much, sir. If we have some comments from our chairpersons, we would love to hear them. Otherwise, we can move on to the next session.
Not sure. Did you discuss about the Topaz trial, biliary tract? Recent data from the
Rakesh, sir, are you there?
Yes, I'm
where they've shown for the first time that the immunotherapy may be, I think, used in the biliary tract cancer. That is the only thing probably, if you've not discussed, that would like to end. Otherwise, you have done a good job. And also about the recent trial, Prodigy 6, I think, where this shown that the FOLFIRINOX may not be superior to GEM-CIS combination.
Thank you, sir.
Kashish, can I ask one question to Dr. Rakesh or Dr. Atul Sharma?
Yes, sir, please go ahead.
Atul Sharma, sir, about the S1 used, did you use the S1? Recently, NATCO has come up with S1. So Japanese have used it a lot, and GEM plus S1 versus GEM plus CIS or single agent. So any comments on that, sir?
So personally, honestly, I have no experience, and I'm aware about this thing, the 3-drug combination. Probably if adding this thing, they showed some kind of the benefit, this thing. So that is probably, if it's within our reach, easily available. But only concern when I've used in some other indication when it was imported from the Japan and this thing, the toxicity may be a little concern. But unless you use it for a variety of patient or number of patient, it becomes difficult to comment about the toxicity also. But I do agree that this may be one of the options. In fact, we did publish our phase 2, which showed that with the inoperable cases, modified FOLFIRINOX is the one thing which may need to be studied further. I don't want to believe the Prodigy data that it is not superior to GEM-CIS or this thing. We have shown and published even before their publication that it may lead to about 40, 45, 46%, I think, response rate and objective responses. And I personally interested in that, and probably we are starting a trial using modified FOLFIRINOX in a neoadjuvant setting.
Great, sir. Thank you. Thank you so much.
One small comment, it's like which I've picked up from the late teacher, Dr. G.S. Bhattacharya. I've started using nimetuzumab, that is Biomab from Biocon, for patients on second line, third line carcinoma gallbladder and intrahepatic cholangiocarcinomas. I've actually been finding very good responses. Many of them, like our speaker showed, are FGFR, EGFR mutations present. And actually, I find this to be, I would like to know actually from the rest of the senior faculty who, whether they have seen any benefit with this. Even Dr. Govind Babu from Bangalore, he uses it. I know we don't have too much of data. I also have another thing that from Dr. G.S. Bhattacharya, he had taken from the seed data. He used to add propranolol 10 mg along with the therapy. Propranolol 10 mg. He's got a paper in ESMO as well, 2014. So it's given at least a 4-month OS benefit. So this is something that I would just like to add. Nimetuzumab along with then propranolol as well. 10 mg of propranolol makes a difference. Thank you.
Thank you so much, sir. So with your permission, we'll move on to the next session. I now invite Atul Sharma, sir, to please introduce our next speaker.
Sorry. So we move on to the next presentation. This will be by Dr. Ram Abhinav from Kovai Medical Center, Coimbatore. And the topic for discussing is the role of microsatellite instability in patient with advanced gastric cancer. Dr. Ram Abhinav.
Ram, sir, can I request you to unmute your mic?
Thank you, sir, for the kind introduction. Today, I'll be discussing about the role of microsatellite instability in advanced gastric cancer and the use of PD-L1 inhibitors. We all know that it is a tumor agnostic indication that we can use checkpoint inhibitors in any tumor who has MSI high status. But this topic or this presentation specifically will look at what benefits or is it worthwhile giving checkpoint inhibitors in MSI high gastric cancers. As we know, gastric cancer is a heterogeneous disease, and according to both TCGA and ACRG classification, the MSI high group represents a significant distinct subset of gastric cancers. And we look at the TCGA classification, Epstein-Barr virus with associated DNA hypermethylation is one category. And the second category, which we are interested in, is gastric cancers with microsatellite instability. And third is genomically stable gastric cancers. And fourth is genomically gastric cancers with chromosomal instability. So what happens in tumors who have microsatellite instability? There are a lot of neopeptides, and these neopeptides act as a trigger for strong T cell recruitment. But what we also have to know is that these tumors also have PD-L1 expression. So that is how they are escaping from the T cells. So that is why probably the use of PD-L1 inhibitors will remove the inhibition which was caused by PD-L1 ligand, and that might lead to triggering tumor cell killing by the T cells. There are not many studies which are distinctly looking at the effect of checkpoint inhibitors in MSI high gastric cancer. This is one study which is looking at non-colorectal high microsatellite high instability tumors. It's included 233 patients, and pembrolizumab was given 200 mg IVQ3 weekly. And we could see that around 10% of the patients were gastric tumors. And what did we see is that there are, out of 24 patients, 4 patients had complete response, 7 patients had partial response, and the overall response rate is around 45%, so which is really significant. The median progression-free survival was around 11%. And importantly, as we usually see with immunotherapy and MSI tumors, the median OS and median duration of response is not reached. So there are some patients was still deriving benefit from it. And the second study, which I'll discuss, is a combination of post-hoc analysis of first-line and second-line data with pembrolizumab, which is a Keynote 059, Keynote 061, and Keynote 062 studies. The post-hoc analysis, the total number of patients were 1370, and out of that, 84 patients were having microsatellite instability high. So to shorten it up, the median PFS with addition of pembrolizumab in these specific set of tumors and Keynote 59 it was not reached, and Keynote 61 it is 17.8 months, and Keynote 62 is 11.2 months. So this is a combination of first line and further line data, and generally because gastric cancers are aggressive tumors, the expected survival was around 11 months to 13 months. So we can see from the TOGA trial, but here we are looking at progression-free survival rates of more than 11 months. And for all studies, Keynote 59, 61, and 62, the median overall survival was not reached with the addition of pembrolizumab. And what is intriguing is majority of these microsatellite high tumors also have increased expression of PD-L1. So as I initially showed in the graph, these tumors generally escape with the help of PD-L1. And because these tumors have high PD-L1 expression, that is how they escape. So that is how, if we give checkpoint inhibitors, probably these patients have, and when we don't have big, large randomized trials to address this, so this is a meta-analysis of all the trials, which also includes retrospective studies as well. And we could see that for overall response rates, if we add an immune checkpoint inhibitor, it definitely favors the arm which has the immune checkpoint inhibitor. And so is the progression-free survival. All the studies invariably show that when immune checkpoint inhibitors added to a standard arm, it improves the progression-free survival, and so is the overall survival. So to the results of anti-PD-L1 regimens is, according to this meta-analysis, the
Sorry, sir.
overall survival.
Naresh, sir, can I request you to mute your mic, sir?
For this meta-analysis, for overall survival, the hazard ratio is 0.34, which is very significant. And the treatment effect was significantly different between the two groups. The p-value for interaction is 0.003. And for the macrosatellite high subgroup, the hazard ratio for PFS is 0.57. Again, very significant. And for the odd ratio of response, it was 1.76. Again, there's increased responses in these groups. So meta-analysis concluded that there is increased response rate, there is improvement in progression-free survival, and there is improvement in the overall survival as well. So the NCCN guidelines, they recommend pembrolizumab or dostarlimab. I've never used that, but these are two agents which are approved for MSI high tumors. So to the take-home message is, we know that microsatellite high tumors, we can use pembrolizumab for any tumor. But when we look at gastric cancer alone, the data seems to be very good. The median progression-free survival itself is on the higher side of more than 11 months. So checkpoint inhibitors should be incorporated if a patient has microsatellite high or deficient MMR. That I'll conclude my talk. Thank you.
If we have any comments from our chairpersons or our session director, we welcome the same.
So I prefer if someone from the audience asks questions, or if we have something in the chat box.
Sir, I believe Dr. Raj Govind Sharma had mentioned something. So was that a question? Sir, you're muted, sir. You'll have to unmute your mic.
Overall survival benefit. So we don't have a separate analysis to say that, or separate phase 3 trial to say that there is an overall survival benefit. But when you look at the meta-analysis, there seems to be a definite trend towards overall survival. That is what the data we have. There's only 5% of the patients who are microsatellite high. So it is nearly impossible to have a trial for these specific group of patients. But the general trend seems to be having a better survival.
Thank you.
Narissa, if you have any comments to the talk, we welcome them. Okay, so thank you so much, sir. Thank you. We'll move on to the next session. This session is on a debate, and I invite Atul sir to please introduce our debaters.
All right, so the debate is about the radiation should be added in pre-operative treatment in gastric or gastroesophageal junction tumor. And we have extremely two learned debaters. For the topic will be Dr. Jaskaran Singh, against will be Dr. Vedant. So I'll give a chance to Dr. Jaskaran Singh. So Jaskaran Singh is a Senior Consultant and Chief of GI, HPB and Pediatric Radiation Oncology Center at Rajiv Gandhi Cancer Hospital. Dr. Jaskaran.
Sir, you'll have to unmute your mic, sir.
Yeah, good afternoon, everyone. I hope I'm audible. Can I have my slide set?
Sure, so we'll just play your slide.
Yeah, till they are playing the slide set, I would like to thank the organizers, especially Dr. Lalit Mohan, for having invited me here today and for this debate, which is quite evenly poised, I suppose. So, should I start?
Yes, sir, please go ahead.
Can you? Okay. So the topic for today is the topic that I'll be speaking for is whether we should add radiation for tumors of the gastroesophageal junction and distal and gastric cancers. So we know that surgery alone is no more an approach for these cancers, and that we need to add adjuvant or neoadjuvant treatment. The two current approaches that are acceptable are upfront surgery followed by adjuvant chemotherapy and or radiotherapy, or preoperative therapy in the form of neoadjuvant chemotherapy alone, or chemo-RT followed by surgery and then followed by the perioperative chemotherapy. Next slide. So upfront surgery followed by the adjuvant treatment was established by intergroup 0116 study and the ARTIST and ARTIST2 studies. I'll not go into detail. Next slide, please. So let's start by what happens when we add preoperative chemotherapy. So over the years, we've had trials from MAGIC to the French trial, FFCD 9703, and the FLOT study, which have shown that preoperative chemotherapy is an option and can be another option with the clinicians who are treating this. But this is where my agreement will actually stop here. Can you just slide on? It gives a good R0 rate, but if we see across these studies, especially when we see the FLOT study and the MAGIC study, only half of the patients were able to complete all the planned chemotherapy, which highlights the difficulty in giving the adjuvant therapy. And this suggests us that patients benefit more from the short duration of chemotherapy rather than pre and perioperative chemotherapy. Next slide, please. Go on. The preoperative radiotherapy has many rationales to it, and these should be utilized when we are treating the patients because it helps us tackle the rocoregional micrometastasis early on in the disease. It helps to downstage, resulting in better R0 resections. It gives us a good treatment compliance, which I just highlighted, that in pre-perioperative chemotherapy, the compliance post-operatively was really bad, and radiation works better when we give it in the pre-op stage as the tumor is better oxygenated. So next slide, please. So role of chemoradiotherapy started with the few early trials like Ajani et al. And RTOG 9904. which showed that when chemo-RT was given, there were better R0 rejection rates. There was a better pathological complete response, which was seen in these patients. And there was, you see, better, the median survival also increased over, these were in comparison to surgery alone. But what both these trials reported was that there was an acceptable toxicity, because most of the times we do not want to add both the chemo and radiation, and the surgical colleagues are especially worried when we add radiation. But both these trials did not give us whether it improved the overall survival. So this actually came about, next slide please, from my next study, which I quote here, is the POET study. Go on, please. Which was specially for locally advanced adenocarcinoma of GE junction, and here we saw that there was a trend towards an improved overall survival, 31, almost 31 months with the CRT arm as compared to 21 months with the perioperative arm. Go on, please. Another trial that showed that chemoradiotherapy results in better pathological complete response, lower rate of lymph node metastasis after giving chemoradiation, and better R0 rejection rate was NeoRest trial. But here there was no OS benefit. Probably because the dose of radiation was 40 gray, which was chosen for the trial, which was a little underdosed. So next slide, please. So now let's come to the important trial which has established chemo-RT as the standard neoadjuvant treatment in esophageal and GE junction cancers. And this trial showed that there was an OS benefit. 48 months in the chemo-RT arm versus 24 months in the surgical arm. The pathological complete response was also almost 30%. The R0 rejection rates were better with the chemo-RT arm versus the surgery arm. And the pathological node negative rates were as high as almost 70%. So it showed that neoadjuvant chemoradiotherapy arm was effective both in squamous and adeno. I know it's many times it is said that the driver of the OS benefit came in from the squamous cell carcinoma, but there was a notable effect with patients of adenocarcinoma also, which we cannot just sideline. And importantly, this trial showed that chemoradiation was not associated with an increased toxicity or surgical morbidity and mortality, which I will deal in the subsequent few slides later on. But one very important thing that we have, next slide please, but one very important thing that we have, next slide please. Excuse me. Yeah, go back. I think you've skipped one slide. Yeah, one very important thing that we have seen coming out of the meta-analysis and the trials that we've been doing to improve the outcomes in this subset of patients is that pathological complete responses and the lymph node status are predictors of better overall survival. They contribute to much significantly in improving the OS. So next slide, please. Go on. So if we see this, I would like your attention to on this table, and you just keep clicking because I would be highlighting some points on this table. If we see that go on. If we see that the MAGIC trial had around 12% patients of GE junction as compared to around 22% in the cross trial. Also, when we see that the complete rejection rates or the R0 rejection rates, they were higher in the cross trial, as much as 92%, much more than the ones we see in the MAGIC trial, and even better than what we see in FLOT. Now coming to the pathological node negative status, we also see that here also chemo-RT does better than both MAGIC and FLOT. When we see the pathological complete responses, it is better, complete rejections are better. And now let's come to the OS data from these trials. Now, this again shows that 5-year OS was around 47% in the cross trial, which was more than the MAGIC. And the Forte Trial reports us a 3-year data, which is 57%. So it's not bad. Now let's go on to the next slide. Again, meta-analysis recently published in 2019 by Cheng et al. And Petrelli et al. Underline the fact that chemoradiotherapy has resulted in a better OS as compared to perioperative and neoadjuvant chemotherapies alone. And at the same time, it has this is because there is a better pathological complete response seen in these patients, and there's no difference in the risk of death when we compare neoadjuvant chemotherapy to neoadjuvant chemoradiation. Please, next slide, please. So now coming to the toxicity profile of chemotherapy versus chemo-RT, which is very important. We see here also in the Forte trial, the rate of hospitalization was pretty high. As much as 1/4 of the patients required hospitalization due to various toxicities, including neutropenias, which was seen in almost more than 50% of the population. Although febrile neutropenias were less, but the rate of hospitalizations were still high. When we compare the grade 3 and above toxicities from cross trial, we see that neutropenia was just 2%. So this again reiterates that chemoradiation is a very viable option. Now coming to a point where the surgeons are very worried about chemoradiation all the time. So if you see the cross trial data again, the anastomotic leaks were more in the surgery alone arm as compared to the chemo-RT arm. The deaths in hospital and after 30 days were comparable. So we don't see that chemo-RT actually is a treatment which is not well tolerated. It's a very, very well tolerated treatment, especially with the doses coming down to 41.4 gray of radiation in the cross trial. Next slide, please. So now I'll just touch upon that why preoperative radiation is better. As a radiation oncologist, I would any day prefer giving a preoperative radiation than a postoperative, because in the preoperative phase, the tumor actually displaces and minimizes the normal structures that come into our treatment portals. The doses that are required to achieve a similar local control are much less in the preoperative strategy than the postoperative. Also, when we are treating the post-operative patients, normal structures are a difficult subset to, they become the organs at risk and are a difficult subset to deal with. At the same time, the anastomosis and reconstructions also give a very big challenge to the radiation oncologist because of the doses that are required in the post-op radiation. Next slide, please. This is just a table, again coming to what again just depicting what I just explained in my previous slide. Let's go on to the next slide. So these days the radiation treatment fields are very, very localized, especially when we use better technologies like image-guided radiotherapy and IMRT. We would take lymph node basins for gastric cancers and GE junctions similar to how a surgeon would be dissecting. Coming to stomach specifically, we tend to include specific lymph node stations depending upon the proximal stomach, whether it's in the tumor is in the proximal stomach or the distal gastric areas. The doses usually in the preoperative trials are up to 45 gray. When we are talking of GE junction is 41.4 these days if you are following cross, or if you are having a single agent, then we tend to go up to 45 grays. Next slide, please. Now there are a lot of this debate is going to go on. This is not only myself and Dr. Kavra debating it out here, but the whole world debates it, and there are few ongoing trials which we hope shall provide us with the sufficient data to choose wisely the therapies for our patients, like the Top Gear trial and the SOPEC trial. Go on, please. And the New Ages trial. New Ages trial has recently come out with a communique in ASCO, which shows that when we compare the R0 resection rates in the two arms of the trial, which are the magic plot arm versus the cross arm, where we use the radiotherapy, we see that R0 resection rates are better. The post chemoradiotherapy node negativity is better. The tumor regression grades are better. Pathological complete responses are better. On the contrary, we see that the neutropenias are much more in the chemotherapy arm. So this is just an initial communique, and they have concluded that chemotherapy is non-inferior to chemoradiotherapy. And please go on to the next. SOPEC is one of the trials that we are all eagerly looking forward to, which is giving us a head-on comparison between the established chemotherapy regimen of FLOT versus the established chemoradiotherapy regimen of CROSS. Next slide, please. So in the end, I would like to summarize my part by saying that both chemoradiotherapy and FLOT are active regimens which can be used. The key issues should be in preventing the toxicities so that surgery is not delayed any further. We all know that we should choose the therapy in all these patients depending upon where the tumor is located and what is the staging of the tumor. We should not we should neither undertreat or overtreat our patients. Next slide, please. With that, I'll end my debate.
Thank you so much, sir. If I may request our chairperson to introduce our second debater.
Yeah, so Dr. Kabra. Vedant Kabra is Principal Director at Department of Surgical Oncology, Fortis Memorial, Gurgaon. So you need, Dr. Kabra probably is going to tell us radiation is not needed. Is he there?
Sir, can you hear us? Vedant, sir?
Don't want to go it like that.
Vedant, sir, can you hear us?
Sorry, I got disconnected. I'll come back. So.
Yeah, maybe some internet trouble.
I think
I can see him, Dr. Vedant.
I'm not switching on the video because it might just go away. Okay. I'll try with that, but let's see.
Sure.
Can I start now?
Yes, please.
Sure, sir, please go ahead.
Okay, I hope my screen is visible.
Yes, sir.
Yeah, so we all know that survival of locally advanced esophageal gastroesophageal junction as well as gastric cancer is poor in spite of doing everything. And surgery alone is only probably 30% 5-year survival, which increases with neoadjuvant therapy. But which kind of neoadjuvant therapy is more effective? Is it perioperative chemo or it is neoadjuvant CTRT? And let us see that. Now, the problem with clinical trials is G junction has often been clubbed either with esophagus or stomach. Not only that, both adenocarcinomas and squamous cell carcinomas have been clubbed together mostly. And please remember, G junction is more akin to stomach, which is adenoCA, than squamous cell carcinoma of the esophagus. And we'll see that why. Now, aims of neoadjuvant therapy are basically to improve R0 resection, improve PCR, decrease locoregional as well as distant recurrence, and ultimately, the putting on the cake would be improving overall survival. Now, this is how the data has flown regarding neoadjuvant chemoradiotherapy or neoadjuvant chemotherapy. In the top half are the various trials of neoadjuvant chemotherapy. Dr. Jaskaran has already mentioned them. I'm not going to go into details. Magic Trial, French Trial, and FLOT, all of them have shown progression-free survival as well as overall survival benefit with good tolerance. Versus Cross Trial, Poet Trial, and CalGB Trial, which were CTRT trials, and I'll be coming to them later on. But before that, is squamous carcinoma same as adenocarcinoma? Let us see. This is a paper from Nature in 2017, and it very clearly says that esophageal squamous carcinomas resembled squamous carcinomas of other organs more than they did esophageal adenocarcinomas. And esophageal adenocarcinomas strongly resembled chromosomally unstable variant of gastric adenocarcinoma, suggesting that these could be considered as a single entity and rather than clubbing them with esophageal squamous carcinomas, which most of the trials have done. And again, this article also says, with respect to histology, there are inherent differences between the two, and squamous carcinomas are definitely more radiosensitive as compared to adenocarcinomas. And what we see here, these are various trials of preoperative chemotherapy versus chemoradiotherapy versus surgery alone. And you will realize that the PCR or the response rates and the PCR rates are much inferior in the squamous in the adenocarcinoma group as compared to squamous carcinomas. Now, coming to German FLOT study, so Dr. Jaskaran said there is a very intensive chemotherapy, but 97% of the patients were able to undergo surgery. Median survival was 50 months in FLOT. And let us see here what happens in CROSS. In CROSS, the median survival is 43.2 months. FLOT has 50 months. This is for adenocarcinoma. Overall, CROSS as a whole group is 49 versus 24 months, but it is largely because of squamous cell carcinomas, where the median survival is 81 months versus only 21 months for surgery alone. So there is definitely a difference between squamous and adenocarcinoma, and CROSS had a good number of squamous carcinomas as well. Now, CROSS study is CROSS for adeno-CA. Multivariate analysis, after adjusting for the known prognostic variables, showed that the survival benefit in adenocarcinoma group was not statistically significant. It was statistically significant in node-negative group, but not so in the node-positive group, which probably is a more important group vis-a-vis distant recurrences, distant disease, and ultimate overall survival improvement. And it is also overlooked that CROSS study is a study comparing neoadjuvant chemoradiation plus surgery versus surgery only, when we know that there is a FLOT trial which is better than other effective regimens which are known to improve survival anyways. So we should take results of FLOT as better than the previous regimens which have been used like ECF or ECX. And now, although it is not absolutely right to compare different trials, but if you see here, cross-trial comparison, addition of radiotherapy does not really seem to decrease local recurrence to a great extent and is associated with a higher distant recurrence. You can see the local recurrence goes up from 9.6 to 12%, but the distant recurrence also goes up from 6% in perioperative chemotherapy on like FLOT, which is probably the best so far, to 12.4% in CROSS. Now, NEO-RES trial, which Dr. Jaskaran had mentioned, it's a randomized phase 2 trial comparing NACTRT with NACT in resectable cancer of esophagus and GE junction using cisplatin and 5-FU versus RT plus the same regimen. And there was no difference in survival. But what was seen was post-operative complications were more severe in the CTRT group. Again, a subsequent follow-up study, health-related quality of life. So Dr. Justin did mention that the quality of life is okay, the complication is okay, but this is a published data from the same group, and they say health-related quality of life after multimodal treatment, which is CTRT, for CA esophagus and GE junction was impaired and more pronounced for patients who underwent CRT with only partial recovery over time. Now, he also alluded to Poet Trial. We all know it was closed prematurely because of poor accrual. Obviously, the power of the trial was not good. There was a trend towards better survival, but at what cost? The post-op mortality was 10.2% in the CTRT group versus 3.8% in the other group. Although it was not significant, but then we can't expect significance when the trial is so underpowered and the recruitment was 1/3 of what was initially planned. There is a meta-analysis published last year, which included 5 RCTs and 15 retrospective studies for a total of 4,529 patients. And neoadjuvant CTRT was associated with higher R0 resections for obvious reasons, higher PCRs, and lower recurrences. There was higher 3-year survival benefit, but only in squamous carcinoma group. And at 5 years, there was no benefit, whether it is squamous carcinoma or adenocarcinoma. Here again, I would like to mention it has not included any of the studies which have used FLOT because they have not yet published their data. FLOT versus CTRT, I mean to say. And perioperative mortality as well as cardiovascular complications were higher in patients with adenocarcinoma. So this debate is largely about adenocarcinoma because it is GE junction and stomach. So please remember, you cannot club everything together and see perioperative mortality. These were definitely higher in adenocarcinoma. There are certain issues with biology as well as current studies. Adenocarcinoma, we all know, is less radiosensitive, and we are talking of giving radiation to them. Trials of neoadjuvant CTRT versus NSCT have not compared it with the best perioperative or best chemotherapy regimen. They are underpowered or they have early closure. And they have definitely shown higher post-op mortality as well as morbidity, especially ARDS and cardiac morbidities. There are ongoing trials, which Dr. Justin mentioned too, ISOPEC from Germany, NeoAGs from Ireland, Top Gear from Australia, and RACE again from Germany. And there are certain trials comparing NACTRT versus perioperative chemo for squamous carcinomas exclusively also. So hopefully we will have results of these trials soon, and we will have an answer to this debate. But before that, NeoAG's trial, again, Dr. Jaskaran did mention about it. He showed a very nice table showing everything in favor of NeoAGs. But please remember that there was no evidence that perioperative chemo is unacceptably inferior to multimodal treatment, notwithstanding the greater proxy markers of local tumor response in the cross arm that he had shown in that table. So this data strongly suggests non-inferiority and support an equipoise in decision-making in the modern practice. Now, coming to gastric cancer, I don't even want to debate this. It is a very clear guideline, preoperative or perioperative chemotherapy is category 1 vis-a-vis chemoradiation in category 2B. Also, as surgeons, we are worried about anastomotic leaks. We are worried about post-operative complication and viability of the stomach tube. And it is not without any reason, because there have been personal experiences and institutional experiences which have shown that. So I like to conclude that there is a large and consistent data from RCTs that perioperative chemo improves outcome in G-junction adeno-CA. FLOT is comparable to NACTRT in terms of PCR rates and R0 resections, which is 84 versus 92%. Mortality and morbidity of neoadjuvant CTRT needs to be considered. It cannot just be wished away with, because especially it is seen that adenocarcinoma patients have a higher perioperative mortality as well as morbidity. I feel the best option for T2N plus or any N otherwise, which is more than T2, G example, a very bulky disease where we are not expecting R0 resection, because radiation definitely this story. I have spoken with people at TMH in our own also. What is practiced actually is, and is squamous cell carcinoma, junction, and lower esophagus, consider neoadjuvant CTRT followed by TA radiation therapy. Thank you very much.
Thank you so much, sir. Now we give 1 minute for rebuttal to Dr. Jaskaran Singh. So I request you to give your rebuttal on that one.
Yeah, my Dr. Vedant, nicely contested, I would say first. Secondly, I would like to bring to everyone's notice that, as Dr. Kabra has said, that whenever we have a bulky disease, we should think of radiation. Because in India, we don't tend to get those T1s and T2s. We usually get T3s and T4s and big bulky nodes. In my practice, I have seen sometimes the primary tumor is less in the GE junction and the nodes are bigger in the gastrohepatic areas and the celiac areas. So this is a subset that needs to be evaluated very thoroughly in chemotherapy trials, how the patients are responding to bulky nodes. Secondly, I would like to also emphasize that reducing toxicity is everybody's aim, and so is it radiation oncologists. And there are trials right now going on where proton is being used as the radiation modality rather than the conventional photon-based radiotherapy. Also, I feel that as you have seen in FLOT and MAGIC both, perioperative does not help. Dr. Kabra pointed out most of them proceeded to surgery in FLOT, yes, but more than 50% could not complete the perioperative therapy. So I have my serious doubts about long-term distant metastasis control with just preoperative chemotherapy.
Vedant sir, are you there, sir?
Yeah, I have joined through a new device now, but I'm sorry I could not hear what Dr. Jaskaran was saying, except that he mentioned about proton therapy, and he did mention about FLOT at the end. I could hear him. So if there are any other points, and if one of you could tell me, then maybe I can give a rebuttal. I'm sorry about this.
Vedant, Dr. Jaskaran's main contrast is that probably in the perioperative setting, many times patients are not able to complete the desired or required post-operative part. So that is an issue, and that's what he wanted to highlight.
Yes. So
another thing, Dr. Kabra, I did point out is that in GE junction and stomach cases, we do sometimes actually see very big lymphadenopathies. And we in our clinical practice see a lot of bulky disease. We don't see early diseases. So I think chemoradiotherapy is a better option when it comes to even GE junction and stomach, especially when diseases are bulky, lymphadenopathy is big.
So I agree with your part that we see bulky disease, but the good part with GE junction and stomach, as compared to lower third or mid third esophagus, is we have a lot of leeway around them. In mid esophagus, if there is bulky disease, we are in problem because there are critical structures around. But with GE junction, we have a lot of leeway. With stomach, we have a lot of leeway. So we are not too concerned about bulky nodes. We can remove them very well, even after perioperative chemotherapy. What we are more worried about is getting radiated to an area which will be anastomosed finally. If it is a GE junction going to lower esophagus, then we'll be taking fundus of the stomach to neck and anastomosing to the esophagus, and the remaining stomach will form the tube. If it is proximal stomach, then again we'll be anastomosing jejunum to that area of esophagus, and we are definitely not comfortable, unless of course if it is stuck to various organs here and there. That's a different ball game altogether. You mentioned about proton therapy. Of course, it is going to improve these complications, but how many of us will be able to afford proton therapy in the current cost that it has? That's a big question to answer.
So, all right, let's congratulate Vedant and Jaskaran for excellent discussion. Personally, for adeno, my own bias is towards neoadjuvant chemotherapy rather than any CTRT. But having said that, I don't want to say that we don't use radiation at all. So any other question in case the organizer permit and this thing? Otherwise, I enjoy the discussion. Excellent discussion.
Thank you so much, sir. Sir, can we invite Dr. Tilak as our expert for the debate?
All right. So it's really a great pleasure and a pride, probably, so my former colleague, Dr. Tilak. So I would like to invite him. He's Professor of Medical Medicine and Medical Oncology at FMC. His expert comment. Dr. Tilak.
Thank you very much, sir. At the outset, my gratitude to the organizers of ICON. It is an honor for me to be on this forum with my teacher, Dr. Atul Sharma here. An excellent debate. Both their speakers had their valid points, tilting the arguments into their favor both the ways. To sum up in 1 or 2 minutes, which I have, the practice of therapy for GE junction stomach cancers, one has got a geographical variation. Whereas the North American people, they use mainly the chemoradiotherapy, whereas the Europeans, they use the perioperative chemotherapy. That's number one. Secondly, adeno versus commerce, very nicely brought out that the biology is different. One is more radiosensitive, other is probably more effective, only bulky nodes, etc. Very nicely brought out. Also that gastric cancer is different from the esophageal cancer. Second, query, in case we have to give a radiotherapy, it is always challenging to give radiotherapy in the post-operative setting, be it with studies which have done with surgery alone, with surgery, 5-FU leucovorin chemotherapy or ECF chemotherapy with radiotherapy. Both in the post-operative therapy, it is a challenge to give. Like in the intergroup trial, only about 64% completed had that, and in the TROG trial, there was slightly better compliance. Efficacy wise, again, there is no difference between the ECF and the 5-FU leucovorin when given, as shown by the CalGB trial. No difference in the post-op chemo versus chemo RT, as shown in the critics trial. In the artist trial, the D2 lymph node dissection, they had only DFS benefit, that too only in node positive kind of cancers. A very important point brought out was the pattern of failure. Chemo RT does give a good local control, but has got a more a poorer distant control and a distant METs as well as a regional control with its delivery. So the studies surely are tilting towards the pre-operative delivery of radiotherapy where indicated. So in this case, we've got the Top Gear study shown by both the speakers. It does show that pre-operative chemoradiotherapy is feasible. Almost 90% received the chemoradiotherapy, almost 85% plus proceeded for surgery. The phase 3 data though is available. I would like to sum up by saying that depending on adeno versus commerce, depending on the nodal burden and the overall burden of the disease, if radiotherapy is indicated, it should be given pre-operatively rather than post-operatively because of tolerance issues. With that, I've finished. If there are any comments from the chairperson, Dr. Atul sir, I'll be more than willing to take them.
Thank you so much, sir. If I can request Dr. Raj Govind Sharma sir to please invite our expert, Dr. Vinayak Maka. So we'll just invite our expert, Dr. Vinayak Maka, who is the professor and head of department medical oncology at MS Ramaya Medical College and Hospitals, Bangalore, to please give the expert comment. Over to you, sir.
I will try to keep the video off. There's internet issue. I hope everyone can hear me.
Yes, sir.
So I think there were two speakers and followed by a debate. To point out, debate was very nicely placed and it was very learning for us. And both were mild, but very subtly they told, in end, what we get in most of the debates is that you have to tailor the treatment for the patients. Bulky disease, histology-driven options, and consolidation. The one thing which has not been spoken is about consolidation therapies. I think there is a clarity with the cross protocol that you can use in a residual disease with immunotherapy. Whereas in FLOT, we don't have still option of exploring more consolidation or anything to add, which is lacking in the thing. Otherwise, first speaker was Dr. Rakesh, who spoke about our difficulties in managing GB cancer. Very interesting GB cancer is that we start treating them, just responding a little bit with tumor marker disease. By the end of the 6th cycle, they progress. This is how the PFS is for the GB. Most of the data is not very exciting. We have a heterogeneous crowd from where we based our data from. And I think 3 points which is pointed out very nice is lack of biomarker driven therapies. Even though we get to occasional HER2 or FGR pathways, those treatment options are not much there except for HER2. And I think a lot is to come from GB because we have the highest population in the world. And I think a lot of studies being happening. Maybe another 5-6 years from then, we may have data from India only. Coming to the second study done spoken by Dr. Ram Abhinav, I think very nice. He was our student before and he's done a good job. So you look closely the MSI value in the gastric cancer in the whole subset where all GI cancers were looked, where they found there was a significant benefit of using checkpoint inhibitors. And second thing is adding immunotherapy in the chemotherapy arm, where there is significant OS benefit when they compared in a MSI high and stable disease. Almost OS hazard ratio was 0.34 to 0.85. It shows that in this gastric cancer, we need additional options. And I think that's my thing. And anything is there, I can take the questions. Thank you.
Thank you so much, sir. Thank you to all the speakers. Thank you to all the chairpersons and our debaters for a wonderful session. We'll now move, and even our session director. Sir, Raj Govind, sir, do you have any comments, sir?
Oh, thank you. Wonderful session. Thank you.
Thank you so much, sir. With that, we'll move on to our next session, which is the Best PG Competition Finals. And I invite our coordinator, Dr. Hollis D'Souza, to please start the session.
Hollis is here.
So you'll have to unmute your mic, sir. So we have Dr. Hollis D'Souza, we have Dr. Bharat Rangarajan, and we have Dr. Krupa Shankar, who are part of the Young Icon committee. And we thank them for arranging a great session.
Hello.
Yeah,
yes,
Hollis.
At the outset, I want to thank Purvish sir and Icon organizing team for this opportunity for getting me back again. So we come to the final round of the 46th Icon. We had 23 teams competing for the prelim round held at 2 days back. The winners of the prelim round are so we have team A, B, and C. These are the top 3 teams that are selected who will battle it out for the main competition. A is Madras Medical College, B is Kidwai, C is LIMS. So going to the instructions, they are fairly clear. They were provided to the candidates much in advance. There are 3 teams, A, B, C. The competition is divided into 8 sets. Each of these sets is going to have questions, points. Some of these questions can be passed, some of these questions cannot be passed. Each of these will be explained before the start of each set. We'll be starting with team A, then by B and C. The questions for team A, that is the set 1, will be first fill in the blanks and definitions. So do I have all the candidates with me from team A?
Yes, sir. Dr. Jyoti, you'll have to switch on your video. I couldn't find the other 2 team members.
Yes, sir.
Together? Okay.
Team B is here?
Yes, sir. Team A is here.
Team B?
So Dr. Anup, please unmute your mic. Is your other team member also there?
Yes, she's there, sir. She is on duty actually. She'll be back in 2 minutes.
Okay, team C. LIMS?
Dr. Kiran Kumar, please accept it.
Sir, we are here. Sir.
Okay, yeah. So we'll
Can you start your video, please?
Yeah, we'll start with set 1. This is the instructions for all. 2 questions in each slide set. 10 points for each question. Total 20 points. There are no negative marks. Questions will not be passed to the other teams. Time limit is only 10 seconds.
At least 1 sec. Huh?
Yes, sir.
Kiran Kumar, where are your other team members?
Sir, actually, like my other team members are in the hospital, sir. They are participating individually, sir. So
have they logged in?
Sir, they have logged in, sir. They're logged in.
Ask them to unmute or start the video, please.
Okay, sir. I'll do it, sir.
Yeah, Hollis, go ahead.
Yeah. So we'll start with the round. Team A. This is your question. Hemolysis syndrome, definition by the Cairo-Bishop criteria. Fill in the blanks for the blue circles.
Potassium more than 5.5 and phosphorus more than 5.
Your time was out, but I accept the answers, but both are incorrect. The answer is potassium more than 6 and phosphorus more than 4.5. It is for adults. We go to team B. Team B, This is your fill in the blanks. CRAP criteria definition for calcium and hemoglobin value.
Calcium more than 11, HB less than 10.
Yeah, both answers are correct. Very. You go to team C. Team C, your fill in the blanks question is post-menopausal hormone levels. This is by trial criteria.
Sir, E2 less than 30 and FSH more than 20, sir.
Unfortunately, both are wrong. E2 is less than 10, FSH is more than 5. We go to set 2, personalities. We'll be starting with team A first. There are 2 questions in each slide set, 10 points for each answer. There are no negative marks. Questions can be passed to other teams if answered correctly, 5 marks for each answer. The time limit is 20 seconds. We'll be starting with team A. So the question for team A is identify the scientist and what are the landmark practice-changing trials she has done in 2005.
Tolani et al. Actrial breast cancer HER2 positive.
That's incorrect. I'm passing it on to team B.
Nancy Lisa.
That's incorrect. Team C.
No idea, sir.
Okay. So she is Dr. Picard for the HERA trials. You go to team B. So team B, this is your personality. Identify the scientist and name the trials for which there was a practice-changing scenario in 2003.
Not always. Pass.
Okay, team C.
Pass.
Team A.
No, sir, we don't.
So he is Professor O'Brien for the IRIS trials. We go to team C. Team C, your personality is identify the scientist and what was the landmark trial in 2007.
Sir, pass.
Team A. I'm sorry, I can't give you any hints here.
Pass, sir.
Team B.
Pass.
This is Professor Modzer for sunitinib. We now go to surgery, a specific set of surgical questions, all designed by senior Dr. Bharat. We'll start with team A first. 2 questions in each slide set, 10 marks for each question. Total 20, no negative marks. Questions will not be passed to the teams. Time limit is 30. Team A, the question is this. This is a Z11 study for sentinel lymph node biopsy. I want the author of the trial. What was the intra finding with mandated axillary clearance? And what is the OS difference between the 2 arms? Any of the 3 questions you can go for.
More than 4 axillary nodal dissections will make us to proceed with the axillary nodal clearance. And
that was for answer. That was a question.
0011 try.
Unfortunately, our time is up. We cannot pass this question. So the author for the trial for Giuliani, it was gross external extension was not more than 4 nodes, and it was a non-inferiority trial that failed. We go to team B. Team B, your question is this. Give me 5 more seconds.
Let's say 20%. for the second one.
Second one is
20%.
No, it is not correct. Your time is up already. The 5-year auxiliary clearance rate was 0.4 and 1.19, while the percentage of nodes dissected was 33%. Team C. This is your question. What is the false negative rate in this trial? And what are the techniques that decrease the false negative rates?
Sir, false negative rate is 10%, sir, and techniques to reduce the false negative rate was using a dual tracers.
And
dual tracer and
Dr. Kiran, I'll give it to you. The rate was 12%, which is close to 10%, and the technique was a dual die technique. I'll give both points for you.
Thank you.
Ashish, I'll be stopping the share here. I just have to change the screen.
For Team C, I've been just trying to add your third team member, Dr. Sumant Kumar, to the panelist. He's not accepted the request. So just wanted to inform you about this.
Okay, sir. I've already informed him, sir. I'll just call him again. Yeah.
You cannot have the third team member enter now. Huh? You please stop. Don't allow him to enter. It's too late.
Ashish, am I visible?
Yes, sir, your screen is visible.
Yeah. So we go to the next set, that is a set 4. We go for drugs. Team A. One question in each slide set. There are 2 slide sets. 10 marks for each question. There are no negative marks. Questions will not be passed to the teams. The time limit is only 10 seconds. These are fast questions. Team A, the question is, which ADC has got recent FDA approval for use in bladder cancer? Perfect. Team B, the question is up. NCCN guidelines mentions which of the following TK as an option in relapse refractory Ewing sarcoma? That's not correct. The answer is cabozantinib. Team C, Kiran. What was the first dose reduction? What is the first dose reduction for rucaparib?
400, sir.
The dose is 500 twice daily. Okay. Team A, we are coming back to you again for daycare rounds. Team A, your question. What is the filter pore size of non-PVC sets used for drugs like paclitaxel?
Sir, 0.5 micron.
That's not correct. Answer is 0.2 microns. Team B. What class level of biosafety tablets is commonly recommended for chemotherapy preparations? We had an IGMPO guidance for this.
2B.
Perfect.
2B.
Team C. Yeah, it's 2B. Team C. Which of the following drug extravasation injury is warm compresses not recommended as per the ESMO guidelines?
Mitomycin, sir.
Yeah, perfect. The answer is mitomycin. We come down to the next set, that is statistics. One question in each slide set, 10 marks for each question. There are no negative marks. Questions will not be passed to the teams. Time limit is 15 seconds. Team A, you're up first. Question is, which of the following trial was the first to evaluate molecularly targeted agents for off-label indications?
Shiva trial.
Perfect. Shiva is correct. Team B, you're next. Which of the following is an example of a platform trial?
Stampede.
Yeah, perfect. All correct. Team C, Kiran.
Sure.
Taylor X trial is an example of what trial design?
Non-biomarker direct design, sir.
Kiran, it's a continuous biomarker design trial. We come to set 6, radiation. I'm sure all will be going fast in this. One question each slide set, 10 marks for each question, no negative marks, but questions can be passed to other teams. Correct answer, 5 points then. Time limit is only 10 seconds. We'll start with Team A here. Team A, identify the radiation technique here.
Hippocampal sparing PCA.
Perfect. Team B, you're next. Identify the radiotherapy plan, team B.
TDCRT.
For?
4 fields, sir. 4 field TDCRT.
Organ.
Pelvis.
I'll give it to its prostate. I wanted, but I'll give it to its TDCRT for prostate. Team C, identify the treatment plan.
So it's for bladder cancer, sir. IMRT.
Kiran, that's not correct. Bladder is way too down here.
Bladder sparing IMRT. Bowel sparing, small bowel sparing IMRT.
Who is this? This is from?
Team A, sir.
Okay, I'll give it to, actually I wanted SBRT for pancreas, but I'll give it a bowel sparing technique. So team A gets 5 points. The next set of questions is for staging. Team A, you are up front. Up first, 2 questions in each slide set, 10 marks for each question, total of 20 questions. There are no negative marks, but the answers have to be precise. Team A, this is your question. Questions will not be passed. Time limit is 30 seconds.
T2 N2A, sir. T2 N2A, and in view of 2 nodes positivity, stage 3, I will prefer either 6 months of FOLFOX, sir. Modified FOLFOX 6 million.
What is your TNM staging again?
Sir, T2 N2A, sir. I will prefer 6 months of adjuvant treatment with modified FOLFOX.
It is T3 N2A. It is not T2, it is T3 N2A. You're correct with the second answer. I'll give you 10 points for that.
Yes, okay.
Coming to Team B. Team B, your question is?
High intermediate risk, sir.
Perfect. Next.
Two years.
2 years.
So actually it is very high risk. It is not high intermediate. It is 1.5 to 3. So I'll give it the second answer to 2 years. Team C. This is your question. 37 male non-seminoma. What is the age staging? Yes, persistent AFP post-surgery.
It's stage 3, sir. I would
Stage
choose
3
3
what?
cycles of.
Please be specific.
Sir?
What is the stage in that?
AJCC.
You have to be specific for the stage.
So stage 3 A, sir. Stage 3A, and 3 cycles of BP, sir.
Okay, both answers correct, Team C. So coming to the final round, that is the rapid fire round. Questions to be appeared in the sequence as they appear. If you do not know the answer, say pass. And after the last question is answered, you can come back to the unanswered questions. Questions answered incorrectly will not be attempted again. There are 8 questions in each, 5 points for 8 questions in each set, 5 marks for each, total of 40 points and no negative marks, but a strict time limit of 45 seconds. Team C will be attempting it first. Kiran will be attempting the slide set first. Are you ready?
Yes, sir.
Okay, so your questions are this. The time starts now. So drugs evaluated in the Peace 1 trial. If you are not going, just say pass.
Pass.
Maximum tolerated dose in spinal cord.
45 grays, sir.
Next, RT dose, phase B. RT dose in the phase B trial, the organ and the dose. You can say
40
pass
grays.
it
40 grays, sir.
That's not correct. Tram flap, what is the blood supply of the tram flap?
Pass, sir.
Pass. 5, what is the mechanism of action of gemcitabine?
Anti-metaboloid, sir.
Anything specific in that?
It's a purine analog, sir.
Okay, I'll give it that. Translocation mantle cell NHL.
11-14, sir. Translocation 11-14. 11-18.
Yeah, that's all right. That's correct. Avapritinib is target. The target for avapritinib is
SDH mutant, sir. SDH.
That's not correct. Colorectal cancer awareness month is
pass.
Kiran, I'm giving you 10 more seconds for your past questions. What drug is evaluated in the Peace 1 trial?
The time is up, Kiran. I can't give you more time.
Okay, sir.
Okay, so these are your answers. This one, spinal cord. Given the spinal cord, 45 is what you said. Tram flap is a superior epigastric artery. It's a pyrimidine analog. Gemcitabine, antimatomide. I'll give it to you. Mental is 1114. Avapritinib is D842 mutant, and colorectal cancer awareness month is coming up. So the next is Team A. Team A, are you ready?
Yes, sir.
Yes, sir. Okay, these are your questions. Drug evaluated in the Embraca trial.
Parikh.
Perfect. What is the maximum tolerated RT dose for the kidney? The mean dose?
16 grade.
Not correct. Next is passport trial. What was the dose given to the elective neck nodes?
Pass.
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 PMMC flap blood supplies from which artery?
Pass, right.
Both is pass. Doxorubicin and mechanism of action.
It is a topoisomerase 2 inhibitor as well as an intercalating agent.
Perfect. Correct. What is the translocation myxoid liposarcoma?
Pass. G12C mutation, sir.
Sotorasib G12C inhibitor.
Okay, KRAS G12C mutation. Perfect. Lung cancer awareness month is when?
November, sir.
That's a lucky guess. Coming back to question number 4, TMMC blood supply. One guess, lucky guess. Time is up.
Sir, axillary artery.
It's not axillary. The time is up. 4 o'clock. This is what I wanted. Kidney is 20 gray. I wanted. All right, Team B, your time. Are you ready?
Yes, sir.
So Team B, your questions are: what's the drug evaluated in the SOLAR-1 trial?
Olaparib.
That's not correct. What's the maximum tolerated Dmax for optic chiasma?
45 gray.
Oh, I wanted something specific. What is the dose in the cross trial?
41.4 gray and 23 fraction.
Correct, that's correct. Latissimus dorsi flap, what's the arterial supply?
Pass.
Pass. What is the mechanism of action of pemetrexate?
It's the antifolate, sir.
Perfect. Translocation Ewing sarcoma.
1122.
I'll give it to you. Pemigatinib, what is the target?
EWS. FLI1.
No, Pemigatinib is, that's not the answer. Then oral cancer awareness month is what?
March.
You should have listened. March. March is not oral. Coming back, latissimus dorsi flap, arterial supply. You don't want to attempt that?
Thoracic artery.
Still have 10 seconds left. And that's not. So alpelisib, optic chiasma 50 is what we're looking for. Latissimus dorsi is a thoracic dorsal artery. It's anterior. It's a bit posterior. Thoracic artery is anterior. Pemetrexate is antifolate. Ewing is 1122. Pemigatinib, FGFR2 was mentioned in the prelims. Oral cancer awareness month is April. So this gets us to the end of the mains. I thank you all. We had 23 teams participating from 17 institutes. I acknowledge my thanks to Purvish sir, Kavina Creations, my senior Bharat Changrajan sir for contributing to this quiz, and my colleagues Sujay and Dr. Dilip for their questions. Over to Kavina Creations. The results will be announced during the prize distribution ceremony.
Thank you very much, Hollis. I think you have become a master of all quiz activities, and I'm sure that the participants appreciated your professionalism in giving the right questions. May I ask the participants to join me in giving a big hand to Dr. Bharat and Dr. Hollis Kisutra. Thank you very much. Thank you very much. As Dr. Hollis said, please be logged in so that you hear the announcement of the winners. Over to Kavina Creations for the next session.
Thank you so much, sir. Thank you, Hollis sir. Thank you, Bharat sir. And thank you, Parikh sir. We'll now move on to our GU cancer session. And it gives me great pleasure to introduce our chairperson. First I will introduce our session director. My apologies. Dr. Lalit Mohan Sharma, who's also our organizing secretary. He's a senior consultant, Department of Medical Oncology at Shri Ram Cancer and Super Specialty Center, Mahatma Gandhi Medical College and Hospital, Jaipur. And I invite Lalit sir to please introduce our chairperson.
Thank you. Thank you so much, Dr. Hollis, Dr. Parikh sir, Bharat for excellent conducted quiz program. We always love that, and we always feel that we are not the participants to answer the quiz. So may I invite my chairpersons for the next genitourinary cancer session, Dr. Sadashivudu. He is additional professor and head of the Department of Medical Oncology at NIMS Hospital in Hyderabad. And along with him, my co-chairperson is dear friend Dr. Gaurav Goyal, who is senior consultant in the Department of Surgical Oncology at HCG Cancer Center in Jaipur. So over to you, chairpersons, for conducting the next session.
Thank you so much, sir. I now invite Dr. Gandhi sir to please introduce our first session, which is the debate.
Thank you very much for giving us this opportunity to chair this session. I think this again debates are going on very well over these ICON conferences. Really, they are doing a wonderful job, because as a day-to-day practice, we have so many questions and they are answering and they are giving their opinions also. And this again, the metastatic RCCs are one of the controversial. Again, we are suffering from plenty, because how to choose, what to choose, and where to choose. So with this, I think now we have the debate on IO plus IO is a standard of care in metastatic RCC by Dr. Mukul Goyal. Is a director and medical oncologist of Asian Cancer Research Institute, Jaipur. So I'll invite the first speaker, Dr. Mukul Goyal. Mukul, I think your voice is not audible yet.
Sir, can I request you to remove your headphones? So we cannot hear you. Can you disconnect the earphones from your laptop, sir? So we cannot hear you. Sir, we're not able to hear you. So will it be possible if you can log in from another device? From your phone, maybe?
Maybe Dr. Preeti can go first, no? And then Mukul can
I think that would be nice, sir. I think we can go to the next. I think anyhow, this debate is, again, they have the choice of rebuttal and everything. So we'll go to the next. We'll invite Dr. Preeti Agarwal. So she's a consultant at Department of Medical Oncology, Apex Hospital, Jaipur. So now she's going on IO plus VGF standard of care. So over to Dr. Preeti Agarwal.
Good evening, everyone. Am I audible?
Yes, ma'am.
Yeah. Okay. Let me share my screen. Okay. Let me begin with thanking organizers, Lalit Mohan sir, for giving me this opportunity to present. My topic for debate is immunotherapy plus TKI as a standard of care for first-line treatment for clear cell RCC, metastatic RCC. So to begin with, as we all know, the RCC is driven by biopathways of angiogenesis because of the inhibition, because of the loss of PHL gene, which controls HIF gene. And this, along with immunotherapy, immunity plays an important role in the progression of RCC. So our two main pathway remains inhibition of angiogenesis and immunity. So, so several treatment options are available for treatment of RCC, which have evolved through years. From 2005, we had sorafenib to sunitinib to pazopanib to exitinib. Now the immunotherapy has grown in the space with along with TKI, including nivolumab and pembrolizumab in combination of TKI like lenvatinib, exitinib, and cabozantinib. And IO immunotherapy combinations are also have come up. So these are the NCCN guidelines 2022 for kidney cancers for stage 4 disease. As we can see, in favorable risk, IO plus TKI, that is axitinib plus pembrolizumab, or lenvatinib plus pembrolizumab and cabozantinib plus nivolumab remains category 1 recommendation for favorable risk. In poor and intermediate risk, along with IO plus TKI combination, IO plus IO combination, that is ipilimumab and nivolumab, comes as first line category 1 recommendation for clear cell RCC. So what to choose, IO plus IO or TKI? So IO plus IO was taken like in Checkmate 214 study, where Nivo plus ipilimumab was compared with sunitinib. By IO and for TKI, we have 4 studies, which I'll discuss in detail in coming slides, where first line sunitinib was compared with IO and TKI. So coming with first study with Javelin Renal 101, where avelumab plus exitinib was compared with sunitinib in total population. Almost 440 patients were taken in each arm, and almost 270 patients were PD-L1 positive. We can see both the populations were controlled in all the factors, and favorable risk had almost 22% patients were favorable in both the arms. And we can clearly see there was good improvement in progression-free survival, as we can clearly see the separation of graphs, as there was absolute improvement of 5.3 months in progression-free survival, with hazard ratio of 0.69, that is 31% reduction in risk of disease progression or death. And pre-planned subgroup analysis also shows benefit in all the risk group, be it favorable, intermediate, or poor. As I already discussed, it shows irrespective of PD-L1 status, age, sex, or nephrectomy status, a combination of IO plus TKI improved progression-free survival in all the arms. Talking about overall response rate, we can see this clearly almost doubling of overall response rates from 27% to 52% with IO plus TKI, that is avelumab plus exitinib. Not only it increases the response rate, the time to response also reduces from 4 months to nearly 2.7 months. So the patients having bulky disease, not only they respond well, they respond fast as well. So not only PFS1 is improved, PFS2 is also improved, as we can clearly see the graphs separating. The PFS2 is 19.4 months with sunitinib, and it is not reached in IO plus TKI arm with a hazard ratio of 0.55. Coming out into next study, Keynote 426 study, where exitinib plus pembrolizumab was compared with first line sunitinib in patients of clear cell RCC. We can see almost 430 patients were taken in both the arms, and the favorable risk group were almost 30%, rest intermediate and poor risk were 70%. Both the arms were equivalent in the characteristics. So coming to progression-free survival, we can clearly see this good separation of graph with a hazard ratio of 0.69. The median progression-free survival was increased from 11 months to almost 15 months with IO and TKI combination. Coming to overall survival, we can clearly see the overall survival. There's good improvement in overall survival, and with improvement in overall survival from 35 months to 52 months with pembro plus exitinib arm. So as I already discussed, improvement in overall survival in total population, intermediate and poor. So intention to treat analysis population, there is good improvement in overall survival. It has good improvement in overall survival in intermediate poor risk as well. In favorable risk, it also improves survival, but it is not statistically significant. So there is improvement in progression-free survival as well as improvement in overall response rates. So coming to third trial, CLEAR trial, which compared lenvatinib plus pembrolizumab, IO plus TKI, along with lenvatinib plus everolimus versus sunitinib. So there were 3 arms. Almost 350 patients were taken in each arm, and almost 30% patients were favorable in all the 3 arms, and 70% were intermediate and poor. So coming to progression-free survival, we can see lenvatinib plus pembrolizumab clearly improves progression-free survival compared to sunitinib. We can clearly see that this progression-free survival is almost 2.5 times compared to sunitinib. From 9.2 months, it's almost 24 months with lenvatinib and pembrolizumab. Coming to and it is improved in all the subgroups, including favorable, intermediate, and poor risk, irrespective of the subgroup, irrespective of the PD-L1 status as well, as we can clearly see from this forest plot. Coming up to overall survival, lenvatinib plus pembrolizumab also improves overall survival, though data is not mature. We can clearly see the separation of graph and hazard ratio of 0.66. So coming to adverse events, so the question is whether the adverse event increase with combination of IO with TKI compared to single TKI. So we can see, of course, there are increase in adverse events, and I'll show to the next slide, increase in adverse events, but these adverse events are manageable. Although the discontinuation rate is not much, it is almost similar to the sunitinib. So coming up to our next study, which is TKI IO combination nivolumab plus cabozantinib compared to sunitinib. Here also we can see there is good improvement in progression-free survival with clear separation of graphs, and overall survival, though data is not mature for overall survival. So there is almost doubling of objective response rates as well. And although the toxicities are increased, but manageable. So summarizing IO plus TKI combination in comparison with the IO and IO combination, we can clearly see there is improvement in overall response rates, nearly doubling of overall response rates in some with combination of IO and TKI, with improvement of complete responses, improvement in median overall survival, progression-free survival. Though toxicity is increased, and you can see the discontinuation rate does not change much. However, with combination of ipilimumab and nivolumab, the discontinuation rate increases. But however, combination with IO and TKI, the discontinuation rates remain similar. Although grade 3, grade 4 adverse events do increase, but discontinuation rates does not increase. So I was discussing, so nivolumab plus ipilimumab, IO plus IO combination, it is approved only in poor risk or intermediate risk IMDC criteria. As you can clearly see in favorable risk, it does not increase overall response rates. So what is the importance of curves in clinical practice? In checkmate, we see this late separation of curves with IO and IO combination. It takes almost 6 months with separation of curves. While in Javelin trial, we can see the separation of curves is at beginning only. It shows that in patient with high tumor burden with high risk of rapid deterioration, treatment choice may be balanced slightly in favor of VEGF with IO versus IO and IO because of rapid improvement in tumor control. So as I discussed, the IO and IO combination, it has, though it has less adverse event compared to IO plus TKI, the discontinuation rates is very high. It's almost 22%, while in case of IO TKI, it is just 3.5% or 6.3%. And steroid use are also very high, like IO combination, almost 35% patient required high dose steroid use, while it was like 11%. And with axitinib plus avelumab and axitinib plus Keytruda pembrolizumab, it is 27%. So my take-home message is IO plus TKI remains first-line treatment of RCC in all the lines, in all the risk group, favorable, intermediate, and poor risk group. Although adverse event increase but are manageable, discontinuation rate does not increase with combinations. The only limiting factor remains cost. Thank you.
Thank you so much, ma'am. Over to our second debater, Dr. Mukul Goyal.
So, am I audible now?
Yes, sir, you're audible, sir.
Okay. Allow me to share my screen. Okay, is my screen visible? Okay, it's visible. So, first of all, many thanks to organizers who have given me this opportunity to be a part of this great academic session. My job now here has been made easy by Dr. CP already, mentioning all the clinical trials and all the approved agents. So I will be here, I am here now to speak in favor of IO plus IO combination in metastatic RCC. So this slide has already been
Sir, you can use the arrow keys, sir. Is that helping? Or you can use the mouse.
1 second. Yeah. Okay.
Yeah, there you go.
So this slide has already been shared by Dr. CP. I will not go into detail. All these trials have been covered in the previous by the previous debater. and I'll not go into detail. What I want to focus here, and I want to contradict from Dr. CP, is the overall survival with your Javelin trial, which you focused on, and there is no overall survival benefit as of now, which we can see. So I will keep this combination out of my basket when I'm choosing treatment for renal cell carcinoma. Again, I will keep out lenvatinib, pembrolizumab, although it is showing early efficacy, very good early separation of curve, but still longer activity and longer follow-up data we still don't have. What I will like to do is I will like to compare these two key trials of IO plus IO versus IO plus TKI. So now these trials have been discussed in detail by Dr. CC. I'll not go into detail. So my concern is the long-term big picture benefit achieved in patients with intermediate poor risk RCC with these new standard regimens. So if we compare these two graphs, they are almost similar in improving overall survival, but we have a longer follow-up for checkmate 214, keeping it a little up if I choose between IO versus IO TKI. Now, from previous use of interleukin 2, we came to know historically that plateau is what is most important. So, a curve that is plateauing in the responders, more durable benefit is there. So, is there a durable benefit with IO TKI? No, still we don't know. But ipilimumab, nivolumab, with the 4-year data, we now have seen that there is a plateau at 24 months. We see the overall responses. And coming to the immediate short-term outcomes in patients, in these patients, yes, there is an improvement in complete response rate, although not much, but CR is one which is more important in patients with RCC to have a better, more durable responses. Again, if we see progression-free survival curve, there is a separation of curves at 9 months, but what I want to focus here is at the plateauing of the curve again. So durability of benefit is what is more important at 30 months. We can see in checkmate 214 that there is a plateau which is achieved if we see, compare the PFS curve, which is not yet achieved with exitinib pembrolizumab. So number of important features stand out with the IO combination. The longest follow-up data of 4 years is one which is most important. And over that period, close to 1/3 of patients are remaining progression-free and a median survival is not yet reached. Similarly, at 4-year follow-up, 65% of patients have ongoing responses. So durability is the one factor which keeps IO plus IO at upper hand than IO plus TKI combination. Now, whenever we are choosing a combination or a treatment, we have a price to pay for it. That is the toxicity and quality of life, which should be taken into consideration. So again, I would like to focus everyone on these two trials. If we see nivolumab, ipilimumab arm, we clearly see that there were only 4 doses of ipilimumab which were used with nivolumab, and later on only nivolumab was used. So this gives us better compliance because in any IO TKI arm, you have to give TKI at home, and the compliance of which becomes a major concern along with the toxicity which is added for long term. So this is one of the benefits which is achieved with IO plus IO. So here is the toxicity profile already discussed by Dr. CP, but here what I want to focus is the grade 3-4 toxicity, which are much lesser with nivolumab, ipilimumab arm as compared to when we see Keynote 426 trial. The side effects, grade 3-4 toxicities are more. So whenever we are choosing a treatment for a patient, we see various factors including toxicity, quality of life, and various other concerns which the patient has. So quality of life analysis we have now with IO combination, that is ipilimumab, nivolumab. with checkmate 214, which is not available for other combinations of IO TKI. Now, again, as I already discussed, more than grade 3 toxicities were more with the IO TKI combination as compared to ipilimumab nivolumab arm. Now, the temporal toxicities also differ between these two combinations in the sense that if we give IO, that is ipilimumab nivolumab, grade 3-4 events arose early. As already Dr. PT has told that steroid use was also high. But at the same time, what we saw was that these typically resolved within first 4 to 6 months of the treatment, as compared to the chronic toxicities which we see with the IO TKI arm because of the addition of TKI. Again, when we are adding these two agents, it is difficult to find which agent is causing toxicity because of the overlapping toxicity. So toxicity management is again a concern when we are using IO TKI because both drugs are used for long. Now, a new concept which is coming up is the treatment-free survival in RCT. And again, et al. They presented data recently on the application of this outcome with and without toxicity. And what they found out was that at a follow-up of 30 months, treatment-free survival without grade 3 toxicity and more was better with ipilimumab nivolumab compared to sunitinib. So this data is not yet available with the if we compare with IO TKIs, and nearly 20% of patients who have received dual checkpoint inhibitor and subsequently discontinued therapy remained off treatment for 18 months. So the ability to improve quality of life by decreasing long-term side effects and cold treatment are compelling reasons that I should consider IO plus IO combination, that is dual checkpoint inhibitor combination in my practice. So here I rest my case favoring IO plus IO because they have better durability of response, better compliance because you are not using TKIs when you are using IO plus IO for better long-term safety profile, better quality of life already has been proven with IO combination, and the recent concept of better treatment-free survival is what it keeps at an upper hand. So with this, I rest my case. Thank you very much.
Thank you so much, sir. We received a question from Dr. Akhil Kapoor. Sir, may I request you to please unmute your mic and ask your question? Akhil, sir? Yeah.
Yeah. So this is a question to Dr. Mukul. How you justify having a very high early progression rates with IO plus IO combination while counseling a patient? How would you counsel and what steps should you take to minimize the same?
So PD rate, if we see with the IO combination, was almost around 27%, although, and this is a concern which actually we put to the patient because if in the early progressor, second line treatment becomes difficult. But at the same time, what I counsel the patient is that the safety profile of this drug is much better than IO plus TKI, so that they can choose with this.
Okay. Thanks.
Thank you so much, sir. If I can request our chairperson to give his expert comments on the debate. Over to you, sir. Sadashivdu, sir. Sir, can we have your comments?
I think both of them, they have debated very nicely. Only thing is, I think nowadays, because for the IO is a standard care nowadays, but still some people, especially Dr. Akhil Johambali, asked the same question. Rapidly progressors. So I think there's a problem is if even the immunotherapy taps will be slowly. Some but TK also has the same its advantage, disadvantage also. But both are, I think, based on side effects profile, toxicity, as well as the cost issues. Everything will play a major role in this one. I think very good debate. I think maybe in the next session, the panel discussion, they're going to cover some of the points in this one. And congratulations, both of them have done a good job. And next we'll go to the panel discussion.
Thank you so much, sir. Sir, can I request you to please introduce our moderator and our panelists? So it gives me great pleasure to introduce our moderator, Dr. Amit Rautan, who is a consultant medical oncologist at Manipal Hospital, Bangalore. And his topic is predictive biomarkers in metastatic RCC. Do they correlate with response to therapy? And his panelists are Dr. Abhishek Singh, Director and Head Medical and Hemato-Oncology, Chandan Hospital, Lucknow. Dr. P.K. Jayachandran, Associate Professor, Department of Medical Oncology, Cancer Institute, Adyar, Chennai. Dr. Uma Dangi, Consultant, Department of Medical Oncology, Fortis Hospital, Mumbai. Dr. Amit Joshi, Professor, Department of Medical Oncology, TMC, Mumbai. Dr. Ravi Vategaonkar, Consultant, Medical Oncology at Aditya Birla Memorial Hospital, Pune. And Dr. Akhil Kapoor, Associate Professor, Medical Oncology, TMH at Varanasi. So over to you, Amit, sir. So please note, Dr. P.K. Jayachandran and will log in soon, sir.
Okay. Thank you, Kashish. Good evening, everyone. I thank the organizers for this opportunity. So when I first saw this topic, I was a little bit intrigued. I thought we could do this panel with a quick fix answer, yes and no, and finish it off. So, but it's an interesting topic and it's interesting points to bring up. So I think it will be interesting to talk about, because we do talk about a lot about these survivals. We do talk about how we choose patients, but it's hardly in RCC we see talks about predictive biomarkers. So I was a little intrigued by this talk, and I think it will be an interesting discussion. So just now we heard that debate points. First line therapy has changed. We believe immunotherapy plays a very important role. It could be IO-IO or IO-TKI, and all of us are fully into it, that we believe that this is the best way forward for our metastatic RCC patients. So coming to biomarkers, what biomarkers do we use? Are we using any biomarkers in clinical practice? So let's just get to a quick start. Dr. Abhishek, do you think about using biomarkers in RCC patients when you see advanced RCC?
No, sir, I don't. As the recommendation also says that the biomarkers which we used to use in previous settings, like PDL1 and all, they don't have clinical correlations these days. So,
right. So nothing, right?
Yes.
Yeah. So I would agree with that. Dr. Uma, your thoughts?
I agree with Dr. Abhishek. In my clinical practice, I'm not routinely using biomarkers because it really does not change my therapy as of now. So I don't use it.
Right. So again, the same thought, on the topic, we could have easily sorted this out with a yes and no. So everyone would say, no, I know that. So Dr. Amit, what do you use when you see patients in clinical practice? What do you start? How do you stratify your patients? What do you start thinking and talking to your patients?
That traditionally, I think the day-to-day criteria IMDC risk score we use for stratify the risk scoring of the patient, and depending upon that. But if you say are the IMDC are the best marker, but I think no, because sometimes the volume of the disease, the characteristic of the patient, and we have seen in practice that sometimes even patient with good risk, they do not behave. We assume they should behave on the even IO plus TKI. So there is something beyond the IMDC. But the only thing is that the validation of these biomarkers has not been done. So whatever we have to take is the whatever best available. From that point of view, IMDC is the best available. It's not a biomarker, but it's a combination of the some parameters which we take in decision. But definitely, this field is rapidly evolving, and I think in due course of time, we should have a 1 or 2 biomarker which we can select the therapies.
Right. I fully agree with you. I think this is the only thing which is there for our patients, and this is the risk stratification of the IMDC, and this is what we do in clinical practice. I don't think we have anything else for our patients as of now. I kind of disagree with the right side curves which we see in the IMDC. These are curves which come out from the TKI era, and we know the poor risk used to be the ones which had the sarcomatoid kinds, and we know that they do the best in nowadays. So the curves really will change a lot. And I think we are eagerly waiting for that newer survival curves to come, which is going to come in the next few, I think in the next few years, we're going to see those publications where they are looking at a newer kind of stratification in the IO era. So I think that's going to be very important. But as of now, as Dr. Amit said, we only have the IMDC criteria, and that's what we use in practice. Dr. Ravi, if I can come to you, Dr. Amit made this point, but what do you do for your favorable risk patients nowadays? We intermediate and high risk, we are not debating. We all say IO, TKI or IO, and that we can debate, but we heard a very good debate there. But what do you do for your favorable risk patients now, currently?
Sir, Dr. Ravi is not there, but we have Dr. Uma.
Okay. So I'll just put this to Dr. Akhil.
Yeah. So, sir, most of the time in favorable risk patients, the benefit, we try to use sunitinib alone in most of our patients. That is what, though I agree that pembro plus exitinib is approved for the same, but the benefit of the same is minimal in specifically for good risk patients. That is what.
So you are more for TKI still in your good risk patients. Yeah, I think that's the way we all think about, and we do believe TKI alone, at least in low burden good risk, we are happy to do it. But high burden good risk, I think we still want to use an IO TKI, and that's the way we are thinking further for our patients. We think in the future it will definitely play an important role, right? So I think then let's get to the biomarkers which we want to talk about and discuss about. So we'll go ahead with the PD-L1 as a biomarker. Dr. Abhishek, what are your thoughts about PD-L1 in RCC?
Sir, PD-L1, when it was like initially it was used, but currently in the setting where we already know that in the setting where nivolumab ipilimumab trial was done, and they did not see any correlation with the PD-L1 in the favorable risk group. So I think the reciprocation of the PD-L1 status will not clinically have any benefit these days.
Correct. I think this is what Dr. Abhishek is talking about. You're seeing the PD-L1 analysis from the Checkmate 214 study. What they did was they looked at PD-L1 first, but just by looking at the TC. And with TC, they saw that about 30% of patients were PD-L1 positive. What they saw, PD-L1 positive patients, the benefit is clearly very good. But even in the PD-L1 negative population, the benefit was there. So the quantum of benefit, it was better in the PD-L1 positive patients. So hazards were better, but even in the negative, the benefit was there. So that's the reason why we cannot really say PD-L1 would hold good for a negative patient and we should use it. So recently they did a kind of an exploratory analysis where they re-looked at their PD-L1, but saying that maybe the TC is not the way in RCC. We believe that maybe even immune cells have a play a role. So they did a CPS and they looked at all this PD-L1 with CPS and survivals, and their PD-L1 positivity went up to 60%. And even with that, they saw the same thing. PD-L1 positive patients respond very well, but even negative patients do respond. So we cannot use PD-L1 as a biomarker. The other data sets also have looked at PD-L1. Dr. Amit, your thoughts on PD-L1 in the other trials? We looked at IO TKI trials where they looked at PD-L1.
I think if you look discuss towards the biomarker, I think it is one of the biomarker. We still not know the biomarker, and I think if you look across all other subtype of like an head and neck, lung, so to say that this biomarker will definitely predict the response, it's not the sacrosanct statement. So definitely among available biomarker which can predict, PDL is one of the biomarker. As you rightly told that even if the PDL is negative, this patient is not going to respond. No, it is not that. The magnitude of response may be better, but even PDL1 negative. So do we need to do in day-to-day setting? I think in RCC still the data has not matured enough or has not shown that indication that even PDL1 negative response. So we can discuss with the patient that the probability of response may be slightly higher, but even PDL1 negative will also going to respond. So in day-to-day setting, I don't think so that we will use the PDL1 for deciding the therapy.
Fully agreed. I think fully agreed. But Dr. Amit, do you have you at Tata done any looking at PDL1 in your RCC patients? Have you done some amount of it? Because we don't do it. No.
In routinely, we are, since it's not a we are not. It can be considered in a some sort of a trial setting or some sort of a thesis setting for some student. But in day-to-day setting, we are not sending as a part of the rarely as a part of the NGS panel. If it goes for second line, third line, when family wants to explore, we are doing. Otherwise, still we are not doing in the first line in the biomarker.
Right. Okay, so I think the PDL1 we conclude. But PDL1 per se has a prognostic importance. There was studies from the TKI era which clearly showed if you are PDL1 positive, your overall survival and PFS is poorer compared to PDL1 negative patients. So there was a prognostic significance, but clearly, as we have discussed and we have seen the data, even in the IO and the IO-TKI trial, it is not predicting for response. There are issues with PDL1, even in RCC, the same issues which came up in other cancers, which platform to use, which antibody to use, TPS or CPS, and they all create a lot of confusion. And people are going back and looking at it in various ways in their clinical trials. But as of now, a high PDL1 may predict for response, but even a low PDL1 patient can respond. So possibly we will not use it in clinical practice. So moving on to TMB, the next biomarker which we talk about for cancers is TMB, and RCC we know is right in the middle of the immunogenicity. It's not the highest of immunogenic, not very high TMBs like melanomas, but not the lowest of TMBs. And so Dr. Uma, if I can come to you, your thoughts on TMB, and especially the FDA approval came a few years back where every patient with greater than 10 TMB, they said you can use it in any cancer if you have used up all your lines of therapy. So your thoughts in RCC, and then thoughts on those that FDA approval. Could we use this and extrapolate it for RCC also?
So like you rightly pointed out, the TMB is not such a big thing in RCC, and there have been studies which have looked at it as a biomarker for predicting response, but all the studies have been negative. So TMB has not actually been validated in RCC, and I would definitely not extrapolate it from the other trials for the FDA approval, and just because I will not even routinely order it in my patients. So I think that TMB is not a good biomarker for RCC.
Right. I think so. That's what all the data sets are coming out. So this was what was looked at from the MSK impact, where they looked at 1,600 samples, about 9% were RCCs. In that data set, they had seen and correlated with response to other cancers. But what they found was in the RCC cohort, even when they tried to push up the TMB to the highest they could, there was no difference in overall survival. So TMB definitely is not coming out as a good biomarker for this group of patients. I would fully agree with that thought that TMB should not be clearly extrapolated very easily. The Checkmate 214 actually looked at TMB, and they looked at TMB, but apart from TMB, they also looked at tumor indel burden, TIB they called it. And what they saw is that TMB did not hold any association with PFS-OS. There was no significance, but the tumor indel burden actually had some association both with PFS and OS. But this is only the Checkmate 214 data, so really we don't know how to extrapolate this data. So as of now, TMB conclusion, definitely we will say it's not a reliable predictive marker for RCC. So we'll probably not think about it. Now, moving on to gene expression signatures, and that's what's come out a lot in a lot of talks, a lot of discussions. Dr. Akhil, what are your thoughts about these RNA signatures and gene expression signatures which have been used in all these RCC trials?
So, sir, the expression of small RNAs, siRNAs, these are coming up definitely, but we don't have any experience of doing those and seeing the patient based on those responses. So these remain investigational for us till now. Do you have any experience of using the gene expression signatures?
No, not at all. Not at all. I found this the amount of investment they are doing in trying to get an expression signature is huge, and it's amazing. They've looked at looking at various ways, and if you look at even there's no one specific signature. They have about 6 types of signatures, and eventually I don't know how they're going to take it over. I'll just show you that slide of the 214 data. They used all this. They tried with all these signatures. They used the Javelin renal signature, which was the one came out from Javelin 101. Then they used the tumor inflammatory signature. They used the T effector signature. They used the IM motion 150 myeloid marker signature. And they also looked at the T effector population using myeloid high and low. So they used all these 5 signatures, and all these 5 signatures are different. And all of them, not a single one correlated with PFS and overall survival. So clearly telling us there may be some benefit, but we really don't know what it is and how it's going to be interpreted. So this was one study where they analyzed all the 4 studies of nivolumab which have shown in the trials, and they saw the signature which looks for metabolic functions that correlated with poor response to treatment, and those signatures which had some immune markers correlated with higher response to treatment. But I think these gene signatures, like if you look at this example of IO motion 150 signatures, the angio signatures have different, and the expression we are looking at is very different. And if you look at IO motion T effector signature, then again the expression we are looking is very different. But eventually, most of these signatures are coming negative in clinical studies. So I really don't know where we will come out with gene signatures. It's clearly not going to be one of those oncotype DX types of gene signatures where we could do easily and tell us that this is where we can go further. I like this analysis from Checkmate 214 because they explained the whole thing well about their biomarker analysis. They said that they did the PD-L1 IHC, they did a whole exome sequencing, and then they did the RNA sequencing. And in the RNA sequencing, they divided into 2 parts where they did the gene expression signatures, the 5 of them which we saw, and they also did a differential gene expression where they did enrichment for certain genes. So they've done an extensive analysis to find out what may be the response, but eventually our line of association is right there in the middle, showing no significance. So I agree. I don't think there's any benefit of gene expression signatures. Okay, now sarcomatoid differentiation. I think this is one point where all of us will concur very, very uniformly. Dr. Abhishek, sarcomatoid differentiation in your practice, when you see a patient with metastatic disease? Oh, I seem to have. Dr. Abhishek is not able to. Okay, Dr. Uma, sarcomatoid differentiation.
Yeah, so obviously looking at sarcomatoid differentiation, one will obviously try to go for immunotherapy. Patient can afford it, IO or IO-TKI.
Absolutely. I think this is something that all of us have kind of really taken it further, and we believe in it very strongly. So just one point about it, it's seen in about 10% of patients, and that they were the ones on the high risk, and they had poor survival with the anti-VEGF therapy. This was analysis of all the meta-analysis of all the trials, the four phase 3 trials. 467 patients had sarcomatoid features. Half and half were given immuno and combination, and half were given sunitinib. And what we saw, PFS difference, hazards of 0.56, OS hazards of 0.56 with using immunotherapy. Overall response rate 52 versus 20, and CR rates 11 versus 0.8. Clearly telling us sarcomatoid, we are absolutely convinced, and we will definitely give some IO-based treatment.
Sir, yes. May I interject? Any particular percentage of sarcomatoid tumor which you think it is important to be considered?
So this has been kind of, I don't think there's a real good answer to this, because they say that even if some percentage of sarcomatoid is there, you should assume it to have some sarcomatoid differentiation and treat it that way. But I don't know. This is something we should put up to our, maybe go back to our responders in sarcomatoids and see, did the percentage really matter? I don't think it did matter. Dr. Amit, your thoughts, did it matter anywhere?
So the only issue when we discuss with our pathologists regarding the sarcomatoid percentage on that, generally what they say to us that this percentage they best can define when they get full specimen. So in a biopsy specimen percentage of area, they are not very, very comfortable. So they just write a sarcomatoid area seen. But if they get whole nephrectomy specimen, sometimes they said around 20 to, if there is more than 10 to 20%. So there is as such no cutoff of when to call it as a pure sarcomatoid. So sometimes if you see the histopathology, they write a conventional RCC with some percentage of sarcomatoid. But when percentage increases over certain number, which varies from different stages, they will label it as a pure sarcomatoid. Right. So in my experience or in my opinion, as you rightly told, that any amount of sarcomatized differentiation, irrespective of the type and even the papillary with sarcomatide, in one of a few of my patient papillary with sarcomatide, they respond as good as conventional the clear cell RC with sarcomatide. So I think, but you rightly point out that any component of sarcomatoid should be treated some sort of IO plus IO, whether IO plus some sort of TKI or IO. If you look to the data, I think in last ASCO there is some updated data of IO plus IO in the sarcomatoid. So if you look to the data of long-term data, the IO plus IO has some more long-term survival in terms of combination of IO plus IO versus IO plus TKI. So,
Right.
IO plus IO may have some edge in terms of the long-term follow-up.
Right. So sometimes I kind of think even IO alone of one drug is enough, and sometimes in sarcomatoid, the way we have seen responses. But yes, as the data said, it should be IO or IO TKI. That's the way it is. So now this is something very unique, which is something that is very easy to do, and in clinical practice you can do it every day. The neutrophil to lymphocyte ratio, NLR. Any thoughts on this, on NLR, Dr. Akhil?
Sir, it is definitely, we are trying to develop a cancer immunogram where apart from PDL1, NLR, and gender, the other autoimmune diseases, there are multiple things. So NLR seems to have some aspect in immunotherapy for all the tumors, but we are not very sure what amount it is there. So
right. So that's yeah, you're perfectly correct. That's the way it is. We think NLR is important in every cancer, but we don't know what significance it carries. This was our center's paper. We had done an ESMO abstract in 2019, where that time 37 patients in metastatic RCC, we had looked at NLR and we had put a cutoff of 5. So NLR less than 5, we saw response rates of 70%. NLR more than 5, we saw response rate of 15%. And even the median OS, it was hugely different. NLR greater than less than 5, it was not reached versus just 5 months in NLR greater than 5. So clearly, in our data sets, we found NLR is important in RCC. We also saw some importance in other cancers, and we had shown that in this kind of a small abstract. But yes, it is not one alone which can say that this is the one. That's the problem with NLR. So the data is very limited. There may be other factors which are affecting the NLR, but there is a lot of thought because this is so easy to do in practice. A continued effort should go on. There were recent publications which said that if it may not be only the baseline NLR, if you do an NLR after 4 weeks or 8 weeks, and if you see the NLR is going up, then probably the response is not going to be great. And if the NLR keeps going down, probably the response is going to be better. So they're looking at NLR in various ways. There are studies which are looking at sequential NLR also. PVRM mutations, this we have this is something that we talk about only in RCC. Dr. Amit, any thoughts on PVRM mutation usage? I know it's purely experimental. It's not something we look for.
I think what I can see from the all other the data from the other side, definitely in coming 2 or 3 years, we may come up with a signature, with a gene signature. So to implicate that only one will decide or one mutation will determine the efficacy versus, so that is not going to be. So I think it is going to be the panel 3 or 4 that will ultimately decide that responder versus non. So I don't have in end experience of PBRM mutation.
Correct. I agree fully. PBRM alone has been very controversial. So there was some data which came out from the Checkmate 025, and they had shown, again, there may be some importance to PBRM. We've actually had a couple of RCCs who did an NGS, and we saw they had the PBRM mutation. For some reasons, the NGS was done. But again, clearly we saw from Checkmate 214, even Javelin 101, there's no association. So PBRM is very controversial. I don't think we should use it in clinical practice. It's not at all an answer. And as Dr. Amit rightly mentioned, one marker may not play too much of a role. I think this is very interesting for all of us. This is something that is getting more and more important for immunotherapy usage. And talking of the GI microbiome, any thoughts and comments on this, Dr. Uma, GI microbiome?
Yeah, I think it is a very interesting area of research. I feel giving antibiotics, hampers the response to immunotherapy. So I find it really interesting. I really don't know how it happens, but probably the bacteria, the immune response of the body to the the tumor antigens, etc. So so whether to withhold antibiotics in these patients, but sometimes you want to give because if they are sick or if they have infection, then you do have to give the antibiotics. So but it's interesting.
Absolutely. So as Dr. Uma mentioned, patients who received antibiotics within a certain time and started immuno, they have not really performed so well. These have been studies which have clearly shown antibody exposed patients having poorer response, poorer PFS, poorer OS compared to those who did not receive antibiotics. And this study actually identified which are the bacteria which are responsible and which are found in non-responders and which are in responders. I think this was very interesting. This is this year's 2021 ASCO.
There is another data by, I think, Akhil in our group regarding the antibiotic. Akhil can
yes,
give some thought on that. Akhil.
Yes, sir. I had analyzed the data of antibiotic exposure and immunotherapy. That was for all the solid tumors, not confined to RCC alone. We had clearly found that use of antibiotics 2 weeks before starting of the treatment till the time of ongoing treatment, there was leading to reduced survival. So there are some limitations for that as well. The patients who are requiring antibiotics themselves are having some of the poor performance status or limited functions. That might be one of the important compounding factor, but definitely when we try to adjust for it also, the patients had poorer outcomes. So we have some of our own Indian data as well for the same.
Excellent. So that's very good to know. We have our own Indian data which is showing the same point which was mentioned by the international publication. I think definitely this is going to be important. My thought was this study which came out in this time's ASCO, it was a very small phase 1 study, but it was so impressive because they looked at IO. They did the patients with EP-Nevo and they added this bacterium and they called the product CBM588. It was a Clostridium. But what they saw was the patients who got Nevo EP plus CBM, the response rates were 59% versus only 11% with Nevo EP. And the PFS was hugely different in patients with a hazard of clearly a very significant hazard. So the authors really said this is something that maybe will come even in future for improving results over Nevo EP, because Nevo EP we know works very well and is the best treatment, but there is always a limitation. And they said that this is what can counter and move it upwards. So I kind of think it is going to be very interesting. But if you look at the guidelines, even now, we know clearly there is a decreased response, as Dr. Akhil has shown us, but the data is not prospectively validated. So the aim is always do not hesitate to use antibiotics if your patient requires it, nor do not give immunotherapy to your patients with antibiotics. Dr. Abhishek, yes, please.
I just want to ask a question here. Dr.
Yes.
Akhil, can you just tell us which of the group of antibiotics which are having more of this kind of adverse effect in your study, if you can highlight about that, so that we can, if we want to use it, we can avoid those things, if you have any data about it.
We have some supplementary data for the same as well. But if we see, the problem is that most of the antibiotics are having effect on the gut microbiome. So we use most commonly, as in our TMH practice, ceftriaxone sulbactam is used as a first line antibiotic in most of the cases. So that was was used in maximum number of patients when the patient presented with fever in our casualty or OPD. So since 70% patients received that, the data was skewed towards that. So we found that it is causing maximum problem. So we cannot say based on this data that which one antibiotic is causing most of the problem.
This is definitely a interesting data to look forward. And I think this particular biomarker, I think, can be of use.
Definitely. It's something very straightforward. Yes, Amit.
Recently, I came to one of the article. It's not in RCC, but I think that was very exciting when I read that paper regarding the malignant melanoma, the responder versus non-responder. So what they did in a non-responder patient, they did the fecal transplantation, like in ulcerative colitis is already one of the, or Crohn's disease, the IBD disease. So it was a phase 1 or 2 that I don't remember at this point of time. But when the fecal transplant from responder to the non-responder, the non-responder becomes a responder. So that ultimately proved the concept that gut flora plays a very important role. We don't know how to modulate, and it's very important in our scenario when we have to use for can we use for a shorter period of time? Can we use with the less dose? So I think that is going to be very, very exciting data for us, that if we can modulate the GI, and it's very cheap. The GI, if we know how to modulate that, that will be a very interesting. But, and from the melanoma paper, I was really very excited to, but it was abstract, so I could not read the full.
No, you're correct, Dr. Amit. There's been some excellent data about that gut modulation, trying to change the microbiome for getting non-responders to responders. Actually, there was some paper initially which said just giving Sporlac and lactobacillus may help, but then later it showed that it won't help. And initially there were a lot of people talking about, let's just give this and see whether that will make a difference or not. But it did not help actually. But very interesting. And I think these are very small points which may make a big difference to our patients. Sometimes we misuse antibiotics a lot also in practice. And maybe it may be something that we have to be aware when we are talking to our patients and giving them immunotherapy. Dr. Hemant has just made a point about I would also like to reiterate that I remember 3-4 years ago when I was presenting one of the immunotherapy lectures, Dr. G.S. Bhattacharya spoke to me about this, and he told me also the same point. He told us that, why don't you look at these lymphocytes? Why don't you just do a simple thing and see these lymphocytes and see whether that makes a difference or not? And he also had told about an antibiotic exposure for RCC. And he told, see, these are immune modulatory antibiotics. And I remember him telling me, azithromycin at low dose is immunomodulatory. So you can actually look at how it works in cancers. It was amazing the way he thought about modulating treatments with an easy way for our patients. So I think we're running out of time, but we have covered everything.
Dr. Amit, I have just 2 basic questions. One is about role of nephrectomy in the treatment of metastatic RCC, and second, in the neoadjuvant and adjuvant setting, any role of IO or any recommendation of the panel.
Sir, so on this role of nephrectomy, so very, very controversial, sir, nowadays. Though we still believe and we do it. So we have made everyone makes few recommendations. So we kind of in our minds have made it. If we see an intermediate and high risk patients and we are offering them IO or IO TKI, we are not offering them nephrectomy very early. But patients with favorable risk, irrespective of what we treat, when they respond well, we are offering nephrectomy in our clinical practice. I think the panelists, would you kind of take up this? Amit, you think this is the role?
I agree with you. The problem or the issue is with the when we are little bit certain about the use of or the nephrectomy at TKI era. So things were little bit uncertain. So if we are going for only TKI, patient with good risk, you can go ahead with nephrectomy and then you can continue the TKI. Patient with intermediate or poor risk, if they are not very much symptomatic or not, so we can wait for those group of the patient, give the TKI, reassess after 6 to 8 months. If they respond well, general condition improves, then after 6, 8 months or 10 months, go for a nephrectomy. So it's an interval. With the IO, things are not still clear. We don't know so there are 2 schools of thought. One school of thought says that if you remove the primary tumor, some sort of new antigen formation goes down and it might not respond. And the other thought, but Amit, I told that we are still continuing at our setup also. If patient is not if patient is presenting with some local symptom, then we may go ahead with intermediate and poor. But if it's not much symptomatic, we start with the IO plus IO or IO TKI. If there is a complete metabolic CR in other part of the body, say let's after 1 year, then we can have a discussion regarding the nephrectomy in those group of the patient. That's what we do in KMH. I think other cannot.
So we have not stopped doing nephrectomy. We have postponed the nephrectomy.
Yes. So it's an interval.
Yes.
Yes. So responder will be considered and non-responder may.
Correct. Sir, what was your second question, sir?
Regarding the new adjuvant and adjuvant.
New adjuvant and adjuvant treatment.
So adjuvant, we've seen now we have approval of Pembro. Your thoughts, Akhil? What would you do?
Sir, for adjuvant, we have the some small experience of using adjuvant TKI, sunitinib, for our patients. And I was the student of Amit Joshi sir for a long time at TMH. So under his guidance only we have the experience. In node positive patients specifically who are fit enough, where we think the patients will get tolerate the treatment, there we have used sunitinib, but these are some limited numbers. For adjuvant Pembro, we have very limited experience. I have used it only one patient till now. The benefit for the same, is it there for long term? Survival benefit is there or not? We don't know. That is why it is selected on very strictly case to case basis, where we think the disease is imminent to come back very shortly, where we feel it's only selected patients.
So that agreed fully. The data is there now, but it's a little bit difficult. It's only disease-free survival. Secondly, we believe that DFS will come to OS because in IOs it will happen. It doesn't happen in TKIs, but in IOs we expect it will happen. But we have to be very careful. We should not be overusing it because IRAEs can happen. So we worry about it in the adjuvant setting. I'm not fully convinced I will offer it to all my patients saying, do it, because there's a big segment who does really well without it. So it's a little controversial. Amit?
Yeah, so I think, Amit, looking to the data and all that, when we read about that, I think there are two patient subgroup which I definitely discuss and recommend is the node positive, because they are going to do poorly. So a node positive or a patient with sarcomatide or patient who have a M1 NED, so that a metastectomy has been done, and now so these are the three groups of the patient where I discuss with in a T3 tumor. You may not T4, some T4, but node positive, sarcomatide, and M1 NED. These are the three subgroups where we should push for or we should discuss encouragingly to the patient for the use of adjuvant Pembro.
Absolutely. I think Dr. Amit has given the perfect 3 patient pools where we would think about it and discuss about it. And I think that's the way further. So we'll slowly be talking about it more. I think by next year, all of us will start getting experience in adjuvant to understand. New adjuvant, sir, the Prosper trial is on, which is looking at 2 cycles nivolumab new adjuvant, and then they have done the surgery and then continued adjuvant. I think that data set is not yet out, but it will be out soon.
And it will be positive.
It depends on the risk of patients.
Lung, if you see any across, I think in next 5 years, everything will be new adjuvant, and then something else.
So we had a patient who was a 75-year-old gentleman with one big RCC, but he was operable, but he could not be operated because he had a thrombus in the bilateral pulmonary vein. So they kind of say this is a saddle thrombus. We can't take him. He's very high risk initially for surgery. So we gave Nevo 4 doses. By the time we gave anticoagulants, the clot went off. 4 doses later, the surgeons operated, and with the remote, it was pathological CR. And this was 2 years back, and we didn't give him adjuvant, and he's still doing fine.
Sorry to interrupt.
Is there sorry? Was there any increased risk of complications post immunotherapy in surgery?
No, not at all. Not at all. I think that's the part of immuno. It becomes quite easy giving them. So I think Kashish is telling us time is up. So thank you, everyone. I think I enjoyed this panel because this is a very different discussion, and biomarkers is something we don't talk about too much. Thank you, all the panelists, for that excellent discussion. Thank you, the organizers. Thank you.
Thank you. Thank you. Bye.
Thank you so much, sir. I now request our chairperson to please introduce our next speaker.
Always here.
Okay. Sir, I'll request you to introduce the speaker so we don't have Dr. Gaurav on board.
Yeah, okay. Sir, again, we'll go to the next session is again the molecular classification of urinary bladder. So again, this immunotherapy is going on. I think really it is a very interesting area. And today, I think none other than our speaker is Dr. Vinit Talwar, the director of Department of Medical Oncology, Rajiv Gandhi Cancer Institute, New Delhi, and is a well-known speaker and very good orator. Sir, I think over to you, sir. So.
Thank you, sir, for the kind words. And I'll just try to share my screen. Am I visible? Am I audible? Both
Yes,
together
sir,
at the
your
same time?
slides are visible and you're audible.
Okay. So the topic which was given to me is the molecular classification of bladder cancers, which is the most exciting topic as of today, because you know that bladder is the 10th most common form of cancer globally, 4 times common in men. And amongst the cancer, it is the 6th most common cancer and the 9th leading cause of cancer death. It is a very notorious cancer in the sense that the incidence of cancer and the mortality, they are almost going side by side. The incidence varies globally, prevalence of tobacco smoking being the main risk factor for bladder cancer, as all of us know. So if you speak histologically, so I'll go retro, I'll not talk about molecular. Histologically speaking, it can be subtyped as urothelial cancers, squamous cell cancers, and ectocarcinomas, with the urothelial cancers having the maximum constitution, that is 90%. And again, histologically speaking, you have two basic types, on which we hinge our present decision making and the treatment paradigms. And the first one is the non-muscle invasive bladder cancer, which is low grade and superficial type, which is also known as NIBC or NMIBC. The other one is the MIBC, that is the muscle invasive bladder cancer, which is universally high grade. But if we look at the molecular pathways, we find paradoxically both of them, whether it is NIBC or whether it is MIBC, they have divergent molecular pathways, whether it is tumorigenesis, whether it is biological behavior, or whether it is the molecular profile. So this is just to show you how much is the paradox whenever you look at the subtypes of classification, whether you go from 2003 to 2016 to 2022. The basic classification which I'll be talking about is the Cancer Atlas, the TCGA classification, and also the consensus classification. But if you see closely, you find that the common denominator in all of them is the luminal type and the basal type, and the rest are offshoots of this. Either they are double negative, null type, or a neuroendocrine type, or a basaloid type, or a basosquamous type, whichever way you might look at it. So let us see the basal type. The basal type shows similarities with the basal subtype of breast cancers. And as you have seen that there is a Claudin low subgroup which was identified. So these outcomes are similar to what it was in the breast cancer, and it is rich in the EMT, that is the epithelial mesenchymal transition signatures and tumor initiating cell markers. These are found to be more frequent in females, and they have a high rate of retinoblastoma pathway gene alterations. And if you go to the luminal type, you find that that is associated with FGFR3, which is the most common amplification mutation genes in the luminal subtypes, and the targeted FGFR. And it has a promising treatment in the sense that there are drugs which can be targeted specifically for FGFR, which we see commonly in our treatment nowadays in the second line after the first line therapy in metastatic CA urinary bladder. The other one is the PIK3CA. It is also a common activated mutant gene which is targeting the PI3K pathway, and that also is very effective in luminal type. So these are the molecular alterations which are seen in both of them. Coming back to the classifications, now we focus on the TCGA classification. If you see this classification, initially it had 3 clusters and then it had 4 clusters. The cluster 1 was the predominantly papilloma type, which was enriched with FGFR3 inhibitors. Cluster 2 was the one which showed FOXA1 and UPK3A transcription factors. Cluster 3 was the squamoid type, and cluster 4 was the Claudin low, which was, as I mentioned, in the breast cancer. Subsequently, there was a further expanded classification into 5 distinct types. The luminal was further divided into 3 types, that is the luminal papillary, luminal, and the luminal infiltrative type. And then came another subtype, which was the neural subtype, which was added into this basal subgroup. So you started with 3 clusters, then you landed up with about 6 clusters. So this was the TGCA classification. Another classification which has come recently, this is the consensus classification, which was spearheaded by Dr. Kemon. And this is basically directed towards the muscle invasive bladder cancers. So they had a consensus over about 19 pathologists who were there. And they took out a consensus statement which was published in the European Association of Urology. And here they have classified luminal into 3 types. That is the luminal papillary, luminal unstable, and luminal specified. So this was on the lines of TGCA. And again, there is another one which is stroma rich, basal or basal squamous. And the last one is the neuroendocrine-like, which forms just about 3% of the cases. So a large chunk is of the luminal type and the basal type, which are the basics whenever we look at molecular classification in urinary bladder cancers. If you look at the oncodrivers, you see luminal predominantly is the FGFR pathway, or sometimes you have the ERBB2 with the genomic instability. But if you look at the basal pathways, it is predominantly T50, TP53 and the EGFR pathways. And in the neuroendocrine, you might have either both of them, or you might just have the TP53 pathways. So if you see the intrinsic molecular subtypes of the NIBC, that is the non-invasive bladder cancer, the genomic expression analysis have shown that there is a distinct expression signature which is associated with cancer progression, metastasis, and survival. So there are 3 molecular subtypes which are majoritarily seen in the non-muscle invasive bladder cancer. And these are the ones which express the FGFR3 and the cyclin D1 pathways, that is showing to have good prognosis. There are some which show FOXMI, that is the forehead box M1 mutations. So these come under the intermediate outcome. And there are the other ones which are the basaloid type, which have CK5 and CK14 overexpression. These are associated with the worst prognosis. So coming to the muscle invasive bladder cancer, again, there are 3 types. The first one is the basal type, and this has basically squamous and sarcomatoid features with expression of CK5, 6 and CK14. And they are unfortunately present in advanced or metastatic diseases. And the key point here is that they are highly sensitive to cisplatin-based chemotherapy. On the contrary, luminal type is the one which has FGFR3 mutations and ERB amplifications. And this is again divided into 2 types, that is P53-like and the luminal type. So P53-like ones are the ones which are resistant to chemotherapy. So here you have some kind of clinical connotations that patients who have a basal type, they are the ones who have sensitivity to chemotherapy, whereas the patients who are the luminal P53-like, they are the ones who are resistant to chemotherapy. So again, going back to the classification, so we have gone from 6 clusters, we have gone to the consensus, which again has 6 clusters, but here again, there is an association of neuroendocrine-like and basal squamous, which was not there earlier in the initial TCGA classification. But nevertheless, as I said, you have basal luminal and you have neuronal. You find that there are similarities between the molecular subtypes in the different classification systems, whether they are luminal and basilar. And you can see from this color coding that you find that the green one is the luminal and the red one is the basal. You find there is a great overlap in most of the classifications, across the classifications and across the tumor types, whether it is muscle invasive or non-muscle invasive. We also did a small study in our institute at Rajiv Gandhi Cancer Institute, and we analyzed a case, 71 cases in which 90% were males and 10% were females. And we found that about 60% had basal type markers and 20% had luminal markers and 10 were the unclassified ones. But unfortunately, when we tried to find a concordance between this and the outcome of treatment, it was a kind of a mixed bag experience. So nevertheless, what could be the clinical connotations or the clinical applications of this molecular classification? Although this has not been put into practice, this has not been accepted into practice like other molecular classifications. But still, when we see the luminal subtypes with the relatively mature differentiation, they tend to have a better prognosis, while the basal and neural types have a poor differentiation, they have a worse prognosis. So the luminal types are the ones which are sensitive to neoadjuvant chemotherapy. And this has a very great connotation simply because of the fact that most of the patients in CA urinary bladder, they get neoadjuvant chemotherapy. So this could be a pointer as to which ones would actually benefit from neoadjuvant therapy, which one would not. And the basal and the squamous types, they have a poor prognosis, unlike the luminal types, which have a better prognosis. And these are the ones which may actually benefit from chemotherapy. So if you have the luminal type, you find that they may not benefit from chemotherapy. If you have the basal type, they are the ones which may benefit from chemotherapy. The other application is that based on the comprehensive analysis of the genome, the transcriptome, and the non-coding RNA of the bladder carcinomas, molecular subtyping provides a new direction for personal and precise treatment. So if you see the non-muscle invasive bladder cancers, you find, as I've already told you, that they have the FGFR mutations, the PIK3CA mutations also, whereas if you see the muscle invasive bladder cancers, it is more of TP53 and RB1 mutations. So these altered genes are involved in a number of important biological processes. So if you target them, or if you have good agents which can practically target them, then probably it can lead to the arrest of disease. So again, if you see the immunotherapy potency, according to the molecular classifications, we find that unfortunately, not all patients benefit from immunotherapy. The luminal infiltrated subtype, which is seen in the TCGA classification, they are moderately expressing the PDL1 and the CTLA4. And in particular, although this subtype is not sensitive to neoadjuvant chemotherapy, paradoxically, it has a good response with immunotherapy. So this again gives you a clue as to how to give immunotherapy in which patients and how to give chemotherapy in which patients. And in addition, the basal squamous subtype is sensitive not only to neoadjuvant chemotherapy, but to a certain extent to the immunotherapy also. So if you have the luminal type, probably there might be a shift towards the immuno-oncology drugs. If you have the basal type, then probably you can go for any one of them. But wherever you have the additions, where, as I have told you, that you get clues as to the neoadjuvant chemotherapy, wherever you can give chemotherapy or wherever you can give immuno-oncology drugs, there are certain limitations with the molecular subtype. So unlike the traditional pathological classification system, where it was easy to obtain the pathological parameters and the prediction results were approximate, the molecular typing is based on static research. That is, it is the detection at that point of time, and analysis of tumor specimens are done at that point of time, and there is no dynamic tracking. So molecular subtyping is basically focused on the genome and transcriptome research. Whereas we find that apart from this, there are certain paracrine pathways, apart from these autocrine pathways, whereas there is an effect of proteomics and also the immune status of tumors, and they are also closely related to their development. So instead of just the transcriptome research, it should be a multiomics, which should be included in the study of molecular subtyping. And bladder cancers often exhibit intertumor heterogeneity. This is a very well-known fact, and it has been seen in certain clinical studies where a sampling of the tumor was done and they found multiple targets at multiple sites. So this could be a problem whenever it comes to molecular subtype predictions. Compared with the traditional pathological classification, molecular subtyping offers a more comprehensive analysis of the genome transcriptome and the non-coding RNA. It has an importance in the guidance of adjuvant therapy or targeted therapy or immunotherapy, as I've already mentioned. But then again, the last word is still to be said, because as I showed you, there are so many diverse classifications. You can't just base your treatment on the genome and transcriptome. You have to use the proteomics also, which subsequently I feel will be used whenever you come to a definite molecular classification. Until the time, we have to rely on whether it is muscle invasive, whether it is non-muscle invasive, whether it is a liminal type, whether it is the basal type or the basaloid type, or whether it is the claudin low type, which is seen in the breast cancers, coupled with the genome and the transcriptome markers. So if you see a rough flow chart of a non-muscle invasive bladder cancer as far as the predictive and the recurrence values are concerned, you see when you use the traditional and traditional marker, there's a rough prediction. And when you add the novel subtyping system based on the signatures of genomics and transcriptomics, it reflects the intrinsic characteristics of the bladder cancer, which we have not still reached as of now. But when that is there, a coupling of both of them, then there could be a risk assessment of the progression and recurrence, the therapeutic responses, the resistant patterns, whether it is resistant to chemotherapy or immunotherapy, and of course, it could give you the clinical prognosis also. And that is which is going to be from the future subtyping system based on the multiomics alteration.
Sir, apologies.
I think I'll stop here. This is my
Thank you
last
so
slide.
much, sir. Thank you so much, sir.
Thank you.
So we'll move on to our next session. I invite our chairperson, Dr. Gandhi, to please introduce our next speaker.
So thank you once again, sir, Varsha. The next speaker again, Dr. Abhishek Singh, is the Director, Head of Medical Hemato-Oncology, Chandan Hospital, Lucknow. The role of immunotherapy in urinary bladder cancers. I think immunotherapy started in melanoma as well as urinary bladder. So now he's going to take us through this again, immunotherapy in urinary bladder cancer from interferon. I think everybody knows interleukins, interferons, and BCG, and everything they initially started in the bladder cancer only. Then we, of course, maybe Dr. Abhishek Singh will explain and where we can use it. Dr. Abhishek, over to you now.
Hello. Yeah, I'm just trying to
Yes,
upload my slides.
Sure, sir. Sir, are you facing any difficulty?
Yeah, I just want to share it, but I am not able to. Do you have my presentation with you? I already shared it.
Yes, sir. We just shared the screen, sir.
Yeah. So good evening, everyone. The topic given to me is a role of immunotherapy in urinary bladder cancer. Today I'm the last speaker of the session probably, and followed by that we have a very good debate on a role of HPV vaccination. So I'm just going to talk about the role of immunotherapy in bladder cancer. Dr. Talwar sir has already mentioned. I'm not able to rotate it.
So request you to say next slide. We'll move the slide.
Yeah. So Dr. Talwar sir has already mentioned about the incidence and the highlights about the significance of the mortality rates and everything. So I'm just going to skip these slides and straight away going to the next slide. Next slide, please. So the evolution of systemic therapy for bladder cancer, it goes like that, from last 2016, there are so many changes has occurred in the field of immunotherapy in bladder cancer, where initially durvalumab was got the approval by FDA in 2016. Then several other atezolizumab and nivolumab and pembrolizumab has got approval. And then recently, two drugs has been withdrawn from the treatment guidelines, durvalumab and atezolizumab, in March 2021. Next slide, please. So treatment of bladder cancer, if we have to give briefly, if it is a non-mother invasive bladder cancer, the role of immunotherapy is there in some patients, where after TURBT, if they have any progression, we can use pembrolizumab in those patients. For muscle invasive bladder cancer, where if it is cisplatin eligible patients, we should be giving a neoadjuvant cisplatin based combination chemotherapy. And for cisplatin ineligible patients, we can substitute with other combinations. And then if there is progression, we can go with the other mode of therapies. And for metastatic disease, if immunotherapy has the limited role in stage 4 disease, metastatic bladder cancer, where we can use it in the cisplatin eligible patients also, and in the cisplatin ineligible patients also. And the role of avelumab was found recently in a recent trial by Javelin 100 trial, and it has proved the role and its benefit as a maintenance therapy. And recently, as I said, durvalumab and atezo has been withdrawn, and second line therapy as a immunotherapy is approved only for pembrolizumab and avelumab. And there are other drugs which are except from the ICI group. We have other groups of drugs like FGFR inhibitors and some antibody drug conjugates, which has found a role in bladder tumors. Next slide, please. So if we see the patient attrition rate from first line to later lines of therapy is drastically, the change, there is a lot of difference. Patients receiving first line and the attrition rate is too much to get the second line chemotherapy. So the main focus should be to optimize the first line therapy in metastatic urinary bladder cancers. So our focus has to be to optimize the correct sequencing and correct treatment guidelines in the first line itself. Next slide. So there are three approaches which has been studied for the metastatic urinary bladder cancer. One is wait and watch approach, which was the till now it is the standard of care, and we see whether patient is cisplatin eligible or patient is not cisplatin eligible. We give first line chemotherapy and then we wait till there is a disease progression. If there is disease progression, we go for the second line therapy. Until now, this was the standard of care. The regimen which we can choose, we already know that it can be the multiple drug regimen, including methotrexate, vinblastine, doxorubicin, and cisplatin, or it is gemcitabine cisplatin. And those patients who are not eligible for gemcitabine, cisplatin, we can choose carboplatin in those patients. Next slide, please. So urothelial carcinomas, they are the for last 20 years, platinum containing chemotherapy has been the standard of care because of its high initial response rate. But even this has got limitation that 25 to 50% of the patients, they do not receive second line therapy. They either progress or they are not eligible for the second line therapies. And 64% of the patients, they progress within 9 months. And if the response is there, which is almost 75 to 80%, even that responses are also not durable, and they don't translate into the median overall survival benefit. The survival benefit which we can have is almost 12 to 15 months. Next slide. So then the next approach was evaluated in the recent trial, Javelin 100, where they used the switch maintenance approach. What they did was they started with first line chemotherapy, and they after some interval they did radio imaging to see the response if patient has not progressed and there is some response either in the form of complete response, partial response, or the disease is stable. Then they started with the first line immuno-oncology drug as maintenance therapy. And this approach was labeled as a switch to IO maintenance. If there is disease progression later on, then second line therapy has been introduced. And the third approach is continuous maintenance, where chemotherapy along with immunotherapy drug started as first line. For the fixed duration of time, the chemotherapy was given, and then if there is no progression in the form of the response is there in the form of either a complete response, partial response, or stable disease, then only immunotherapy drugs has been used as the maintenance. And similarly, if there is disease progression on that, so the second line therapy was started. So these two approaches were studied later. Next slide, please. So for the rationale, if we see the rationale for maintenance therapy in bladder cancer, so the urinary bladder cancer is chemosensitive, and their response almost 70% response has been seen in first line therapy. And if we see the urinary bladder tumors are they are highly immunogenic. So if we start immunotherapy drugs as a maintenance, probably the response will be sustained, and we can have longer OS benefits and PFS benefits also. And the other benefit which we can drag from starting immuno-oncology drug as maintenance, that we can see whether disease is controlled or not. If the disease is not controlled, we may not use it in the later line of therapy. So these two are the rationales why maintenance therapy, immuno-oncology drug has been evaluated as maintenance therapy. Next slide, please. So this was the approach which Javelin Bladder 100 trial has they studied, and started with chemotherapy for fixed duration of time, and then later on response is there, so maintenance was started. Next slide, please. Avelumab is basically it's an anti-PD-1 L1 immunotherapy drug, and it has got two approaches. It has adaptive immune response and innate immune response also. NK cells will be induced, and they also will have the tumor lysis effect, apart from the PD-L1 and PD-1 blockage. Next slide, please. So this schema of the trial was chemotherapy was given as an induction chemotherapy in the unresectable, locally advanced or metastatic bladder cancers, and they receive first line chemotherapy either 4 to 6 cycles, cisplatin gemcitabine or carboplatin gemcitabine. Treatment free interval was 4 to 10 weeks. Then the radiological assessment was done. For those patients who are not progressed, they were given maintenance of avelumab 10 milligram per kg every 2 weekly, along with best supportive care. Other arm was compared with the best supportive care only, no maintenance therapy. And the primary endpoint was OS. Primary analysis populations were all randomized patients, and also they also did the subset analysis of PD-L1 positive populations. Secondary endpoint were they were PFS, overall response rate, time to response, response duration, disease control, safety, and tolerability. Next slide, please. So these were the baseline characteristic. They were all matched in both the groups. They also the ECOG performance status was 0 to 1 mostly. Even they included some of the patients in 2 also. The visceral and non-visceral metastasis also has been evaluated, and all they studied the effect of maintenance across all the regimens, whether it is GemCis, GemCarbo, or any of them. Next slide, please. So this was the primary endpoint. We can see the avelumab maintenance improves the overall survival. If we can see in the both whether it is overall population, the survival benefit of almost 21 months, and the range of median duration of overall survival was almost 25 weeks. And in the PDL1 population, it is almost they were still on the maintenance till this was published. Next slide, please. Secondary endpoint, again, there was benefit, improved PFS benefit were seen in the avelumab maintenance therapy, where the study arm had 3.7 months of PFS benefit compared to best supportive care arm, and the PDL1 population, we have seen this 5.7 months of the median of PFS. Next slide. So as I was saying that all the first line therapy regimen, whether it is gemcitabine cisplatin combination or gemcitabine carboplatin, the OS and PFS benefit was seen, which we can see in the graph. The early separation of the curves were there. Next slide, please. They also see the median overall survival improvement has been noticed after the chemotherapy, prior response to chemotherapy, whether it is complete response or whether it is partial response or a stable disease. The median overall survival benefit has been noticed. Even the next slide, we can see the PFS benefit also were noticed in whatever the response to chemotherapy initially was there. Next slide. After giving maintenance, if there is a progression, still patients receive multiple drugs. But as I was saying, the rationale of giving maintenance chemotherapy, immunotherapy, as this patient has already received immunotherapy, in the maintenance, they did not give much of immunotherapy drugs. But other group of drugs like FGFR inhibitors and chemotherapy drugs has been used in the study group. In the best supportive group, where immunotherapy was not exposed, they gave subsequent line of therapy as immunotherapy and FGFR inhibitor and other chemotherapy. Next slide, please. The secondary endpoint was one of the secondary endpoint was safety in the overall population, and there were no new safety signals or concerns were identified. Whatever the safety profile for avelumab was consistent with the monotherapy use. The same side effects profile has been noticed. There were no significant treatment emergent adverse effect, and they reported only a few deaths as a treatment emergent side effects from the avelumab group. Next slide, please. The other secondary endpoints, FT, only hypothyroidism, rashes, and other significant some rashes were the side effect profile, and they were managed with the high corticosteroid uses. They were also vanished. Next slide. So avelumab received FDA approval in bladder tumor as maintenance, and in 2021, as we got the gold in Javelin, same time we also got Avelin as in India as a maintenance therapy, as first line maintenance switch therapy. Next slide, please. Then the third approach, which was continuous maintenance therapy along with chemotherapy and immunotherapy drugs, were studied, but we have disappointment from various trials that immunotherapy giving upfront was no benefit. In the 3 trials, landmark trials, we can see Amvigar trial 130, Epigenetic was not found superior. Keynote, again, pembrolizumab was not found superior if we give as a starting therapy. And the Denovo trial, where we can see durvalumab also did not see any OS and benefit if we start as along with chemotherapy as a continuous maintenance therapy.
Sir, apologies, sir, we're running short of time.
Okay, only few slides. So is there any role of immuno-oncology drug upfront? Yes. Next slide. Yes, in the selected patients, we can use atezolizumab and pembrolizumab as initial monotherapy. Next slide, please. And come to the last slide, I think, second last slide. So yeah, this one, I just want to subsequent lines, second line, next slide. So we have a role of pembrolizumab and nivolumab as second line immunotherapy in bladder tumor. Durvalumab and Atijo has been withdrawn. Next slide, please. These are the new drugs, targeted therapy, erdafitinib and antibody drug conjugate like enfortumab vedotin and sacituzumab govitecan, which has been recently studied, and they have found promising results, and probably they have opened up the new aspect of giving therapy in immunotherapy in bladder tumors. So probably they are having a way forward to go for these three drugs. But they have promising data. We can skip and we can go to the last slide, and probably we can end up here. So these are the trials which shown the benefit of the drugs, antibody drug conjugates. We can just sum up here. Probably the next. We are short of time here. So just wanted to thank Akhil and Anuj for giving some help of making these slides, and clinical care options, and Mark for sharing some slides. Thank you.
Thank you so much, sir. We'll now move on to the debate, and I request our chairperson, Dr. Sadashivdu, to please introduce our two debaters.
Yes, thank you very much. I think Dr. Abhishek, that because of technical issues, we could not complete the whatever presentation. But again, this is one of the most important topics at present is HPV vaccination. Whether we can go for universal vaccination or not, I think there's a big debate is going on in the country. But the two eminent speakers, they are going for and against. But I think at the end of the discussion, I think both of us should give some conclusions. At least we can give the same thoughts to the government. I think I think we are trying to talk to some of the government agencies to provide this one, but they have their own apprehensions. I think then definitely with your debate, is the best debate of this icon is this one. I think for to change, to see a change in our future generations. I think both discussions will have some idea and we'll discuss in detail. The first speaker is for the universal vaccination of school-age children is standard of care. Dr. Manoj Mahajan, the Director of Oncology Services, Senior Consultant Medical Oncology, Hematology, Pacific Medical College Hospital, Rajasthan. What do you, Dr. Manoj?
Am I audible, sir?
Yes.
Yeah. Thank you. Thank you for the nice introduction, sir. And I'll be.
So just 1 minute, sir. Rahul, can you reshare the screen without the optimized screen sharing?
So I'll be speaking for the topic like universal vaccination. HPV vaccination for school-age children is a standard of care. So before setting the vaccination point, just the pretext would be like, what is the gravity of the cervical cancer in India? That we'll see in the next slides. Next slide. So as we know, every year there are nearly 11,57,000 new cancer patients detected in India. And next slide. And out of these, we can see cervix cancer is the third most common, forming nearly 8.4%. It's quite a huge. And if we accumulate all other infectious related diseases, it goes almost 15% of the cancer contribute towards the overall new cases. And with the effective treatment or effective aspects of various treatment parts, including treatment, vaccination, plus screening, these incidences and mortality related to these cancers can be definitely reduced. Next slide. So as we know, HPV-related cancers, which most common is cervical cancer, nearly 99% cancers are related to HPV and various strains. Then the anal cancers, vulvar vaginal cancers, penile cancer, nearly half. These are US-related data, but more or less we can say the percentage should not differ too much. And the oropharyngeal cancer. So considering HPV-related only cancers in India, that forms bulk of 12% of patients, where we need to think of and re-strategize the our overall treatment approaches, where we are dealing with like while treating in metastatic disease, we take 1.5 months of survival as a mind-blowing or path-breaking recoveries, where we miss the chances of screening and vaccinations also, which can prolong or which can save millions of lives that we'll see in a subsequent slide. Next slide. So this forming this context, we know cervical cancer always and always goes from CIN 1 to 3 to invasive cancer, and then as per the stage it progresses. So this dogma is usually followed by cervical cancer, and that is why screening is also effective. So the whatever HPV vaccination, the hypothesis is, does HPV vaccination reduce the invasive cervical cancer incidence? So this is the probably one of the largest recent studies, Swedish trial, which included almost nearly 16 lakh of population, girl population 10 to 30 years of the age, from 2006 to 2017, where they have found the unvaccinated group as compared to unvaccinated group, between the ages of 16 to 80, there was nearly 30% reduction. Between 14 to 16, 60% reduction, and below 12, almost 90% reductions of CIN 1, 1, 2, 3, and invasive cancers. Though the flip side of, I'll say, we need further follow-up for defining the exact incidence, decrease in incidence of invasive cervical cancer. But this hypothesis has been proved with these studies, where the cervical CIN 1, 2, 3 pre-invasive cancers have been reduced by the HPV vaccination. Next slide. Again, one more study with the Nordic countries, where the quadrivalent papilloma HPV virus has 12 years follow-up study has reduced the all subtypes of CIN 1, 2, 3. Next slide. So what is the new approach we should adopt? So we have 3 tools in terms of approach to cervical cancer. One is the vaccination tool. The second tool is the screening tool, and third is the actual treatment. So WHO has currently proposed 90-70-90 approach, which means 90% of the girls should be fully vaccinated with the HPV below 15 years. 70% of the women in the screening age group should be undergo the high performance test, and 90% of the patients identified pre-invasive or invasive should be treated as per the guidelines. So this will keep the alone possibility of elimination of the cervical cancer. So where we think of prolonging or certain cure, this is the only cancer where we can think of the complete elimination with this approach. And the mathematical models have shown, if we talk about 100 years here forward, nearly approximate 62 million lives will be saved with this approach. And even if we don't want to go 100 years, I want to see the results in my lifetime. So probably there is medial cervical cancer incidence will be reduced by 42% by 2045. So it's still just 20 to 25 years away, and we'll see the definite change, as we have experienced in many of other countries who have adopted vaccination. Next slide. So this is the dogma I have spoken about. So we always talk about the tertiary prevention, but now we need to shift the gears in cervical cancer. We need to actively participate for secondary prevention, screening modulated, as well as primary prevention, which is the HPV vaccination in the appropriate age group. Next slide. I'm not able to see the slide.
So do you want us to go to the next slide?
No, I'm not able to see the slide.
Oh. Sir, can I suggest if you can log in from your phone?
Pardon?
Sir, will you be able to log in from another device, maybe your phone?
So I'll have to leave this one?
So probably not. You can just log in from your phone if possible. I'll just share your link immediately to your WhatsApp.
Okay, yeah. So this is how the overall approach would be. Am I audible?
Yes, sir, you're audible.
Yeah. So the overall approach is quite extensive. The many a times there is a question. Next slide, please. So many a times there is always a question about the efficacy and immunogenicity of the vaccines which is provided, like immunogenicity of the vaccine with the recent trials has shown younger the age, immunogenicity goes up to 90-95%. Efficacy of this vaccine, especially in the HPV naive patient, HPV naive population, has been like more than 90%, which is at par with the most of the vaccines of the current standards. Even for the pediatric infectious diseases cancer, the efficacy is not this much. So I think this 90% efficacy is quite a great standard. And with the controversy which arose way back in 2006-7 related to the vaccination in India, has been tried, like Dr. Shankar Narayanan and Dr. Partha Basu has like given the insights. This the 12 days had occurred in the during that controversial period has been declared unrelated to the vaccination by Indian government. And I think there is a way forward to move around it, and we need to take this forward. Next slide. The cost analysis or cost effectiveness is always question. This is a UK study which shown the cost effectiveness. The additional cost which incurred for the vaccination is nearly 20% of that what it is currently involved in the treatment of cervical cancer, anogenital cancer, or other related cancers, and including genital warts. So if we compare the actual cost bared by the taxpayers at current times related to the treatment versus vaccination is much lower. So it is not only effective in like reducing the mortality or surviving of so many patients, but also the cost which will be saved over a long term. Next slide. So the final comment: HPV related cancers can be effectively prevented, and the next approach should be gender neutral vaccination, including boys. So herd immunity has definitely played a role in many of the studies, and I think both of them should be vaccinated. Thank you.
Thank you so much, sir. Over to our chairperson. Sir, apologies, we're not able to hear you clearly. So because of want of time, I will just introduce our second debater, Dr.
So may I
Prakash.
request Dr. Prakash Chitalkar, sir? He is director at Sir Aurobindo Cancer Institute, very passionate about cancer prevention and cancers in the TY, teen and young adults. So with this small introduction, may I request Professor Colonel Chitalkar to deliver his talk, please.
Surely. Thank you, Dr. Lalit, for the kind introduction. And may I have the permission to share my slides?
Yes, sir. Please go ahead, sir.
I hope it happens quickly. Otherwise, Kashish will have to play it from their side.
Sure, sir. We'll just play your slides.
Yeah, I think start sharing that. Yours.
Sir, yeah. Sir, I think you sharing the slides, sir. You just clicked on it.
Where has it come?
Sir, just click on the presentation. So
Okay.
with your permission, we'll share the slides. So can I request you to share the slides?
Yeah. So thank you, Dr. Sadashiv and Dr. Lalit for the kind introduction, and thank you, ICON, for giving me the opportunity to participate in this debate. Well, universal HPV vaccination of school-age children is a standard of care. That's the proposition for this evening. And my esteemed opponent, Dr. Manoj Mahajan, has done a great job by presenting to you the data from the World Health Organization, from the publications in Lancet, and the worldview of the World Health Organization, how quickly reduce the incidence, not quickly actually, over several decades. But my contention will be a little different. I must first start with a disclaimer. May I have the next slide, please? Well, my disclaimer is, please go back. My disclaimer is that, well, after witnessing 1.75 billion doses of the COVID vaccine given in the Indian population in the last 12 months, I'm not about to join the anti-vaxxers. Definitely not. The scientific anti-vaxxers. But our healthcare system has the depth of experience in vaccination over several decades for communicable diseases. And I also don't believe that we'll not succeed in achieving similar success in the non-communicable diseases like cervical cancer or other cancers caused by HPV. However, the proposition says that this is a standard of care. So may I have the next slide, please? And the standard of care, ladies and gentlemen, is actually a legal term and not a medical term. To apply the term standard of care to practice of HPV vaccination in absence of known care pathways for a majority of patients who will be young adults, teenagers and young adults with cancer, both cervical, penile, or even head and neck, it actually amounts to jumping the gun. May I have the next slide? It's a national problem, and as Dr. Manoj brought up, we are the huge number of women in India and many men are actually vulnerable to it. The prevalence in the United States is about 24% of its population. The prospect of morbidity and mortality among AYAs because of cervical and head and neck cancer is actually very daunting. 90% of HPV infection, however, actually clears over time. So if exposed to HPV already, the benefit of the vaccine is then questionable. The ubiquity of screen access is actually the real need. And vaccine, of course, is recommended. Nobody denies that. May I have the next slide? Now, there are several disadvantages. Firstly, the current regime recommended is a multi-dose regime. So our Indians set up the population which is on the verge of multiple survival issues, including family issues, cost, jobs, education, mobility, migration, etc., etc. The multi-dose regime doesn't seem to be the most effective way of doing it. Cost is certainly there. That is the reason why the national vaccination program has not yet started making it part of it, because it will involve taxpayers' money. Then vaccination does not preclude the need to screen. That's one most important thing, is to understand that even if a young girl or young boy is vaccinated at the age of 18 or 19, he or she needs to get screening, especially the girl needs to have cervical cancer screening continuously. And that's a very difficult concept to, that needs to be first established in the community. Most individuals reach the late teens by the first dose, and ensuring screening after vaccine in AYAs, adolescent and young adults, is very daunting. They have a risk-taking behavior ingrained in their cerebral cortex, and it's so common among the AYAs, and therefore a national vaccination program does not include HPV is such a difficult thing to implement. The next slide, please. Is there an adjunct to vaccination? Well, an excellent, cost-effective, scalable method of cervical cancer screening is now available, and the seminal paper for that was published by Surendra Shastri from Tata Memorial, and it is imperative that a mass screening should be adopted as a primary initiative in the National Cancer Plan, along with the vaccination, of course. By the next slide. There is a problematic narrative that this is not a viral vaccine, it's actually a sex vaccine. A lot of parents of AYAs, a lot of the policymakers in the West, where the vaccines are now ubiquitous, they actually say that this causes permissive behavior. It reduces the fear of infection. It promotes unsafe sex. And women's health clinics and AYA cancer community actually needs to address these issues and emphasize the benefits of the vaccine and the screening together. Next slide. So I oppose the proposition. Universal vaccination for HPV infection for school-going children is not feasible, far from the standard of care. And I may like to rebut one issue. 97% clearance by 2000. I mean, it was 2220, I guess. 100 years away. It's certainly not a sustainable goal to set oneself on. Such a program is not likely to achieve eradication of HPV for this reason. Access to universal screening must be made available first, and vaccination will at best be the phase 2 of our HPV campaign. The first should be widespread access to screening, and the two will then go in tandem. So I will rest my case at this time, and if the organizers permit, we can have a short tete-a-tete in the form of a rebuttal. Thank you very much.
Sir, there are like new propositions from the whatever I think the mishap happened that has been turned in a good way. Like few patients were vaccinated just once, few girls were vaccinated once, and few had received only 2 dosages, and then that the last trial was stopped. That was evaluated or analyzed by Dr. Shankar and Dr. Partha. And they came up with the idea, even in resource restraint setting, 1 dose may be effective. So probably like what you have mentioned, that we agree. I agree, but I think we should work hand in hand together rather in crossing each other. So 1 dose vaccination, and as like even newer studies and even Indian Bharat Serum is coming up with the new cervical cancer vaccine. Probably that will make the cost effectiveness in Indian scenario, and that may lead to like including in the national immunization program.
There are studies about the single dose vaccine. Definitely it's effective. No question about it. They've found a clearance over 18 months and so on. Nonavalent vaccine to address the issue of only 70% coverage by the quadrivalent vaccine. All those, I'm not touching them because they are very common issues. More importantly is to set up a care pathway for the young people who are the most vulnerable to this disease. And in that matrix of the care pathway, if you introduce this screening and vaccination both, then I'm sure Dr. Manoj's dream, I don't want to call it a pipe dream, but I'll call it a dream of actually eradicating it up to the extent of 97% in the next 80 years or so will certainly happen.
There is some disturbance.
Sir, your voice is very muffled, sir. Can I request you to remove the earphones and talk? So you'll have to disconnect the earphones as well.
Sada, we can't hear you. Sorry, we can't hear you.
Sir, apologies, we are not able.
So meanwhile, may I request Professor Hemant Malhotra, sir, to introduce our expert, Dr. Ravi Malhotra, sir, please.
So thank you, Lalit. Dr. Ravi is a very old friend of almost 30 years, and we've done a lot of work for the government of India in the ICMR. He, of course, did a lot more work than I did. I was just a member of a small committee, and I got to witness Dr. Ravi and how he worked. Then he became director of one of the ICMR institutions. And I have no hesitation in saying that he's one of the foremost experts of the country in preventive oncology. You can see his introduction in front of you. He is adjunct professor of epidemiology at the Rollins Institute of Public Health, Emory University, Atlanta. And he is founder of the CHIP Foundation, Noida. And he is also the ex-director of the ICPO in Noida. So long experience of preventive oncology, especially oral oncology, in fact, all preventive oncology. So over to you, Dr. Ravi. This is a very hot burning topic. Should cervical cancer vaccine be given to all the girls in India? Your comments, over to you.
Yeah, thank you so much, Hemant. It is always a pleasure to be with you and your team, and it's an honor to be part of the ICON with Dr. Sharma and the rest. The 2 speakers, of course, Dr. Chitalkar also happens to be a senior of mine from my alma mater from AFMC, and of course, Dr. Manoj. They had to speak what they had to speak because of being on the opposite side of the debate. I'm very sure there is no debate as far as the need is concerned. The concern really here is that is it the right time for India to bring it into the universal health immunization program? That really is the crux of the matter. Without going into all the 90, 70, 90 groups and what are the advantages, will it be 50 years or 100 years? That is in the realm of scientific research. It is very well published. If there was a recent Lancet article about maybe not even a year ago in which they talked about where is India as far as HPV vaccination is concerned. I was part of it, and I think Shankar, again another old friend and colleague, was heading it, which was followed by an international group in which they compared various countries as how many years it will take. So as far as India is concerned, the story was that if we actually get on to appropriately screening individuals and universal immunization, it will be 60 years before we get rid of it. Now, both are ifs and they are buts. The vaccine, I mean, I was also part of, was fortunate, and I think our friend Hemant and many others were part of that group in which we formed the guidelines for India as far as cervical, oral, and breast, the three major cancers are forming nearly 40%, out of which oral and cervical are, of course, preventable. But the only cancer we have a vaccine is cervical cancer. So those guidelines were released, the framework was released, and we started off with VIA. And this is very shortly after Surendra's study came out from Bombay. However, the reality is that training people in VIA is not easy. Making sure everybody is followed up is not easy. And because of the last 2 years pandemic, we are really far behind where we should be. If I were to be asked that what is the best buy and the lowest hanging fruit, if you can afford it, that remains HPV vaccine. And there is ample amount of scientific deliberation to support that. As Manoj also mentioned, the Serum Institute was supposed to be releasing the HPV vaccine low cost. I mean, that would bring a change. For example, what has happened in hepatitis B, if you remember. But unfortunately, they all got caught with the COVID vaccine. I can well understand that. So that has taken a back seat. We are hoping to see the result within this year. The moment that vaccine is released and we can get over, and now that people are primed to getting vaccinated because of COVID, I personally feel that is going to be the way of the future. And I've talked to many of the NTAGI, that is the National Technical Advisory Group on vaccine, and they said, well, as soon as we get the Indian vaccine becomes affordable, it will probably become part of it. The second question was 3 dose versus 2 dose versus 1 dose. I think very recently UK moved to the 2 dose for younger kids, and now it is being very well established by studies from India, the cohort that Manoj talked about, in which we have a reasonably good response with single dose. That is probably the way in the future, although till it happens, obviously, that is not the last word. Lastly, I know we are short of time. So what Dr. Chitalkar mentioned, that screening has to be continued, yes, but the duration of screening, instead of having it yearly or 2 yearly, it will probably be extended to at least 5, maybe even 10 years. Again, another study came up that if you do screen only once in a lifetime, at the age of 40 or 45, you reduce the chances of cervical cancer by 50%. Now, all these figures, they may be sounding very esoteric, but they're real gross reality. So until and unless we have screening for cervical cancer as a routine, cytology is not really an option for India. Unfortunately, what has happened in the West, they had huge amounts of money. They had cytoscreeners, they had follow-up for PAPs. That is how cervical cancer went down. But that is the time when they didn't have HPV vaccine. If they had HPV vaccine 50 years ago, for example, I don't think they would have spent that kind of effort and money into cytology. Regarding VIA, regarding colposcopy, of course, all those things are important. I'm not saying they will go away, but they will be an adjunct. So the way I would tend to agree with both the speakers, I don't want to be partial to any of them, that what Manoj is saying, yes, in our lifetime, hopefully not, but in the next generation, yes, we'll probably find that it used to be a cancer called cervical cancer, hopefully. Regarding Chitalkar's point of view, that yes, it is going to be tough. Well, things which are, it would not have been tough, it would have been done already. But now with this vaccine coming up and Indian and the costing become appropriate with 90 to 95% efficacy if it is a non-valent, and 80% if it is quadrivalent, even that is going to change the entire scenario. I'm very optimistic, but I am also pragmatic that the road ahead is not easy. It will take time, but it will happen, inshallah. Thank you, Hemant. Thank you, Lalit.
Thank you, Ravi.
Yeah, thank you, sir, for your wonderful, I think, exposition and conclusion. Sir, Chitrakal, sir, I think you are not an opponent of this one topic. So, what is your personal opinion, sir? Because I think you are the founder of this adolescent and young adults group, I think, and everybody, you are a role model for all of us. Yes, sir.
In the TYA, teenage and young adult cancer space, I always say there is something which is a low-hanging fruit and something which is the ultimate frontier. And this is one of the combination. This is actually the two together, because if actually the young people's life free of cancer, then that's a huge, huge positive for the rest of the cancer space. That's the way I look at it. So
thank you very much.
And I think leaders like Ravi they really can put it together. And so it's fantastic meeting you virtually though. And thank you very much, everybody.
But one day we should get together, sir, for a meal.
Absolutely.
If not more.
So I invite you to Jaipur for this.
Thank you. Thank you so much.
Thank you. Thank you so much, sir. And now I request.
So thank you once again, Ashik. I think we are just sir, if you can just request our expert to give the expert comment for the entire session. Yes, I think again I'll invite Dr. Mukesh, assistant professor and a department of something like BMT SMS Hospital Jaipur. So Dr. Mukesh, I think overall comments, and I think we are running short of time. So
good evening, sir. Great sessions by great speakers, and today we discussed lastly on genital urinary cancers. Started with kidney cancer to end with on vaccinations. So initially we started with kidney cancer. We know that currently it's a role of IO with and IO with TKI, and this how changes the treatment paradigm of the kidney cancer, and then started the molecular biology of the bladder cancer, how it's evolving like a lung cancer, and that then we discussed the role of immunotherapy in bladder cancers and role of maintenance avelumab in the metastatic bladder cancer, and then lastly the vaccination is a standard of care or not currently. So that is greatly discussed with speakers. So I am concluding that is great lectures, and this is good topic presentations. Thank you, sir.
Thank you.
Thank you once again for giving us this opportunity to chair the session. And Icon, I am handing over this podium to this organizers. Thank you once again. I think well done. Thank you.
Thank you so much, sir. We'll now move on to the valedictory function. And I request Dr. Parikh to please announce the results of the competition.
Thank you very much. We come to the end of the wonderful conference organized by Dr. Hemant Malhotra and Dr. Lalit Mohan Sharma with the team. It is my privilege on behalf of all the judges to announce the winners of the various competitions. Let me begin with the radiation oncology competition. The third place was won by Dr. Nurul Ayan Fatima. Heartiest congratulations. The second place goes to Dr. Amruta Mohan. Once more, heartiest congratulations. And our first place winner is none other than Dr. Apurva Vijayan. Great congratulations and a big hand to you. So this is as far as the radiation oncology competition is concerned. As far as the oral paper presentation is concerned, the third place is by Dr. Chinnu Jomi. The first place is by Dr. Sri Gopal Mohanty. And the second place, as you must have guessed, is by Dr. Abhilash Menon. So heartiest congratulations to all three of them as well. For the oral papers, we were compelled to give a commendation certificate. Of course, there is no cash, but at least there is an appreciation of the hard work that they have done to two additional participants. One is Dr. Aparajita and the other is Dr. Sindhu Kilaru. So heartiest congratulations to them also. As far as the molecular grant competition is concerned, both Dr. Padmaj Kulkarni and I were quite concerned and disappointed with the casual attitude of many of the applicants. And there were several deficiencies, the most important one being not being familiar with the research methodology that they were proposing to do, or not having done a thorough review of literature. Just to give you an example, one of the proposal was to do a study in 60 patients because there was no evidence on whether this test is useful or not. And when you look at the literature in 2018, there was a publication in 1650 patients with a highly significant p-value regarding the value of the drug. So we request all molecular grant competition applicants to really make sure that you pay attention to your proposal. It seems that the judges are paying 10 times more attention to your proposal than you actually are. In other words, this time there is no winner for the molecular oncology grant proposals. Finally, I come to the best PG competition. And as you noted, the three finalists were all from south of India, Chennai, Hyderabad, and Bangalore. So heartiest congratulations to your dedication and hard work. The third place goes to Jyotis P. Jose, Niranjan V. and Tintu MV from Madras Medical College. So now you have to decide who's the first between Kidwai and NIMS Hyderabad. And the first place goes to Kidwai Bangalore, Sabina Chaudhary, Sindhu Shah K. and Anup Hegde. The second place winners NIMS Hyderabad included Macha Kiran Kumar, Kishore Chandra, and Malupattu Sumant Kumar. So heartiest congratulations to all three of you, all three of your teams. You will get your certificates and the shields, etc. in due course of time. All the detailed communications will be done by Kavina Creations team. And over to you.
Thank you so much, sir. And I now request our program director, Dr. Hemant Malhotra, to please give the closing remark. Over to you, sir.
Thank you very much, Kashish. It's my pleasure and privilege to conclude this 46th ICON organized by the Mahatma Gandhi Medical College Hospital. First of all, I'd like to thank Dr. Lalit Mohan Sharma, my very good friend, and the organizing secretary of this college and a co-faculty with me at the Mahatma Gandhi Medical College Hospital for his, hard work and his commitment. He's a tried and tested commodity. He's been at my shoulder for the last so many conferences which I have organized. I'm really happy to, thank him and acknowledge his help and support and sincerity. So thank you very much, Lalit. You really put in a lot of effort. All of us really truly appreciate it. Also would like to thank Dr. Purvish Parikh, who was instrumental in designing the fantastic scientific program and the talks, the panel discussions, the debates with very acute insight and with very thorough knowledge of the current topics and the areas of interest for all of you, both for practicing oncologists across the board, surgeons, radiation oncologists, medical oncologists, and also for our students. Also would very, warmly like to thank Kashish and his team. Kashish, can you put the video on? I do want everybody to see your face. So this is not, thanking you because you are Dr. Purvish's son. This is really truly thanking you for the untiring effort you've done, and you did not even leave the conference virtual venue for even 1 minute. So we really truly appreciate that, and we really truly realize how much of input of time and effort you have put into this. And also considering the fact that you're recently married, my apologies to your wife and many thanks to you. And of course, I have to thank all the speakers, the chairpersons, the moderators, the panelists who were the true crux of this meeting. And we've had some incredible talks, some wonderful talks. We had two international faculty participating also, and I did mention that Dr. Varsha Gandhi, who is a very dear friend of ours, very dear friend of ICON, very dear friend of Indian oncology, who refused to record her session and chose to present live at 12 o'clock at night, 12 midnight from Houston. She made her presentation. So like it is the commitment of top people like this across the board in India, outside India, whether they are surgeons, whether they're radiation oncologists, whether they are medical oncologists, north of India, south of India, east of India, west of India, all of you contributed together to this really good scientific program. And I think we'll try and make available all the presentations on the website so that you can access these presentations as and when your convenience. My scientific committee and the organizing committee and the Mahatma Gandhi Medical College Hospital faculty conveys the heartiest congratulations to all the winners of all the various prizes. And we hope that you'll do even better. And when we see some of these competitions, when we see some of you perform in these national level competition, you know, it for those of us who are 60 plus, it makes us feel good that the future of oncology in our country is in safe hands. Then also I'd like to thank our various industry partners without whom it would not have been possible to, you know, do this conference. So my sincere thanks on behalf of my personal behalf and behalf of my organizing team to the industry partners for helping us organize this meeting. So in case you find something good in this meeting, it is entirely because of Dr. Lalit Mohan Sharma and the other organizers, Dr. Purvish, Parikh, Kavina Creations, Dr. Mr. Kashish and his team. And if you find some lacunes in this conference, then it's probably because of my oversight. So we seek forgiveness from you for that. We would have very much liked to do a physical conference, have you over in Jaipur, interact with each one of you on a one-to-one basis. In addition to science, also, you know, meet you socially, let down your hair. But with the second wave and the third wave and the Omicron business, we decided not to do a physical meeting this time. But I promise you that in the near future, we will invite you to Jaipur and we will make up for not meeting you and not taking care of you and not offering you the traditional Rajasthani hospitality this year. So again, if my apologies if I have forgotten to mention somebody else or to thank somebody. Lalit, did I forget something? Somebody?
Kashish has postponed his, in fact, honeymoon for this conference. So I think that needs highlights.
So again, I mean, I can't thank Kashish and his commitment enough. And now, Kashish, I hope and pray that you do two back-to-back honeymoons and do whatever everybody does on their honeymoon and do it well. So with that, again, on behalf of Dr. Lalit Sharma and myself, and behalf of my institution, we would like to close this 46th ICON meeting. All the participation certificates, all the certificates and prizes to the winners, you should get them in the next 7 or 10 days. And thank you very much for investing your weekend with us and ICON. I really truly hope that significant knowledge gain happened for all of you. We enjoyed organizing this conference for you. We enjoyed the scientific deliberations, and we sincerely hope that you too did. So Lalit, any final words from your side before we?
No, sir. Thank you so much. I think we have covered every aspect. Dr. Parikh says that you did not say anything about our wives, sir. Dr. Bharti, Dr.
Yeah. So I think if you would do a physical conference and your wife is sitting in the audience in front of you, then you don't forget them. But otherwise, of course, nothing can be done without the support of the better half. And of course, thanks to our better halves. I keep telling Lalit कि अपन लोगों ने पिछले जन्म में कुछ पुण्य किए होंगे, कुछ मोती मोती दान किए होंगे कि इतनी शानदार बीवियां मिली हैं अपने को. And I think a lot of like Colonel Chitalkar would join me in the statement, and Purvish would join me in that statement. So again, thank you very much, Lalit, for reminding me and saving me from lot of heat. Thank you very much. So with these final words, we'd like to say thank you and bye-bye to you. Enjoy the rest of the Sunday, have a drink or whatever. And thank you very much. Thank you.
Thank you. Good night.
Thank you, everyone. Thank you so much.
Thank you so much, sir. And with that, we come to an end to the 46th ICON conference. Thank you, everyone.
Thank you, Kashish and team. Thank you so much. Thank you, Parikh sir. Thank you, Hemant sir. And good night.